Hello, I think we can start now. So how we'll be going ahead with this, we'll start with obstetrics first and we'll basically do all PYQs. While we'll be doing each question, any related information we will discuss point to point. We are not going into basics now. You know everything. We'll be discussing important points. We'll be discussing controversial points because I have realized while on WhatsApp grouping that there are still certain points which you have not, guys have not updated. And that's okay. That's what we are here for, right? We'll update the new information, we'll discuss the related topics, and we'll discuss if a new question comes up, how we can approach that question. Should we leave that question and should we not leave that question? That will also be discussed. Okay? So please give me a thumbs up if my screen is visible and my voice is audible. If my voice is audible, please give me a thumbs up. Yeah. And you can always message. Okay? Feel free to message or put comments. You didn't get anything. This is your time. You have to make maximum out of it. So we have 5-6 hours. We'll be finishing OBGY like a last course revision. Just a second. Somebody has not got the link. Okay. Few students have not got the link. Let me just send them and then we'll start. Okay. We have to make maximum out of these 5-6 hours. So this is my responsibility and yours too. So make sure to ask questions. Okay? Okay? Let's start. Starting with antenatal care. Very basic question. 35-week pregnant woman has delivered twin last time. What is her para and gravida? This is something which all of you know. Can everyone please quickly answer in the comment section? And be quick. Just answer so that we can just go ahead. Okay. Correct. So what do we know from gravida para up till now? Let's just revise quickly. Gravida is how many times she has been pregnant and current pregnancy is included. No matter it was abortion, ectopic, full term, preterm, doesn't matter. Gravida may we calculate all the pregnancies including this one. So she's pregnant right now also. Last time also she was pregnant. She's gravida too. Para is, remember, para is how many times her pregnancy has crossed the viability. Once that viability is crossed, then it will come into para. Even if it was an IUD, I will count it in para. If it was a preterm delivery, I will count it in para. What will I not count in para? I will not count abortions. I will not count current pregnancy. Until current pregnancy is delivered, I will not count it in para. Okay? So para is something only when it has crossed the viability. Point number one. Point number two, twins. Twins may para is always one. Pregnancy was one, no. No doubt the babies were two, but it was one pregnancy. So para of twin is always counted one. We don't count abortions. We don't count current pregnancy in para. Right? So this is clear to everyone. Let's discuss certain basic things. I know all of you know how to calculate expected date of delivery. If an LMP is given, you will calculate EDD by using Neagle's rule. I know you know that. One thing which I want to add in here is, see, Neagle's formula is for somebody who has a 28-day cycle. Okay? Neagle's was the scientist name. When he made that formula, it was for a person with 28-day cycle. But a normal person does not have a 28-day cycle. God, there are people who have not. Okay. Yes, I've sent everyone. There are people whose cycle length is not 28 days. And that's when the Wood's rule came. Wood's rule, you should know. What is Wood's rule? That whenever the cycle length is given in the question and it is not 28 days, suppose the cycle length given is 32 days. So it is 4 days extra. So you add those 4 days in your calculated EDT. That's the Wood's rule. Similarly, if question has deliberately given you a woman of cycle length 24, calculate her EDD, the question has deliberately given you the cycle length and it is not 28. Suppose the cycle length is 24. You have to subtract 4 days. Okay, so if you get a question and the cycle length is mentioned, don't just ignore that cycle length. There is a purpose of adding that cycle length. If the cycle length is not added, they have just asked you to calculate EDD, consider it at 28 days, calculate using this simple formula. Okay, so remember the Wood's modification. Now, second thing is, these days, a lot of pregnancies are IVF pregnancies. So you should know also in case, so this question has not come, but it can, in case it is an IVF pregnancy, then how will you calculate EDD? So in case of an IVF pregnancy, you calculate EDD not from LMP, but from the date of embryo transfer. In case you have been given a date of embryo transfer, same, add 9 months, but subtract 7 days. So in IVF pregnancy, how to calculate EDD? Add 9 months, subtract 7 days. In a natural pregnancy, add 9 months and add 7 days. Okay? GPLA calculation, we know gravida means how many times she has been pregnant irrespective of the outcome, and we calculate current pregnancy also. Para means how many times the pregnancy has crossed the viability. It means I will not count abortions and I will not count current pregnancy. Okay? Yes, ET is embryo transfer. When was the embryo transferred into her uterus? So when it will be an IVF pregnancy, the date that will be given to you will be ET, embryo transfer date, not LMP. LMP is not significant in here. So there you will calculate EDD by adding 9 months and subtracting 7 days. Okay? Another thing that you have to know in general pregnancy is how to calculate the gestational age currently. So normally we calculate gestational age using her again LMP. But what is the exact method of calculating gestational age? This also all of you know. The exact method of knowing how old the baby is right now is crown rump length. So in first trimester, crown rump length is the best measure of knowing the gestational age of that baby. Suppose she comes in second trimester. She has not come to me in first trimester. Then which parameter will I use to calculate the gestational age? Then I will use her biparietal diameter. If she comes to me directly in third trimester, that happens in India. People directly come to you in third trimester. That time, which parameter will you use for gestational age? Femur length. Among these three, which is the exact measure for gestational age? This one. So every trimester may you have to use a different parameter. You will not keep using crown rump length even in third trimester. But the most sensitive is CRL. Right? It is extremely important to use ultrasound for gestational age calculation, especially if women has irregular cycle, women doesn't remember LMP, and women has been on OCPs. If she has been on OCPs, what she's getting is not her natural cycle. She's getting a withdrawal bleed. So in that case, it is always better to use CRL for gestational age calculation, not LMP. Okay? Okay? Going ahead with more questions. Before going ahead with more questions, I want to discuss certain few things in general pregnancies. In general pregnancy diagnosis, there are certain presumptive signs, probable signs, and confirmatory signs for diagnosing pregnancy. ठीक है, 3 तरह के signs होते हैं, presumptive, probable, positive. How to remember them? In case it comes, which of these is presumptive sign? Of presumptive means patient is presuming I am pregnant. Probable means she has come to you and you are doubting. Probably she is pregnant. And there are only 3 confirmatory signs through which I can confirm pregnancy. So presumptive sign is everything which patient is feeling. Every symptom that patient is having, that is presumptive. Nausea, vomiting, Patient is having nausea, vomiting, na? Amenorrhea. Okay? Then all the urine pregnancy test, the kit test is done by patient at home. That is also presumptive signs. So amenorrhea, nausea, vomiting, urine frequency, breast changes that she's feeling, UPT, they all are presumptive signs. Probable signs, how to remember probable signs? The signs which you can see, the signs which are visible to you. What signs are visible to you? You can do ballotment. Ballotment of the baby will be done by you. All the pelvic signs that we read, that we learn the name, that will be checked by you. So these are probable signs. Ballotment, all the named pelvic signs, Braxton Hicks contraction, and blood pregnancy test. Blood pregnancy test is also done by you. Patient will not do blood pregnancy test at home. So all these are probable signs. Remember, there are only 3 confirmatory signs of pregnancy. See, listen, feel. You can see the fetus in the ultrasound. You can feel the fetal parts. You can listen the fetal heart on Doppler. These are the only 3 confirmatory signs of pregnancy. See, feel, listen. I can see on ultrasound, I can feel the fetal parts, I can listen the heart on Doppler. These are the 3 confirmatory signs of pregnancy. Presumptive, felt by patient, probable, felt by the doctor, confirmatory are last 3. Okay. Quickly discuss the pelvic signs. You will tell me, what is this sign? It's a very, very common question. Please tell me, what is the sign? Please message, what is this sign? Perfect. It is Chadwick sign. Bluish discoloration. Remember, bluish discoloration of basically vulva. Along with that, cervix also gets blue, but Chadwick sign was basically bluish discoloration of vulva. So always remember, if question asks, Chadwick sign is bluish discoloration of vulva, bluish discoloration of cervix, of uterus, you always mark vulva. Okay? So bluish discoloration of vulva and vagina and also cervix is Chadwick sign, and that why it is happening? Because of increased vascularity. So pelvic signs are basically 6. There are 6 pelvic signs. Okay? Among these 6 pelvic signs, 3 are cervical and 3 are uterine. So first cervical is Chadwick sign. Second is a soft cervix is a good cervix. है ना? A soft cervix, that's how we used to remember. So the soft cervix is a good cervix. So Goodell sign, that is softening of cervix. It is the first pelvic sign of pregnancy that comes. It comes at 6 weeks. First sign. So cervix becomes really soft. Okay, Goodell sign. Third cervical sign is when I keep my finger in the fornix, matlab around the os, I can feel pulsation. So os se yaad rakhna, I can feel pulsation, it is Osiander sign. I'm keeping my finger in the fornix around the os, I can feel uterine artery pushing the blood into uterus. Osiander sign. These are 3 pelvic signs. So these are 3 cervical signs. 3 uterine signs are, please somebody tell me what is this picture? What is this one when my 2 hands are trying to approximate? What is this picture? Correct. Hagar. How will you remember? Like letter H. These are my 2 hands, like letter H. In the middle, my hands are able to approximate. My hands are not able to approximate in the upper part because of the baby. My hands are not able to approximate in the lower part because of the cervix. Like letter H, Hagar sign. 2 hands approximating in middle, not above, not below. Similar sign, but see different. Here my 2 hands are not approximating. My hands are trying to cup something. I'm trying to hold something in my palm. Palmer sign. When I'm trying to hold the uterus in my palm, I'm feeling the uterine contractions. So it is Palmer sign. My hands are not approximating. Here my hands are approximating. Third is lateral implantation of uterus will lead to lateral enlargement of uterus. Piskaki sign. So these are the 6 pelvic signs in pregnancy. The earliest one is Goodell sign. Ultrasound extremely useful in diagnosis of pregnancy, in gestational age calculation. Okay, let's see how the different signs of pregnancy come in ultrasound. The first thing I see on ultrasound, GSAC. GSAC is the first thing that I see on ultrasound. Okay? GSAC is seen as early as 5 weeks. After GSAC, what I see is, can you see a small ring? Yolk sac. Yolk sac is seen at 5.5 weeks. Yolk sac is a confirmatory sign of intrauterine pregnancy. If I am seeing a GSAC, it is not a sign of intrauterine pregnancy. It means there is something else that can cause GSAC-like formation. Yes, that is pseudo-GSAC. Since there is an entity named pseudo-GSAC which occur in ectopic, it is not a confirmatory sign of intrauterine pregnancy. Confirmatory sign of intrauterine pregnancy is only when I can see a yolk sac. So which of these is confirmatory sign of intrauterine pregnancy? Yolk sac. What is the first sign seen on ultrasound in pregnancy? GSAC. First sign is GSAC. Okay. But presence of yolk sac indicate pregnancy is intrauterine. But yolk sac doesn't indicate that pregnancy is viable. Pregnancy is healthy. It doesn't indicate that. And what is the indicator of viable pregnancy? Fetal heart. Okay. I can see the embryonic pole. Can you see here two blebs? I can see a fetal pole and an embryonic pole at 6 weeks. And at 6.5 weeks, I can hear a fetal heart. When I see a fetal heart, that is a confirmatory sign of a viable pregnancy. Confirmatory sign of intrauterine pregnancy is yolk sac. Okay? Okay? How will you differentiate between pseudo GSAC and true GSAC? Pseudo GSAC occur in ectopic. Very easy to differentiate. Can I see a round structure, round and uniform, round and regular margins? What is the shape of pseudo GSAC? Changing. It keeps on changing. Depending on how much pressure I'm giving using my probe, it will change. It is nothing but water collection. When there is an ectopic, water gets collected in the uterine cavity, a small drop of water. So there is no fixed shape. I put more pressure, the shape will change. So there is no fixed shape. Shape keeps on changing. Then remember, see, embryo always implant on the uterine wall. है ना? Uterine wall पे it implant. So it is never in the center. It is eccentric. Why? Embryo is not hanging in the cavity. It is in the wall now. So it is always eccentric. It is never centric. But the GSAC, the pseudo GSAC is water collection in the center. Right? Second. Yeah, I know it's not getting clear. Basically, it's not the handwriting. The pen is just not working clearly. Don't worry. Once I'll send you the PPT, I'll type everything. Okay? I'll just go through again through this PPT, and whatever is not clear, I'll first type that up. Okay? And then I'll send that PPT. I'll not send it this raw PPT to you. Okay? Don't worry. Thank you for telling me this, but I'll just take care of that. I'll try to write down everything. I'll make it like here, I'll make a table. Then I'll send. That'll be easy for you to revise. It is eccentric, it is central. Now, other than that, since it is covered by two layers of decidua, can you tell me what is this decidua? Capsularis. This decidua is parietalis. So there are two deciduas which are covering it. So there is double decidual sac sign. But here, double decidual sac sign is absent. Here I can see two blebs. I'm just checking again and again because people are not able to join. People are not able to connect. I just don't understand why. So class have started, people have not. ठीक है. So double decidual sac sign is there in true G sac. In C2 G sac it's not there, and there is a double bleb sign. There is a yolk sac and an embryonic pole, but here the double bleb sign is negative. ठीक है. Simple. Now question. So this was general information that you should know. ठीक है. How to calculate GPL age, gestational age, and everything. A woman of gravida 2 para 1 present at 28 weeks. Her uterus is 24 weeks. Absent liquor. What is the cause? What is the cause of absent liquor? What is the cause of absent liquor? Let me just check. Everyone has joined. Ready? Please answer meanwhile, everyone. Have you mentioned? What is absent liquor? Renal anomalies. Okay, whenever there is a renal problem, the fluid reduce. Whenever there is a GI problem, the fluid will increase. So what is the main contributor of amniotic fluid? See, at less than 20 weeks, the main contributor is fetal skin. It transudate through fetal skin. But after 20 weeks, what happened? The skin get keratinized. Now it is impermeable. So after 20 weeks, the main contributor of the amniotic fluid is fetal urine. So whenever there is a renal problem, it will always lead to oligohydramnios. Okay, except one, that is Bartter syndrome. In Bartter syndrome, what happens is the water conservation by the kidney is hampered. Okay, it's a genetic problem where the kidney can't conserve the water, and that is the only renal problem that leads to polyhydramnios. Other than that, all the renal problems like unilateral kidney or bladder outlet obstruction, posterior urethral valve, they all lead to oligohydramnios. The most common cause of oligohydramnios. What other causes can lead to oligohydramnios? Around the third trimester. So all these renal problems will cause oligohydramnios in mid-gestation. In late gestation, oligohydramnios basically happen because of two main reasons, PPROM and placental insufficiency. If the baby is not getting food, how the baby will produce urine? Baby can't. So these are the two common causes leading to oligohydramnios in late gestation. What are the causes of polyhydramnios? Whenever there is a GI problem, tracheoesophageal fistula, esophageal atresia, है ना? Cleft lip, cleft palate, baby is not able to swallow. As a result, there is polyhydramnios. Or diabetic mother. Diabetic mother matlab baby is also getting high sugar, resulting in polyhydramnios, polyuria. ठीक है, तो diabetic mother. What else can lead to polyhydramnios? All the neural tube defects. When there are all the neural tube defects, the fluid keeps on leaking out, resulting in polyhydramnios. Okay, so these are the causes. Now let's go to the another question. A patient 32 weeks pregnant present with over distended abdomen but not tense. When I mentioned not tense, what I have excluded? I have excluded this. It is over distended. Obviously, it is not IUGR. Fetal parts are not easily felt, not audible. It is polyhydramnios. Why it is not fetal and maternal ascites? Fetal and maternal ascites means some systemic problem, and that too severe one. Like a severe anemia will lead to this kind of condition. Presentation will be similar. Over distended abdomen, unable to hear the fetal heart sound, but there will be other presentations. Severe anemia, severe hypertension. That will cause the fetal and maternal ascites. There will be many other symptoms. If they are not there, then it is polyhydramnios. ठीक है? Hydramnios के बारे में I need to tell you 2-3 things. What is hydramnios? Oligo, I know you all might be knowing. AFI more than 25 centimeter. Single deepest pocket, 8 centimeter. There is one more way, one more layman term of explaining hydramnios means amniotic fluid more than 2 liter. It is not a definition, but yes, radiologists still use it as polyhydramnios. When the fluid is more than 2 liters, we call it polyhydramnios or hydramnios. Okay? How the patient will present as it has been seen in the question. Okay? What is the management? Management is suck the fluid out. See, majority of the polyhydramnios, majority of them are idiopathic. So idiopathic is the most common cause. In idiopathic, you don't have to do anything. Only when mother is distressed, you take the fluid out. In ultrasound guided amniocentesis is done. Previously, in previous years, indomethacin was used. Indomethacin is a prostaglandin inhibitor. So indomethacin was used to reduce the fluid. But eventually it was seen that indomethacin leads to a complication. Who can tell me what complication can happen with indomethacin? It's a prostaglandin inhibitor. Please write down the correct complication that can happen if I'm giving indomethacin to a pregnant woman. I knew ये लिखोगे तुम लोग. Yes. Yes. Premature closure, not see, premature closure and patent, they are bilkul opposite. Premature closure, closing before time. Patent matlab not closing. What is happening with indomethacin? Premature closure. It is not patent ductus arteriosus. It is premature closure. Remember, jaldi jaldi mein dekha option wo PDA mark kar diya. No. No, we are not going to do that. Okay? There is no scope for silly mistakes. It looks, sounds same, it is not. It is not PDA. What is closure of PDA? What is closure? Premature closure of ductus arteriosus. Okay? This is what it happens. See, ductus arteriosus is patent in fetal life. It has to be patent so that fetal circulation is maintained. Who is maintaining that patency? Prostaglandins. Prostaglandins ka ye job hai, it is prostaglandins job to keep that patent. If you will give inhibitors of prostaglandins, it will close. Okay? इसीलिए prostaglandins are also not given for long term. If you will keep on giving prostaglandins, it will lead to if you keep on giving prostaglandins in pregnancy, that will lead to patent ductus arteriosus. It will not let ductus arteriosus close. Which question, Betu? This one? See, IUGR mein uterus will not, it will not be over distended. Why will it be over distended? It will be reduced in fundal height. The baby uterus will be filled with baby. It will seem that uterus is filled with baby. And the fetal heart and the fetal parts are very clearly visible. See, there is no liquor. The uterus is just holding the baby. You can feel the fetal parts very easily. Okay, na? Good. Good, you asked. So keep asking questions, but I told you it is my responsibility, no doubt, that I have to make maximum of these 5-6 hours what we have got. I know it's a very important exam you're gonna give, but it is your responsibility too. So keep your eyes and mind wide open. Keep asking questions and keep answering questions. Yes, I'll do RH negative also. Don't worry. I know RH negative mein there is controversy. You have not updated. Guidelines have got updated already 2 years back. है ना? But you guys have not updated now. Not your mistake. Maybe the edition of book which you are reading right now is an older edition. And that's what I'm here for. I will update. Don't worry. You got this? So this was the question in 2020. Oligohydramnios in RH negative. RH negative pregnancy leads to fetal anemia. So what exactly happens in RH negative pregnancy is fetal anemia leading to fetal ascites. Fetal ascites is something that happens in RH negative pregnancy. IUGR can happen because of placental insufficiency, because of anemia, baby might not grow, might need to lead to IUGR, not oligohydramnios. Okay. Okay. Premature closure of ductus arteriosus that we have done. Okay. So this was all about liquor that we should know. Okay. A patient 34-week pregnant feel dizzy on lying, better on turning left, a very favorite question of NEETPG examiners. What is it? What is this sign? Come on. What? Supine hypotension. It is not postural, it is supine hypotension caused by IVC compression. Now, this is a very common question, but what we have to remember from here is, see, when does it happen? At what gestation the supine hypotension syndrome appear? At what gestation? It is not an early sign of pregnancy. Uterus should be large enough to compress this big vessel. Okay? It will not come in first and second trimester. It will come at 28 weeks. So that's what you have to remember. The uterus should be huge enough to compress that large vessel. Okay? So we read some early signs of pregnancy, pelvic signs. You have to remember certain late signs of pregnancy. Okay? Late signs of pregnancy means once the uterus is enlarged, there are certain signs that comes late, like appearance of stria gravidarum. Appearance of stria gravidarum is a late sign that appears at around 28 weeks. Okay? Don't worry, I will type everything. I can myself see that pen is not working. I'll write down. Okay? When I'll pass these to you. Stria gravidarum is a late sign. What else is the late sign of pregnancy? Yes, cloasma also appear at around 28 weeks. Then, remember a 20-week milestone. A 20-week milestone is very important. Lot of signs appear at 20 weeks. Fetal heart is first time auscultable at 28 weeks. The quickening that mother feels, that is also something which comes at 18 to 20 weeks. Fetal ballotment is again something that comes at 20 weeks. You can feel the fetal parts again at 20 weeks. So 20 weeks पे lot of things appear. ठीक है? Quickening 18 to 20 पे you can feel fetal parts, you can listen fetal sounds, and ballotment. They all come at 20 weeks. Okay, remember, this is external ballotment. Internal ballotment, when I'm pushing through vagina, feeling through abdomen, that is internal ballotment. I don't know who does that, but that is at 16 to 28 weeks. But external ballotment is at 20 weeks. So 20 weeks is like a milestone that this baby has achieved. Lot of things happen at 28 weeks. Some signs are very late signs. That comes near term. Near term, certain signs that come is lightening. Lightening is a sign that comes at 36 weeks. When the uterus descends down, mother's respiratory problems start becoming better. So lightening is a sign that comes very late. Okay? So these are the late signs of pregnancy. Do not confuse them with the early signs. Okay? Now let's quickly revise the physiological changes that happen in pregnancy. I can't as such see in these 5 years the questions asked on that, but we have to know what changes happen. Physiological changes. What happened to blood volume? Blood volume rise. Plasma volume rise significantly and RBC volume rise a little. So plasma volume rise by 40%, whereas RBC rise by 25%, resulting in dilutional anemia. Okay? Maximum blood volume rise is at around 26 to 28 weeks. There is significant rise in blood volume. Once you know that blood volume has rise, you know how much blood women collect? 6 liter. 6 liter of extra blood is accumulated. So much. So once you know that so much blood is collected by this female body, you will remember other things that happen. Cardiac output. Blood volume has risen. The vessels have got dilated. Blood pressure fall hota hai na pregnancy mein. In pregnancy, BP falls. The fall basically starts in second trimester. Okay? So blood pressure has fallen, blood volume has risen. What will happen to cardiac output? It will rise. By around 45%, there will be rise in cardiac output. Maximum rise happen again at 26 to 28 weeks during antenatal period. Another 20% is added when the woman is in labor. When the woman is in labor, with every push, the cardiac output is rising. But remember, maximum cardiac output, maximum in whole pregnancy and labor is immediate postpartum. Immediate, once the baby is out, all the IVC compression is gone. So much of blood from lower limb flows into the heart. So immediate postpartum cardiac output is immense. So the time when maximum heart failure happen is immediate postpartum in a heart disease patient. This is the most dangerous time. ठीक है? Point number 2, ठीक है, immediate postpartum, the cardiac output is maximum. When will it return to pregnant value? Whatever pregnant value was, when will it return to the pregnant value? 2 hours. After 2 hours, when the woman has come down, she has relaxed, now it will reach the pregnant value. When will it return to pre-pregnant value? Like a normal person, when the cardiac output will return to pre-pregnant value? You guys tell me, when will it return to pre-pregnant value? Like normal cardiac output, when will it be? No? But it will not happen in hours. It's a involution. It should happen in weeks. Within hours, thodi na wo pre-pregnant value pe it can't come into pre-pregnant value in hours. Okay? 2 weeks. 2 weeks. So in 2 hours, it turns to the pregnant value. In 2 weeks, it turns to pre-pregnant value. Okay? आगे समझ? A little bit changes in the heart sounds. You have to know what changes in heart sounds happen in pregnancy. S1 and S2, which are normally not split, they become widely split. You can separately hear the sound of mitral valve and tricuspid valve. They get split and they get louder. Split bhi ho gaye and louder bhi ho gaye. They are split and louder. Correct. S3 appears. S3 is a ventricular gallop. When the blood comes in the ventricle, a ventricular gallop sound is heard. A new sound appears, S3. S1, S2 become widely split, loud, and S3 appears. So this is normal. What is abnormal? How will you know that, no, this is not a pregnancy change? Another one thing which I forgot which will appear is ejection systolic murmur. Heart is ejecting so much of extra blood, so forcefully. So ejection systolic murmur appears, which is normal. So ejection systolic murmur is completely normal. What is not normal? Diastolic murmur is not normal, and presence of S4, atrial gallop, that is not normal. Good. So neither S4 is normal, neither diastolic murmur is normal. Continuous murmur, generally when it is heard, it is generally mammary shuffle. The increased blood flow to the mammary gland lead to mammary shuffle. That is that continuous slow murmur that is heard. Okay? That is the change in heart. Done? Let me remove. What happens to the oncotic pressure? Since so much of the blood is there in this maternal body, so much of blood, what will happen? Everything is falling. So oncotic pressure will fall. Total protein has increased. Remember, the baby is whole protein. So total maternal protein has increased, but the concentration of everything falls. Hemoglobin concentration, platelet concentration, urea, creatinine, everything concentration falls. So same oncotic pressure, it falls. Okay? Because protein concentration falls. What will happen to GFR and renal plasma flow? Who will tell me? What will happen to GFR and renal plasma flow? Socho. Women has collected so much of blood. So what will happen to the blood flow to the kidney? That will increase. Increase in renal plasma flow, increase in GFR. But since there is so much blood, serum creatinine and serum urea, the concentration is reduced. And somehow tubular secretion is also hampered. In pregnancy, women start secreting glucose. Women start secreting protein, which is normal. So glucose urea and protein urea start happening, but it never crosses the limit. Limit is 300 milligram in 24 hours. It will not cross the limit. Yes, BUN also decrease. Okay? So glucose urea happen, protein urea happen, and GFR and renal plasma flow increase. Okay? At what gestation uterine height is at umbilicus? Please give me the right answer. At what gestation uterus reaches the umbilicus? You have to give me the right answer for this, please. Thank God. I was expecting you will write 20 weeks. It is 24 weeks. At umbilicus, it is at 24 weeks. At Ziffy sternum, it is 36 weeks. Okay. One point some of you have mentioned that yes, hydronephrosis also happen in kidney. Hydroureteronephrosis is also normal in kidney. Glucose metabolism. What changes happen in glucose metabolism? Postprandial, what will happen? Please write down what will happen once she has eaten. What will happen to sugar? Once she is fasting, matlab she has gotten from her sleep, what will happen? But albumin globulin concentration fall. Total content increase, but the pressure, oncotic pressure and the concentration falls. Okay. What will happen to postprandial sugar? What will happen to fasting sugar? What will happen to the insulin levels? What will happen? Okay. Right. More answers, please. Okay. See, one thing we know that insulin resistance happens in pregnancy. We know this much. Insulin resistance, why it happens in pregnancy? Why naturally insulin resistance happens? What is the function of insulin? I always call it insulin. In se yaad rakhna. It puts glucose everywhere inside. It converts glucose into glycogen. It converts glucose into fat. And it puts the glucose inside cell for utilization. That's what the function of insulin is. Just storing the glucose. We don't want stored glucose. In a pregnant woman, don't want to store glucose. She want to give glucose to the baby. If she has a free glucose, then only that can be transferred to baby. That is why insulin resistance happens, so that we don't store glucose. We have a lot of free glucose and that can be given to baby. Now, what happened because of that insulin resistance? That when she has eaten the food, she has got insulin resistance. When she has eaten the food, she can't utilize this. She can't store it. She will have hyperglycemia because she is resistant to insulin. When she is sleeping, all this hyperglycemic glucose will be transferred to the baby. Also, her insulin levels have increased. Why? Because of resistance, her insulin levels has increased. So there is hyperinsulinemia in pregnancy. There is insulin resistance in pregnancy. Postprandial sugar will increase, but when she is sleeping, all the sugar is transferred to baby. And fasting, she will wake up with hypoglycemia. So postprandial hyperglycemia, fasting hypoglycemia, high insulin levels and insulin resistance. These 4 points remember in glucose metabolism. Got it? Okay? Okay? I will not repeat everything. I'll repeat only when you'll tell me to. Okay? Because we have a lot to cover. If you'll tell me, I'll repeat them. So that's what we have done with the basic changes in every system. Respiratory system we left. Sorry. Where should I write? I think I should write somewhere here. What happened in respiratory systems? But remember, certain things increase, certain things decrease. See what is happening in respiratory system? The uterus is pushing the diaphragm above. As a result, the residual volume, which was there in the lung, which I can't expire, the residual volume fall. Expiratory reserve volume fall. Okay? What about total lung capacity? See, no doubt the lungs have, the diaphragm has shifted up, but the ribcage has expanded like this. So as such, total lung capacity remains normal. It doesn't change. Vital capacity remains normal. Respiratory rate remains normal. It doesn't change. What increase? Tidal volume. The volume of air you are taking in each breath, that is increasing. Do you see, have you ever seen a pregnant woman? Yes, that's what I'm telling. Inspiratory capacity, tidal volume, they increase. Have you seen pregnant women inspiring? They take deep breath. That is progesterone regulated. They always take deep breath. So the volume of air inspired in each breath, that increase. So the tidal volume increase, not the respiratory rate. Okay? So what is increasing is tidal volume. Yes, minute ventilation. What is minute ventilation? In 1 minute, how much air she is taking. Tidal volume is in one breath, how much is she taking. So minute ventilation is when you count that in 1 minute. So that minute ventilation is also increasing. She's taking more deep breaths, but she's not tachypnic. She's not, her respiratory rate is not increased. Yes, FRC decrease. So everything related to residual capacity, that decrease. Vital capacity normal, total lung capacity normal, respiratory rate normal, tidal volume and minute ventilation, that increase. ठीक है? चलो. I'm just checking that everyone has joined. I hope nobody is messaging me for not joining. Let me check once again. Sorry, I've crossed one out. Up tak everything is clear. Now we are going with the early pregnancy and related complications. We'll do abortion, ectopic, everything. Now see this one. Primary gravida, normal regular cycles, present with amenorrhea for 6 weeks, followed by bleeding and right-sided pain. What comes to your mind is ectopic. On examination, UPT is positive, BP normal, beta HCG is this much. What is your next step? Please answer fast, everyone, so that we can go. Okay. Okay, anybody else? Correct. Good. So PYQ may you all are perfect. You know everything related to PYQ. I don't think I need to go ahead with these. So you will repeat beta HCG. Okay? Why? Because it might be ectopic, it might be intrauterine, I don't know. Can somebody tell me what is the discriminatory zone? Discriminatory zone is that value of HCG beyond which it should be visible in uterus. If HCG is more than discriminatory zone, still not visible, it is ectopic. What is the value of discriminatory zone? You're telling me or you're asking me? Sagrika? Exactly, this is the value given by American Academy of. Okay, 3500. So just remember, discriminatory zone has been recently changed. That is 3500. 35 international unit is the zone after which pregnancy should be intrauterine. If I'm not seeing it intrauterine, now I'll not keep on following it. I will treat it like ectopic. Before discriminatory zone, I will keep on repeating. My answer will always be repeat beta HCG. Okay? If less than discriminatory zone. Other things I am not gonna do. Okay? Why will I repeat ultrasound? I know I will not see anything. So there is no use of repeating ultrasound. I'll do ultrasound only when my discriminatory zone is crossed. Okay? So that is how you manage pregnancy of unknown location. No, if whatever your beta HCG is and you can't see the pregnancy anywhere, you repeat beta HCG. Your answer should always be repeat. If there is a rise in 48 hours, there is rise of almost 60%. It indicates it is healthy intrauterine. It is not confirmatory. Remember, confirmatory sign is only GSAC with YOTSAC. It indicates it is healthy. If there is a fall and that fall is more than 50%, it indicating that it is abortion. I'll still keep on, my answer will be still keep on monitoring beta HCG unless it is 0. And if it is falling somewhere in between these two values, then I will keep on repeating my beta HCG till I reach the discriminatory zone. Once I have reached the discriminatory zone, it is not visible, it is ectopic. Okay. A woman at her 12 weeks present with profuse bleeding. Where is the ectopic? Profuse bleeding. Ectopics never bleed profusely. Even when they rupture, they don't bleed vaginally. They will bleed intraperitoneally. Be it ovarian ectopic, be it tubal ectopic. It will never come out vaginally, except one ectopic that will bleed vaginally. See, ovarian ectopic hoga to bhi to, if it will rupture, it will bleed in abdomen. Why there is vaginal bleeding? Yes, it is cervical ectopic. It is cervical. When it ruptures, it bleeds vaginally. There is nowhere else blood can go. So cervical ectopic is the one that bleeds profusely. Other all ectopics only have spotting. They never ever bleed profusely. Important thing, cervical ectopic is very commonly confused with a Incomplete abortion, abortion that is in process. So there is a sign called as sliding sign. Remember the sliding sign. Sliding sign is used to differentiate whether it is an ectopic or it is an abortion. When I press my probe, when I press my ultrasound probe, if it is an abortion, it will slide. Sliding sign positive. But if it is an ectopic, ectopic is in the wall. It is implanted in the wall. If I put my probe pressure, it will not move. It is fixed to the wall. So sliding sign negative is cervical ectopic. Sliding sign positive, it means it is sliding. It is an abortion that is happening. Okay? Clear? I hope every one of you know the management of ectopic. Ectopic की management हमको मालूम है. मालूम. So conservative में क्या क्या होना चाहिए? Sac should be small. HCG should be less. And no cardiac activity. है ना? ये सब होना चाहिए. Patient should be stable, obviously. When I'm using methotrexate, remember single dose methotrexate. Multi-dose नहीं use करते. Single dose IM. Sac should be again small. There should be no cardiac activity. But important is that beta HCG is somewhere between 1000 to 5000. If any of these is not following, I will do surgery. Okay? We know this much. Let's do this question now. A patient of infertility of 3 years has 6 weeks amenorrhea, present with spotting. Ultrasound mein there is an adnexal mass with fetal pole, but cardiac activity absent. Sac is this much, beta HCG is this much. So what will be the treatment? In which category is it lying? Single dose. Multi-dose methotrexate with leucovorin is given in choriocarcinoma. It is not the treatment for ectopic. Okay? So ectopic management we know. Now we have finished ectopic. Now we'll do the abortions. Abortion is the favorite topic for NEETPG people. Favorite. So abortions के बारे में we have to know every single detail. ठीक है? 36-year-old gravida 3 para 2 7 weeks want MTP. What drugs will you use? CAC is the Indian guideline. Comprehensive abortion care guideline is the guideline made by Indian government. Indian government keep everything very simple. So according to our guideline, there is only one method that can be used. We can use only one method. MIFI and meso. In our country, we don't use methotrexate, we don't use methergine, we don't use these. There is only one method that is allowed, that is this. Okay? Can anyone tell me the dosage of both of them? Yes, MIFI 200, meso. Meso? Not 400, 600, 800. Guidelines are very clear. There's no range. 800 meso. Simple. So MIFI 200, 800 meso. No gestation-wise mesoprost change. This is the dose written in CAC guideline. ठीक है? Right? ये milligram, ये microgram. ठीक है? Milligrams और micrograms ये भी याद रखना है. What is the unit? Okay? And now till what gestation the medical? No. So that's what I'm saying. See, what I'm doing personally in my clinic is not important. What CAC tells is important. CAC के according, day 1 पे you give MIFI. Day 3 पे you give meso 800 together. Vaginal, oral, sublingual. Anything. But एक साथ 800. That repeated dose and all, no. पहले करते थे, these were older guidelines when teachers used to teach what they do in their practice to be on safe side. You as a student has to remember what guidelines say. Okay, so guidelines say 800 single dose. It is very simple. Okay, no repeat, nothing. And up till what gestation am I allowed to do a medical abortion? Up till what gestation? First, what? No. Tell me the correct gestation. I want you to know everything about abortion. Up till what gestation I'm allowed to do medical abortion? Up till what gestational age? Medical abortion. Using only MTP नहीं कह रही, using medical method, medical termination of pregnancy using medical method. Sorry for not framing my question right. Up till what gestation am I allowed to use termination using medical method? That was the question. Now answer. As per CAC. Should be absolutely no confusion. 9 weeks. No 8 to 9, no 9 to 10. 9. When guidelines have clearly mentioned, जो government ने बनाई है उन्होंने, they have mentioned 9. Why? Who are we to put a range onto it? 8 to 9 पे कर देंगे यार. 9 to 10 पे we will do abortion. No, it is 9. If she has crossed 9 week and you are doing a medical method, it is not legal. In case some problem happen, the patient can sue you. My question was up till what gestation I can use medical methods for causing abortion. Okay, so remember it is 9 weeks. Everything in our Indian guideline, you have to be very, very sure about it. 9, 10, 8, 9, nothing. No. So this is my favorite page of abortion, which I have prepared. I love this page. So just see here. Medical abortion is allowed till 9 weeks. Okay. According to our guidelines, we keep it very simple so that anybody can understand. Any peripheral health worker, anybody, any medical officer sitting in periphery can give this method. So we give MIFI meso only. Still, you can be questioned on WHO method. WHO give 3 methods: MIFI meso alone, letrozole, and meso. These are the 3 methods given by WHO. Remember, methotrexate is not a method for inducing abortion. So if a question asks which of these medications not used for abortion, MIFI, meso, letrozole, methotrexate. Answer methotrexate. Methotrexate is not used for abortion according to any guideline. WHO does use letrozole for abortion. Okay? How to give, that we have discussed how we have to give. Okay? Day 1, day 3 and call her at day 15 for follow-up. Surgical कर सकते हैं. Can we do surgical abortion in first trimester? Yes. And the name specially given is vacuum aspiration. It is such a small product, you just aspirate, create a vacuum manually using this syringe, MVA syringe, or using electric pump, using Carman's cannula, just suck out. So vacuum aspiration is the term used for first trimester abortion. Okay? In case it's a second trimester. So in second trimester, my medical method I can't use. I can use surgical method, but what is the method? Dilation and evacuation. Now it is a big pregnancy. So dilate, evacuate. Using suction, using forceps, using suction, and forceps is this forceps, ovum forceps. So the term for second trimester abortion is dilation and evacuation. Term for first trimester is vacuum aspiration. Okay? Clear? Okay. I hope all of you know the gestational age for abortion. All of you know the gestational age for abortions. उसमें तो I have to explain nothing. Yeah, this is right. मुझे पता था you all know this answer. ठीक है? Gestational age पता है? Whenever a question asked contraception failure, please, up till what gestation a contraceptive failure woman can come to you for abortion? Up till what gestation she can come to you? 20 weeks. Wait, if you have conceived because of contraception failure, then come before 20 weeks. Why are you coming after that? है ना? Why are you knowing about it so late? So come within 20 weeks. Up till 20 to 24, there is a special category. When mother is has a physical problem, when mother has a mental problem, it is a disaster pregnancy, rape, minor, baby has anomaly, 20 to 24. Beyond 24, only and only one indication, only and only one. And that is fetal anomaly. Okay? That is one. Here I need permission of 1 RMP, permission of 2 RMP, permission of a medical board. One important thing you should remember, when a permission has been given to a medical board made by these people. Okay? when a permission has been asked from a medical board whether she can have abortion or not, the answer has to be given within 5 days. Okay? She can't, the board can't sit with that permission. They have to answer within, sorry. They have to answer within 3 days. Within 3 days, they either have to accept the request or reject the request. And once they have accepted, the government hospital has to undertake abortion within 5 days. So this is the limit which is set by the guideline. Answer within 3 days, and if answered yes, then please do the abortion within 5 days. You just can't delay this. Okay? That you should know. Another thing about consent I want to mention here is more than 18 whose consent is needed, only patient. We don't need consent of husband or parent or anything. Whether girl is married or unmarried. She is married, she is unmarried, it doesn't matter. More than 18, only her consent needed. Less than 18, whose consent is needed if she is less than 18 or she is mentally not well? Whose consent is needed? Who will tell me whose consent is needed if she is not medically well? Arre, very good. Very good. Guardian. This is something that I always stress. Guardian consent. It is never parent, doctor, partner, husband. No. Guardian. Anybody can be the guardian. Only guardian consent is needed. At less than 18 years, one thing you have to know is you have to undertake abortion after guardian consent, and according to POXO Act, Protection Against Child Sexual Abuse, you have to inform the hospital authority or the local police. So either the hospital authority or the local police has to be informed by the doctor in case abortion of an less than 18-year girls come up. Everything is written in the guideline. Okay? So you are obliged not for an FIR, but yes, for informing the local police. Okay? Okay? Now, these questions were there in the guideline itself. So I want you to answer them. They are not previous year questions, but in the CSE guideline, these questions were mentioned. These are easy questions, but I was doubting they can be asked anytime. You've given the answer? So in case there is a product of conception, if you have done the abortion and you can't see anything on the histopathology, the product of conception is not visible. What can be the cause? It was ectopic, patient was not pregnant, or there is some septate uterus. The pregnancy is in another horn. Another question was there in the guideline itself. There was this question. Which of the following are signs of completion of vacuum aspiration procedure? Which of these indicate that the procedure has completed? Gritty sensation, cervix gripping the cannula, red or pink foam coming and not tissue. What of these indicate? I will answer all the above. Okay. So all of these indicate that the procedure has completed very well. Okay. Chal. A patient of rape victim presents at 22 weeks. What will be your advice? A rape victim comes to you at 22 weeks. What will be your advice here? She is allowed. Okay. Permission of 2 RMPs is needed. She is allowed. A patient presents at 8 weeks. What method has to be used? We know, MIFI-MISO. Okay, I'm just showing how many questions have been asked. 24-year-old mother, ये NEET 2020 का question है. 7 weeks POG present to ANC with history of accidental exposure to radiation. What will be your advice in this regards? Here. Correct. You will continue with this pregnancy. You will ask her that please continue with the pregnancy. ठीक है? International Radiation Control Committee. According to this, they say that whenever there is 0.1 गारा है, आप कह सकते हो 100 milligray. Whenever radiation exposure is more than that, then that can cause a anomaly or abortion risk. So 0.1 to 0.2 gray, more than that is harmful for the baby. Lesser than that, you do not need to do any kind of intervention in pregnancy. Okay? So up till 100 milligray is allowed in pregnancy. Okay? How much exposure happen with a general chest X-ray? 1 milligram. Okay? So it is way above the threshold. So you don't have to do anything. No termination is advised. Okay? So remember this value also, up till what value the radiation exposure is allowed? 0.1 to 0.2 gray. When it is asked milli, then 100 to 200 milligray. Okay? A lady present with history of recurrent abortion at 8, 11 and 22. She also had preeclampsia in last pregnancy. Cardiac activity of all three were normal. What is the probable cause? What is the probable cause here? There are two differentials here. I'll just answer your question, beta. There are two questions here, two options here, which looks very probable, syphilis and apla. Torch does not cause recurrent pregnancy loss. Okay, recurrent loss हो रहा है उसको. GDM will not present like that. Okay, so GDM will not keep on presenting with abortion in each trimester. Okay, it can be syphilis, it can be apla, but when they have written preeclampsia, that is why my diagnosis is apla. Otherwise, it can have been safely syphilis. But because they have mentioned preeclampsia, that is why my diagnosis is apla. One of you has asked which scans are not allowed in pregnancy. CT scan, obviously X-ray, though X-ray does not cross the limit, but it is not allowed. DEXA scan. They are not allowed in pregnancy. Okay? MRI, Doppler, they are allowed in pregnancy. So that's, we have finished ectopic, we have finished abortions. If my speed is okay, we are not going fast, please let me know. If you want me to further increase the speed, then also let me know. Molar pregnancy. Question. 32-year-old female present to hospital with cannonball appearance on chest X-ray. Patient had a history of molar evacuation. What is the best management? This is a NEET 2020 question. Different types of abortion you want to know? I thought it's pretty easy. That's why I didn't mention. I'll just tell you different types of abortion. Tell me. Okay. Imago regime. Next answer to this question. Molar के बाद there is cannonball appearance. So most likely she has developed what? GTN. ठीक है, उसको कोरियोकार्सिनोमा हो चुका है. Okay, what else? Please, everyone. So we have got it that it is molar that has converted into choriocarcinoma. Okay. Only choriocarcinoma is the one that metastasized so far. GTN, gestational trophoblastic neoplasias में क्या क्या आता है? PSTT, placental site trophoblastic tumor, invasive mole भी आता है, epithelioid tumors. These all are malignant, but they don't metastasize. There is no distant metastasis except in choriocarcinoma. So it's a case of choriocarcinoma. It has reached lungs. Now, choriocarcinoma has two management. Either multi-dose methotrexate, single agent chemotherapy methotrexate, single agent methotrexate, or imacorigy, depending on the prognosis. So will you calculate this prognostic scoring? This huge scoring will tell you, according to this huge scoring, if it is more than 7, then you go for imacorigy. If it is less than 6, then you go for methotrexate. So will you calculate the whole scoring in this question? No, you don't have to do that. Just remember what things can worsen my score. Just remember what comes in 0. If the pregnancy was, if the choriocarcinoma has happened after molar, the score is 0. 0 score. The lung metastasis is very common in choriocarcinoma. I have given it a 0 score. So lung metastasis is not something very risky. It is 0 score. High HCG, but less than 1000, 0 score. ठीक है? So when these are given, lung metastasis है, molar की वजह से हुआ है, beta HCG less than 1000 है, the score is 0. ठीक है, 1000 से 10,000 है, स्प्लीन एंड किडनी में गया है, देन ऑल्सो स्कोर इज 1, मतलब स्कोर इज लो. So here I just know that it is in lungs. Lungs was score 0. ठीक है, it was after molar. Even if I don't remember age, I know it is not a very good score. Question is trying to give me that score is somewhere lower side. Lungs hai, molar hai. So most likely it is single agent methotrexate. You can't calculate the whole score here. Nobody can. So just remember what are the variables which are on the extreme left, and what are the variables that can give me a high score. High score is when choriocarcinoma happens after term pregnancy, when beta CG is more than 1 lakh. ठीक है, when the metastasis is in brain and liver. If the question gives you metastasis is in brain and liver, don't think of anything. Just realize examiner is trying to indicate you a bad score. They are trying to indicate a bad score. That is why they have given brain and liver metastasis. Don't remember other things, more than 8 drugs, more than 8 size, more than 2. Don't remember this. Remember brain, liver, remember after term pregnancy. Okay, remember more than 10 lakh. That is a bad score. I will give Imacoregime. Okay, so here everything was good. Nothing was bad. So I'll give methotrexate. You got what I was trying to explain you. And whenever such big scores are there, now I'm not going to calculate this. I just want to know whether it is good or whether it is not good. Lung is good for me. Choriocarcinoma after molar evacuation is a good sign for me. Beta ICG 1000 and less than that is a good sign for me. I know this. That's it. And that's what I have to know. What is not a good sign for me? Term ke baad hua hai. And then it has reached the brain. It is more than 10 lakh. It's not a good sign. So examiner will give you only this, either extreme right or extreme left. ठीक है? Got it? ऐसा नहीं था कि सब everything went above your head. What is ma'am saying? And we don't get it about prognosis. You get what I'm trying to say about remembering the score. About any score, I'm saying this. About bishop score, be when you remember, don't go on remembering the score. Just remember what are good things. Bishop score mein anterior cervix, soft cervix, dilated more than 4 is good score. So if everything of like this is given, I'll say a good score. Posterior cervix, long cervix, closed cervix is a bad score. Okay? Don't go on remembering everything. Okay. So what is GTD? GTD is a trophoblastic proliferation. It can be benign. It can be malignant. When it is malignant, we have given it a different term, which is GTN. Benign ka kya hote hain? Molar and complete and partial mole. ठीक है? Complete mole is diploid, but it is androgenic. All the chromosomes are coming from the father. So it is androgenic diploid. Partial mole is triploid. It has mother and father genes both, but it is triploid. One ovum is fertilized by 2 sperms. ठीक है? Complete mole has a very typical snowstorm appearance. Okay? And you will also see theca lutein cyst. What is the treatment for molar pregnancy? What is the treatment for molar pregnancy? Single dose methotrexate, multi-dose methotrexate, suction and evacuation, Imacoregime. What is the treatment for molar pregnancy? Yes, never mention methotrexate. It is always suction evacuation. We don't use methotrexate in molar. Now we know molar can turn into GTN. Once I have done the suction evacuation, I'll follow it using a hormone called as HCG. Why? Because I know it's a pre-malignant condition. It can turn into cancer. So I will follow it for 6 months. So for how long will I say suction evacuation with oxytocin? No. Remember, molars are small grape-like vesicles. I am doing suction. In case I give oxytocin during the procedure, the uterus will contract. It will suck the vesicles. Okay, resulting in amniotic fluid embolism, resulting in, molar embolism. So while doing the procedure, oxytocin is never used. So if the question comes, while doing the suction, patient starts bleeding profusely, your answer, complete the procedure fast and start oxytocin. During the procedure, I'd never start oxytocin. not I, matlab it is recommended by guidelines. You don't start oxytocin during procedure. So if she starts bleeding profusely, complete the procedure fast, start oxytocin. Okay? Never oxytocin during procedure. When I'm doing a molar evacuation, I do not allow this woman to be pregnant for 6 months because I have to do HCG evaluation to see whether she's turning into GTN or not. So she can't be pregnant for 6 months. Similarly, if I have managed a GTN patient, I have given the chemo, beta HCG is now negative. I have to keep on following HCG for recurrence for 1 year. So a GTN patient after management is not allowed to be pregnant for 1 year. Why? Because I have to monitor beta HCG to see whether it is recurring or not. If she'll be pregnant, I can't monitor beta HCG. So molar pregnancy is not allowed to be pregnant after procedure for 6 months. GTN patient is not allowed to be pregnant after chemo for 1 year. Okay? Okay? कितना रह गया? Okay, medical complications इसके बाद. Got it? You want a break, everyone? Let's finish this placenta, then we'll take a 10 minutes break. है ना? Then we'll come back. सबसे जल्दी yes type हुआ. Answers type करने में time, yes सबसे पहले. Should we just finish this one? Okay, take a 10 minutes break, then we'll come 12:20. We'll meet at 12:30. ठीक है? Go and have some little water and coffee, and then we'll come back at 12:30. ठीक है? Okay. If there's any problem you are facing during the teaching, during the style or anything, please, you can always message me. Please message me before I've taken the class, and then you will tell me, ma'am, you were fast or something. Okay. With my language, with my speed, always message. Right? Let's meet at 12:30, everyone. Hi, everybody. So, few questions. Voice is breaking up. Okay. The session might go till 5, maybe 6. We'll finish Ops and Gynae both. It's one request I can tell you, if I can tell you, is that those who are planning to see the recorded video, good, but generally it doesn't happen. If you have not been able to continuously sit right now and see the whole video live, it gets really difficult to see the recorded one, sitting all alone with no activities. It gets really difficult. So try staying live. If you can't due to some technical or any other problem, definitely you will get a recorded video. Okay? Try being there for the whole session. Is my voice audible to everyone? Is my voice clear to everybody? Okay. Okay. So why am I telling you to stay here till 5 or 6? Why am I saying that? I know it's tiring for you, for me, both. But you know what I've learned is that if you have thought of today, giving this day of yours today to Obs and Gynae, then you have to. You have to be extremely honest with yourself. If you have made a commitment to yourself that I'll give this day to Obs and Gynae, then give it. Don't quit in between, because that becomes a habit of quitting in between. That nahi ho pa raha hai, let me just quit, I'll do it later. Trust me, later will not come. It will not just not come. And it is not going to harm me anyway. It is gonna harm you. It is making you a person who is very easy to quit anything. There are so many learning platforms I was just seeing, and so many free videos, so many revision sessions right now going on YouTube. So many other companies are giving the revision session. There is no limit to how much and from where you can learn. Still, many of the students, majority of the students, end up not getting selected, end up having a bad, not even only a bad rank, but the bad marks. Why? If there is some coaching that can actually make you get selected, then why not enroll into that coaching? Everyone should get enrolled into that coaching and get selected. But it doesn't happen. It is not the coaching, it is not the faculty, and it is not the book that will help you get selected. Trust me. Videos are everywhere. Every faculty is very much close to each other. Somebody is 20, somebody is 18 or 17. So it doesn't matter what you are joining. What matters and what will help you get selected is how disciplined you are. Trust me, people are not disciplined. I'm sitting here in my clinic. Every day I get ladies asking me how to lose weight. There are videos, there are diet videos. Why don't you lose weight? Telling the ladies, I'm not talking to you about losing weight. This is not the time you should focus on that. I'm just saying the ladies in mid 35, 40. Why they are not losing weight? They know what to eat. They know what to exercise. Why? The problem is they are not disciplined. The problem is not that nobody knows how to lose weight. Nobody knows how to exercise. Everyone knows. You have to be very disciplined. Need maybe everyone knows what to read. Everyone has accessible videos. Everyone has accessible books. Still people don't get selected because people are not disciplined. They're not disciplined that if I have decided to sit for 6 hours, I'll sit. No. You guys quit very easily and that becomes a personality. If you want to be different, be disciplined. People are not disciplined, I'm telling you. And only this one thing will give you an extra edge. No matter how intelligent you are, if you will be disciplined, it will give you an extra edge and you'll perform much better. Okay? So try being on that. Sure. Enough talk. Back to the obstetrics. During embryological development, the testis would release testosterone. Which among the following is responsible for release of testosterone? No, 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 no. Who will release testosterone? वैसे, even normally in males, what cell release testosterone? Leydig cells release testosterone. Under which hormone it is influenced? Leydig cells has receptors for LH. And this LH result in Leydig cell stimulation and resulting in testosterone. Now, males need testosterone even when they're inside their mother's womb for formation of genitalia. Girls doesn't need. They don't need estrogen. Estrogen content of an intrauterine girl is very less. Still, they form internal genitalia and external as female. They don't need. Boys, intrauterine need testosterone. Now, where will they get testosterone? There is no LH. His hypothalamus is not active yet. So, where will this come from? HCG. The HCG is the one that mimics the action of LH and does a very important function, is that stimulate Leydig cell of an intrauterine fetus so that he can properly form male genitalia. So this is a very important function of HCG. Now this was a very new question when it was asked. So in case you have just hello मामी हाँ मैं ना क्लास में थी, मैं कॉल करूंगी थोड़ी देर में. हाँ ठीक 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 ओके ठीक है. So when this question was asked, it was a new question. So many questions, even if they are new, you can exclude by just knowing the other basic information. Okay, NEETPG may you will get a question that you have already seen will not happen. You will get new question. That's a rule. You will get new question. But when you'll read the options, you'll know that somewhere I know them. These kind of questions which are extremely new, if you don't have the information, my request is leave them. Don't end up marking anything. If I would have been at your place and this question would have been asked from me for the first time, I would have left it. Because I can't exclude any option. I don't know whether LH of mother reached the baby or not. I don't know whether it is inhibin or HCG that stimulate Leydig cell. Now I know because it's a previous year question. So such questions which are extremely new, which are theoretical, not clinical. So I can't use my knowledge to exclude the options. Everything looks same. Leave them. It's okay. Don't lose marks on such questions. Now it's a PYQ. Now I know. Okay, so if you see some theoretical question where I don't know anything about any option, leave. Okay, so HCG is an extremely important hormone. HCG has basically three functions. One is it is a savior of corpus luteum. Corpus luteum we need till placenta is formed. We need corpus luteum for progesterone. So HCG saves corpus luteum. Another function we just read, HCG stimulate the Leydig cells for testosterone release in male fetus. Third, HCG also stimulate the thyroid gland. It is a thyrotropic hormone. These are the three functions basically of HCG. When does HCG peak? HCG peaks, it starts rising at around 8 to 10 weeks, it peaks. And after 8 to 10 weeks, it falls. Why? Because now it does not need to save corpus luteum. After 8 to 10 weeks, the function of corpus luteum is taken by placenta. So this is the same time when luteoplacental shift happen. This is the same time when corpus luteum has maximum activity. So maximum activity of corpus luteum is at 8 to 10 weeks. Luteoplacental shift happen at 8 to 10 weeks. HCG peak happen at 8 to 10 weeks. It is same. So if this graph is given, this is HCG. Now another graph. Can you see this one? This hormone is rising straight. As the placental weight is rising, the hormone is rising. This is human placental lactogen. In case such graph is asked from you. Okay, so as placental weight is rising, just along with the weight, a hormone is rising, and that is human placental lactogen. Another hormone in this graph is, can you see this one? It was initially a slow rise, and suddenly after 20 weeks, there is a peak. This is progesterone. Okay? Another hormone that has been asked previously is the change of prolactin in pregnancy. Okay? So how does prolactin change? Prolactin keeps on rising in pregnancy, and at term, it is extremely high. It is almost 400 to 700 nanogram per DL till term. And as soon as the baby delivers, it falls. It falls immediately after delivery, and then as baby starts feeding, it peaks. And every time baby feeds, it peaks. Otherwise, it keeps on falling. So if this kind of graph is given, that is prolactin hormone. So see the graph for each hormone. Okay, they have asked this question, they can ask again. Serum prolactin is highest at, it is highest third trimester. Immediately after delivery, it falls. It peaks as the baby starts sucking, but it falls immediately after delivery. So highest level is in third trimester. ठीक है. Since they have asked prolactin, I want you to know the change in each other hormone. This is HCG, this is human placental lactogen, this is progesterone. Okay. Embryo implantation take place at which day? Again, a theoretical question. If you know, good. If you don't know, leave it. These are, you can't exclude them. So implantation starts from day 6 and implantation completes at day 10. Okay? Correct, correct, good. In oogenesis, after ovulation, the ovum will be, once the ovulation has occurred, what ovum do we get just before ovulation? Which ovum do we have? Please answer. Once ovulation has occurred, which kind of ovum do we have? We have secondary oocyte. Secondary oocyte is arrested in which phase of meiosis? Secondary, no, meiosis 1 or meiosis 2? It is arrested in meiosis 1 or meiosis 2? Correct. It is arrested in meiosis 2. Then why are you answering B? Always give a little time before answering. Secondary oocyte is arrested in meiosis 2. Why am I writing M1? ठीक है? Okay? Good. Polyspermy. Polyspermy means one sperm fertilize one ovum. It has to be prevented by cortical reaction. Again, very theoretical questions. इसके पीछे का basics we don't have to discuss. So it is the, no, acrosome reaction means when this sperm's acrosome membranes, which is made from Golgi apparatus, it ruptures, resulting in release of lot of enzymes, acrosin enzyme, hyaluronidase enzyme. The purpose of acrosome reaction is to pierce the zona pellucida. Once it has entered the zona pellucida, what will happen? It will release a lot of calcium granules, which will go and cover the ovum. These calcium granules will cover the ovum and will make it impermeable to any other sperm. That is how we prevent polyspermy. Decreasing membrane potential also happen, but it happen in non-mammalians. In non-mammalians, how do they prevent polyspermy? The membrane potential decrease. All the sodium suddenly goes inside, resulting in a negative potential outside. And that is how they prevent polyspermy. We prevent polyspermy by cortical reaction. Okay? So now this is finished. Now we have come to medical complications. We have come to the another half of obstetrics, medical complications, starting with very own favorite, hypertension. 34-year-old woman with preeclampsia. What is the basic cause? Why the preeclampsia has happened? What vessel is not invaded by trophoblast? I know you know, all of you must be knowing this. It's not a very old question. Okay, spiral arterioles are not invaded by extravillous trophoblast. ठीक है? Extravillous trophoblast has to invade the spiral arterioles. Extravillous में कौन से? The endovascular trophoblast. The endovascular trophoblast does this function, and when this function is impaired, basically the second wave of invasion is impaired. That is the time when we develop preeclampsia. So what is preeclampsia में हो क्या रहा है? There are two syndromes going on simultaneously, placental and maternal. So because of improper invasion, ठीक है, this trophoblastic, what is preeclampsia? Mother is not tolerating this new antigen. It is a form of stating that I'm not tolerating this new antigen. So as a result, mother will stop the invasion. So this invasion, which was converting vessels into big dilated channels, this invasion is stopped by mother. And the vessels do not dilate, they are still thin. And these thin vessels, which are not dilated, will lead to what? They will lead to hypoxia. Hypoxia will happen at the placental interface. And it will release so many mediators, anti-angiogenic factors, inflammatory mediators, resulting in the maternal syndrome. So hypoxia started here, resulting in inflammatory mediators here. And what will happen? Endothelial damage. Once the endothelial damage happened, now see what happened. What is the function of endothelium? It releases nitric oxide. So as a result, nitric oxide decrease. Endothelium release a lot of prostaglandins. So there will be imbalance in prostaglandins. What imbalance? Prostacyclin, which is a dilator, reduce. Thromboxane A2, which is a vasoconstrictor, increase. Another thing that happens is, now since these endotheliums are injured, the vessel becomes very sensitive to vasopressors. A little bit of amount of adrenaline will result in vasospasm. So nitric oxide decrease, thromboxane A2 increase, prostacyclin decrease, and vessels become very sensitive to the vasopressors. So what is happening in preeclampsia? Because of this endothelial damage, what happened? Now endothelium is damaged, fluid will leak, edema, proteinuria, platelets will come and plug those damaged endothelium, thrombocytopenia. है ना? अरे बेटा ये तो रिवीजन चल रहा है. लो, see. I'll share no slide with you. Don't worry. I'll share this with you. Don't try to write anything. Just try to understand quickly. Don't write anything right now. Just try to understand, focus what I'm saying. I'll share the slides. Okay. Edema, fluid leak, platelets will come and try to plug it, thrombocytopenia. Now, so many platelet plugs have formed. RBC passed through it, mechanical hemolysis. Other than that, what will happen? So many platelets are used that, when the fluid is leaking, it will lead to hemoconcentration. So edema, hemoconcentration, thrombocytopenia, mechanical hemolysis. What will happen in each organ? Because the vessels are so sensitive, person will have hypertension. This person will be hypertensive. Everything started because of improper invasion. What will happen in lungs? Endothelium is damaged, edema. What will happen in liver? Enzymes will get deranged. Liver hematoma will form. In kidney, when there is vasospasm, GFR will reduce. Proteinuria will start happening. In brain, so much fluid is leaking, somewhere it is spasm, somewhere fluid leaking. So much cerebral irritation happening that will lead to headache, cerebral symptoms and convulsions. And where it all started, in placenta, what will happen there? IUGR, oligo, deranged Doppler. All started with improper invasion of spiral arterioles. Okay, that's what all we see. Okay. So remember, what is the definition of preeclampsia? Whenever hypertension happens at less than 20 weeks, it is chronic hypertension. Okay? And whenever it happens after 20 weeks, it is because of pregnancy. We call it pregnancy induced. Now, pregnancy induced hypertension may, if along with hypertension, there is nothing else, it is gestational. But along with hypertension, I have either proteinuria, or proteinuria is not there, but I have a sign of organ involvement. What is the sign of organ involvement? What we have just read. Pulmonary edema, raised liver enzyme, increased creatinine, cerebral symptoms, oligo-IUGR. They all indicate systemic involvement. So if proteinuria is not there, but any organ involvement is there, it is again preeclampsia. So NEETPG में definitions come. Hypertension दिया है, proteinuria is negative. They have given you cerebral symptoms. They have given you AST, ALT raised. Mark preeclampsia. Any organ involvement is preeclampsia. ठीक है? What is impending eclampsia? Impending means something which is about to happen. Impending eclampsia means eclampsia is about to happen. What is eclampsia? When there is convulsions or coma, that is eclampsia. Okay? Remember, the convulsions can be generalized tonic-clonic. It can be focal convulsions also. So eclampsia definition mein focal convulsions are also included. Okay? So impending eclampsia means convulsions are about to happen. So what signs indicate convulsions are about to happen? Obviously, so many cerebral symptoms. Headache, improper vision, persistent headache. Other than that, one is epigastric pain. Epigastric pain indicates liver mein hematoma. Liver is forming hematoma. Liver hematoma means it's such a severe condition, now she will throw convulsions. So impending eclampsia के signs होते हैं. Cerebral signs and epigastric pain. They indicate that convulsions are about to come. Manage this patient. ठीक है? A 34-year-old woman advised an ultrasound and a double marker. What would the Doppler of uterine artery help to predict? Uterine artery Doppler हम क्यों करेंगे? No. Impending eclampsia, HELLP syndrome, Yes, HELLP syndrome is also severe condition. Anything severe is impending eclampsia. Impending eclampsia is basically symptoms. Impending eclampsia means those symptoms that indicate eclampsia is about to come. HELP is a diagnosis based on not symptoms but based on lab investigations. Okay, so HELP syndrome is not a symptom. Symptoms होते हैं जो impending eclampsia को में count होते हैं. ठीक है, HELP is not a symptom. It's a biochemical diagnosis. Yes. Uterine artery Doppler will help me detect what? Early onset preeclampsia. ठीक है? So even if I don't know what is the answer, even if I'm seeing it for the first time, if I know that uterine artery Doppler, I don't know why uterine artery Doppler is done, but what I can see is preeclampsia is given twice, IUGR is given twice. So what I know is that uterine artery, spiral arterioles are a branch of uterine artery. So spiral arterioles invasion happens at around this weeks. And at 10 to 12 weeks, invasion happens. So if there is an improper invasion, it can lead to preeclampsia. Though very difficult way of deducing that answer, still you can think that yes, uterine artery can only thing that can help, that can link to uterine artery is preeclampsia. Only pathology that I can link to uterine artery is preeclampsia. So that ways you can answer. When to stop MaxSelf? So I think at around 4, I will finish gynae obstetrics, and at around 6, I will finish gynecology. Okay. When to stop MaxSelf? Yes, when your urine output is less. 4 घंटे में, in 4 hours, how much urine you should see in the bag? 100 ml. So when it is 100 ml, it means it is normal. It is lesser than that, then you have to stop the MaxSelf. Okay? MaxSelf toxicity में all are monitored except routine MaxSelf. Routine MaxSelf is not done. You do respiratory rate, urine output, and DTR. Okay, what is the first sign of toxicity? DTR. Respiratory rate less than 16 is respiratory depression, that is seen in next sign of MaxSelf toxicity. What is the antidote for magnesium toxicity? Okay? Correct. Calcium gluconate. Oh, the huge question. 22-year-old Mm-hmm. 22-year-old type 1 diabetes post-op में है after cesarean due to severe preeclampsia. So she has diabetes and preeclampsia, drowsiness and altered sensorium, maintain max self, pulse 70, BP high, respiratory rate 10. On auscultation, lungs में normal entry है, abdominal examination is normal. What is the diagnosis? Sugar is high. What do you think should be the diagnosis? Not because we are reading that topic. What do you think should be the diagnosis? When they have given me bilateral patellar reflex absent, that is only and only present in MaxSelf toxicity. ठीक है? Patellar reflex absent is directly indicating MaxSelf toxicity. Why it is not DKA? Why it is not diabetic ketoacidosis? Sugars are high. Even if this is not given to me, will I call it DKA? No. Why diabetic ketoacidosis may? Not only ketones, there is respiratory rate is very high. She's tachypnic. She's hypotensive. It is reverse. Pulse is tachycardia. She has hypotension, tachycardia, tachypnea. That is the clinical symptom of DKA. It is completely reverse. Why it is not peripartum cardiomyopathy? See, peripartum cardiomyopathy is a typical heart failure. Typical heart failure that happens in 3rd trimester around delivery. So there will be symptoms of heart failure. What will be that? Again, there will be tachypnea. There will be orthopnea. Bilateral air normal entry is not there. In heart failure, there will be crepes, there will be murmur. Okay? When there is heart failure, there is hypotension. So even if patellar reflex is not there, I can see these 3 things are telling me it is magnesium toxicity. है ना? Right? Now this question, similar. You got previous one, no? Why it was maxillary toxicity? Even if patellar reflex is not there, then also I know. Okay? Respiratory depression happens only in maxillary toxicity. Okay? Now why it is HELLP syndrome? I have three things. HELLP syndrome के लिए I need three things. All three of them. Hypertension हो या ना हो. Sometimes their hypertension is not there. I need high SGOT-PT. I need high LDH. High LDH indicate hemolysis. LDH is an RBC enzyme. So high LDH means hemolysis and thrombocytopenia. All three are present. It is HELLP syndrome. ठीक है? Why it is not viral hepatitis? Viral hepatitis may SGOT-PT is raised, but it is 2000. So if SGOT-PT are given to you 2000, then it is viral hepatitis. It is so high. Acute fatty liver is again liver failure. It's a very emergency condition. Liver fails. So when the liver fail, what else will be given here? See, they have given deliberately coagulation profile is normal. When liver fail, coagulation deranged. Liver can't excrete ammonia. So suddenly her ammonia will be high. She will show psychotic symptoms. It's an emergency. Her blood sugar will be very low. Okay? Her kidney functions will get deranged. So it's a typical liver failure and they have given coagulation is normal. No psychotic symptoms, no ammonia levels. So it is not acute fatty liver. Cholestasis is a mild condition where if they have to give you cholestasis, they will always mention itching. Cholestasis does not happen without itching. They will always give you itching. Itching के साथ what is actually rising is SGOT-PT बढ़ता है, but what is actually rising is bile acids. Bile acids are rising. That is cholestasis. So that's how you differentiate that it is HELLP syndrome. Okay. Right now it is easy to get the answer. SGPT, OT are high. ALT, ST are high in cholestasis and the values are somewhere around, they are less than 80. They are more than 40, but they are less than 80. Okay. So right now the question is looking easy because we are reading the hypertension. When you'll get it in exam, you'll just get it randomly. You will not know which system to get involved with. I don't know it is from which system. So there, just see the basic features. Hepatitis nahi ho sakta. SGOT-PT is not this much. Acute fatty liver is a failure. Coagulation is normal. Why they have given coagulation normal? Deliberately to tell you it is not failure. Then cholestasis, there is no itching mentioned. But yes, rise, low, HELLP syndrome. Okay, so there though you have to read all the options. Okay. 35 is from NEET 2020. 35-year-old female, history of IVF, diamniotic, dichorionic, 38 weeks. First twin breach, BP high. What is the next line? So they have tried to ask multiple things in one question. Okay. So if first twin is breach, I cannot deliver it normally. So induce gets wrong. Induce gets wrong. I have to do cesarean, but when her BP is high, 38 weeks, I'll do cesarean. Okay. High BP, hypertension in pregnancy has to be terminated at 37 weeks. Severe hypertension has to be terminated at 34 weeks. Okay. So I don't need to take it above 37 weeks. I don't need to. Okay. So this finishes our hypertension in pregnancy. This much, knowing this much is more than important, is more than sufficient. Okay. Diabetes in pregnancy. Diabetes in pregnancy, as such, in last 5 years, there has been only one question, which is this. In which pathology this kind of malformation is seen? A tough. Non-severe preeclampsia is BP more than 140/90 but less than 160/110. Severe preeclampsia is BP 160/110 or if BP is normal, any organ involvement. that is a sign of severe preeclampsia. BP is not that high, but there are constantly cerebral symptoms. It is severe. BP is not that high, but the liver enzymes are persistently deranged. It is severe. Okay, so any organ involvement, it is severe. Yes, this question which I have asked is sacral agenesis, where the lumbar vertebra has not formed. Lumbar vertebra doesn't form. Sacral agenesis is very specific of diabetic mother. Okay, so whether it is seen in diabetes or GDM, in which case more sacral agenesis will be seen. Which of these has more incidence of sacral agenesis? GDM में anomaly नहीं होते. Congenital anomaly does not happen in GDM. Always remember, congenital anomaly only happen in pre-gestational or overt diabetes. ठीक है? Because gestational diabetes में sugars are never very high. The question I asked in the group, sugars are never very high to cause anomaly. So whenever a question is asked what complications can happen in GDM, polyhydramnios can happen, big baby can happen, labor will be difficult, but congenital anomaly and abortion, that doesn't happen in GDM. And that brings me to the diagnosis. All of you have had answered wrong. The diagnosis of diabetes in pregnancy. It is not like hypertension. Before 20 weeks hai to overt hai, after 20 weeks gestational hai. No. It is not like hypertension. Any abnormal sugar detected in pregnancy, irrespective of gestation, is GDM. It doesn't matter. You do the screening test, sugars are high, it is GDM. Unless the sugars are very high. GDM में sugars are never very high. If the sugars are very high, again, irrespective of gestation, it is overt. What do I mean by very high? My fasting is more than 126. I did the OGTT and the value was more than 200. Random blood sugar was more than 200. Or HbA1c is more than 6.5. If I have got this, it is not GDM, it is overt. And nowhere I have mentioned gestational age. I have not mentioned gestational age anywhere. Okay? So even if it is 8 weeks, sugar are high but not this high. Your OGTT is more than 140 but not 200. It is GDM. It doesn't matter what gestation she is in. So diabetes diagnosis and preeclampsia are different. Okay? So the question I asked with very high sugars at almost at 12 weeks, it will be overt. Okay? The test that we do is oral glucose tolerance test where we give how much sugar, 75 gram glucose. And after giving glucose, we measure sugar after 2 hours. We don't do fasting and it is according to DIPSI criteria. Diabetes in pregnancy study group of India. No fasting done. Give 75 gram glucose, measure after 2 hours, value more than 140 GDM. Value more than 200 overt. Okay, so remember this diagnosis. Okay. Again, complications, congenital anomalies happen only in overt. It does not happen in GDM. Can somebody tell me what is the most common congenital anomaly that happens in overt diabetes? The most common. Just listen, think, and then answer. What is the most common anomaly that happens in overt diabetes? Perfect. What is the next most common system involved? After heart, the next most common system involved is neural tube defect. So heart defects is the most common anomaly. Usme bhi VSD is most common. Sacral agenesis is most specific of diabetes. It is not most common. So never mention sacral agenesis as the most common anomaly seen in diabetic mother. No. It is very specific, but not common. Okay? Why are you remembering least common? Who is asking you the least? Just imagine this question. Least common anomaly seen in diabetic mother. Question will be asked which have a clinical significance. The most common anomaly will be asked because a diabetic mother may you do a fetal echo. You do fetal echo, that is why you have to know the most common system involved is cardiovascular. Next most common is CNS because you do a neural tube scan. Knowing least common is not important. Why I'm saying this? This brain has limited memory, and we should select only what is important. Okay? Okay? I know there is an urge to learn everything, but beta, it is limited, right? Most specific is TGA. Most specific cardiac anomaly is TGA. Most common is VSD. Okay? So this is all about diabetes. Diabetes ka diagnosis should be known to you. The screening test should be known to you. When do you do screening test? First at the first ANC visit, second at 28 weeks. So this is the time when we do the screening test for diabetes. Okay. Now we comes to anemia. A patient in 22nd month of pregnancy with anemia, hemoglobin 9. What is true about starting the iron? She's anemic, right? When will we start iron in her? Correct. Right. 8 to 10 weeks. So again, this was also a new question, but this can be very well answered seeing that she is anemic. One urge will be, I will start it at 14 weeks because prophylaxis is started at 14 weeks. Na? It is not prophylaxis, it is treatment. If you know that oral iron can be given in first trimester, if you know this thing, oral iron is allowed, you will mark 8 to 10 weeks. In case you have incorrect information that iron is not given in first trimester, contraindicated, then you will not mark it. It's a wrong information. Oral iron can be given in first trimester. So if she is anemic, we'll start oral iron. What we can't give in first trimester is IV iron. IV iron is not given. Okay? Prophylaxis is started at 14 weeks. Why? Because GI symptoms बहुत होते हैं, nausea, vomiting. Okay? So immediately as you discover she is anemic, you will start the treatment with oral iron. You have to remember the Anemia Mukt Bharat program. Okay, also called as Intensified National Iron Plus Initiative, which has 6 by 6 by 6 schedule, 6 beneficiaries, 6 interventions, and 6 institutional mechanism. 6 interventions everyone knows. Everyone knows 6 interventions that have to be done to prevent anemia. Should I ask one by one? चलो कोई नहीं. What are the 6 interventions? One we already know, iron folic acid supplement. कब से start करना है? Second trimester, 14 weeks से. To every pregnant woman, everyone. Intervention 1, intervention 2, deworming. Done in second trimester. Using what? Using albendazole. How much albendazole? 400 milligram. So this is what has to be done in everyone. Correct. Keep writing the interventions if you know. Keep typing. There's no problem. Just keep moving your fingers and keep writing. Intensified year-round change. Intensified year-round change means certain change have to be done by obstetrician, like delayed cord clamping. Delayed cord clamping has one purpose, and that is preventing fetal neonatal anemia. All the blood that is there in the cord will be going to the baby. So delayed cord clamping. Then testing the anemia using digital methods. Now hemoglobinometers are there in every center. So you don't take sample, you just make a small prick and measure the anemia. So digital hemoglobinometers now available. Food fortification, adding iron to normal routine atta of yours. Okay? Addressing non-nutritional causes. Okay? Like malaria, like fluorosis. Okay? Good. So these are the 6 interventions. Folic acid dose हमको पता है. We know the folic acid dose. 60 milligram iron, 500 mcg folic acid has to be taken for 180 days. Good. Very good, Sagarika. Perfect. This is the iron folic acid supplement taken to be for 180 days. 180 days during pregnancy and 180 days again during postpartum. So total 360 hota hai. So 180 in pregnancy, 180 postpartum. Okay? You don't have to remember the WHO one. You just remember the routine iron folic acid supplement according to our country. Okay? So it has to be started from second trimester. What you have to give in first trimester is only folic acid. Only folic acid has to be given in first trimester to prevent neural tube defect, and the dose is 400 mcg. ठीक है, anything more than that, more than 400 mcg has to be given to prevent neural tube defect. In a women of high risk, means previous history of neural tube defect, obese women, women on anticonvulsant drugs, then diabetic women who are in risk of neural tube defect, the dose is 10 times. ठीक है, okay, got it. Now we have finished anemia also. Whatever questions keep coming to your mind, please let me know. If you have any other information which you think is different from what I am telling you, please let me know. Okay. Treatment for hyperthyroidism at 8 weeks. What is the answer? So hyperthyroidism is correct. So two antithyroid drugs are available, basically propylthiouracil, methimazole. Both of them cross the placenta. Both of them cause the congenital anomalies. Both of them. So which to use? The one which is less harmful. Both of them are harmful. Okay? But which is less harmful, that has to be used, especially at less than 16 weeks, which is propylthiouracil. Propylthiouracil has to be used up till 16 weeks. Okay? Basically, it also causes renal anomalies like single kidney and sometimes outlet obstruction, but it is less significant than methimazole. Methimazole क्या क्या कर सकता है? Methimazole can cause choanal atresia. हर चीज को atresia कर देता है. Choanal atresia, esophageal atresia, cicatricial skin lesions, aplasia cutis where the scalp has not formed. All that is called by methimazole. Aplasia cutis, choanal and esophageal atresia, they are all caused by methimazole. ठीक है? Propylthiouracil is used, preferred at less than 16 weeks. Next, primary gravida deliver her baby. Now, when you're writing this, that second, third trimester, we should use carbimazole. I've read the whole guideline, and not carbimazole is not used, methimazole is used. But what the American Thyroid Association has written is that propylthiouracil is preferred at less than 16 weeks. After 16 weeks, you can choose. So they have not mentioned that I have methimazole. They have not mentioned that you have to use methimazole. It depends on patient tolerance. So after 16 weeks, you can choose. There is no specification in those guidelines, but yes, before 16 weeks, they have specified that propylthiouracil has to be used. Okay. Primary gravida deliver her baby at village health center. After 1 hour, she develops hypoxia, hypotension, and DIC. So there is a triad that has come: respiratory, cardiovascular, and DIC. What is it? Correct. It is amniotic fluid embolism. Amniotic fluid embolism has a typical triad. When the first symptom is respiratory and cardiovascular followed by DIC, it is amniotic fluid embolism. PPH maybe patient can develop this, but PPH may the presentation will be first excessive hemorrhage will happen. Excessive hemorrhage followed by hypoxia and hypotension followed by DIC. In amniotic fluid embolism, there is hypoxia and cardiovascular problem and DIC. Now, this DIC can lead to PPH later, but PPH will be last. Here, it will start with PPH. So this typical triad that within 1 hour of delivery, there is respiratory involvement, cardiovascular involvement, and DIC. This triad is there in amniotic fluid embolism. Okay? Why it is not uterus rupture? It is not uterus rupture because uterus rupture will not present after 1 hour. Okay, na? And peripartum cardiomyopathy, I have told you, it is typical heart failure. They will give you orthopnea. Okay, they will give you hemoptysis, Krebs, holosystolic murmur. They all will be there in heart failure, which is peripartum cardiomyopathy. So whenever you get this triad, abrupt onset of cardiorespiratory arrest, hypotension and respiratory compromise, and coagulopathy prior to blood loss. Blood loss abhi nahi hua hai, but coagulopathy has happened. That is amniotic fluid embolism. Okay? during labor or within 1 hour. So when without bleeding, somehow DIC develop. There is no excessive bleeding, but somehow respiratory compromise and hypertension develop. You don't understand why. It is amniotic fluid embolism. Okay, so amniotic fluid embolism is the, no, it is not the abruption is, okay, जाने दो. What is the most common cause of DIC in pregnancy? What is the most common cause of DIC in pregnancy? Okay, we saw one is amniotic fluid embolism. What is the most common cause of DIC in pregnancy? Abruption. That is the most common cause of DIC in pregnancy. ठीक है? Right. Next. Gravida 2 para 1 at 18 week 5 days has come to you. Cervical length 1.5 centimeter. There is not much benefit of cerclage. She is insisting for cerclage. Which of these is an absolute contraindication for cervical cerclage? When cervical cerclage, what are you trying to do? You are trying to prevent the preterm. Okay, you're trying to prevent the preterm labor. When somebody has gone into preterm labor, okay, there are uterine contractions. She has gone into preterm labor. Now giving cerclage will not help. Okay? No. So advanced maternal age has nothing to do with cerclage. Membranes bulging also nothing to do with cerclage. There are two probable diagnoses. Positive fetal fibronectins indicates preterm. It indicates preterm. Ruptured membrane means the membranes have totally got ruptured. If the membranes have got ruptured, will I try to stop this pregnancy? If I try to stop this pregnancy, is there not risk of infection? Isn't it? So if the membranes have ruptured, though a proper preterm labor and ruptured membranes both are contraindication, but which is most suitable here? If the membranes have ruptured, will I try to put a suture in that ruptured membrane? Will it not cause infection? It will no. So even if I don't know, I can think that membranes have ruptured. Clinically, membranes ruptured. Will I tie a suture? No. It might cause infection. You might be wrong. This way, if you'll answer, you might be wrong, but the chances and the probability of being right is more. So there are certain questions like this. When you don't know the answer exactly, again, which is a new question. When in any question, remember, in any question, if you are very easily able to exclude two, and you are left with only two, always try attempting that. Always try attempting that. If I'm able to exclude two options, I'm left with only two, always try to use whatever you can understand and attempt that. Your chances of being correct is more. Okay? So if I'm using my common sense, I'm not sure, but I'm using my common sense, it can cause infection. I'll mark it. There are more chances I'll be right. So never leave a question when only two options are left. Okay? Okay, never leave such questions. But as I've told you in HCG, if it's a theoretical question, you have no idea, you are seeing it for the first time, leave that question. But not such questions. Okay? When doing such question, my heart is saying, I think D is there, B can also be there. Still, I'm seeing D is there. Whatever your heart is giving you, first option, mark it. Don't leave such questions. Okay? Fetal fibronectin test. See, preterm labor, when we read preterm labor, now there are two things in preterm labor. One is somebody at risk of preterm and somebody who is in preterm. At risk of preterm, matlab that right now she might be only 7-8 weeks pregnant, but she has given me a history of previous preterm, or she has given me a history of previous mid-trimester abortion, or she has given me a history of cervical surgery. These women are not in preterm right now. These are at risk of preterm. Here my answer is cerclage. I will give them cerclage. Once I have done a 11 weeks anomaly scan, I will give cerclage. Another category, she is in preterm. Right now, she might be at 25 to 28 weeks. She has come to you with pain. She has come to you with pain. and now you are diagnosing that she has gone into preterm. How will you diagnose? Either cervix is open, इसे हम कहते हैं diagnosed preterm. When cervix is more than 4 centimeter, I have no doubt she is in preterm labor. I have no doubt she is in preterm labor. So, pain is there, contraction there, cervix more than 4. Suppose cervix is closed. Will I send her home? You are not in preterm. Go home. No. She's having pain. She's having contractions. Maybe she'll go home, cervix will open. So I'll do certain test. I'll do ultrasound cervical length assessment. What I did in last question. If the ultrasound shows that she has pain, closed air, but it is small, she is in preterm. If I don't have ultrasound, then I do fetal fibronectin levels. In the vaginal fluid, I check fetal fibronectin. If I don't have ultrasound. What is the condition? Patient has come to with me with pain, cervix is closed. I'm doubting preterm. I'll do fetal fibronectin. If it is more than 50, she is in preterm. Anybody who's in preterm, I am not gonna give Cerclage. She's in preterm labor. Contraction will start, it will rupture. It will rupture the cervix. So in preterm, treatment is not Cerclage. Treatment is steroids. Treatment is tocolytics. So there are two categories of preterm labor. One is at risk, one is in preterm right now. So fetal fibronectin is used to diagnose the preterm if cervix is closed and I don't have ultrasound for cervical length assessment. If cervix is closed, she is having contraction, fetal fibronectin is high, she is in preterm labor. I will treat her like preterm labor. Yes, 3 things. Magself, steroids and preterms. These are 3 things which will be given in her. In her, who is at risk, I will do Cerclage. I will give her vaginal progesterones. Clear? So if I'm talking, let me just remove this one, otherwise nothing will be visible here. So if I talk about Cerclage, Cerclage is given in a woman who has some bad history. इसे हम कहते हैं history indicated Cerclage. History indicated Cerclage is given in a woman who has 3 or more than 3 previous preterms. 3 or more than 3 previous preterm birth or mid-trimester abortion, I will give Cerclage. I will not measure the cervical length. I'll give Cerclage. When is it given? At 11 to 14 weeks. When I have done my aneuploidy screening and I am sure baby is healthy, then I give Cerclage. In anybody with 3 or more than 3 previous preterm. इसे हमने बोला, this is what we call history indicated. One is ultrasound indicated Cerclage. Ultrasound indicated matlab? Ultrasound shows cervix is small. So it means we go and measuring cervical length in everyone? No. Anybody with history of 1 to 2 preterm birth. 3 होंगे तो सीधा Cerclage, straight away Cerclage. 1 to 2 preterm birth या mid trimester abortion or some kind of cervical surgery has been done. Here I'll do ultrasound. If ultrasound shows a short cervix, I give Cerclage. This is called ultrasound indicated Cerclage. This is history indicated Cerclage. Okay. So question comes, a lady with history of previous 3 mid-trimester abortions, your next step. Your next step is not ultrasound. Your next step is not fetal fibronectin. Your next step is Cerclage straight away. A lady with history of 1 preterm, next step, ultrasound cervical length assessment. If here cervical length shows less than 25 mm, then I'll give Cerclage. So these are 2 types. ठीक है? Okay. One is rescue Cerclage. Rescue Cerclage किसमें देते हैं? Anybody where os is open. ठीक है? Os is open, membranes are bulging. I will give Cerclage. But one thing, there should be no contractions. Without contraction, cervix has got open. Most likely it is a weak cervix. If it has got opened without contraction, I'll give Cerclage up till 24 weeks. इसे हम बोलते हैं rescue Cerclage. There was no history. She came to me, I saw cervix was open. I'll give Cerclage, but there should be no contractions. Contractions matlab she's in preterm. If she has gone in preterm, I'm not gonna give Cerclage. So when do we give progesterone? Now you are getting deeper and deeper into this topic. So if there is history of 1 to 2 preterms, mid-trimester or cervical surgery, I did the ultrasound cervical length. Cervical length is normal. I will start with vaginal progesterones. She has a history. So I'll give vaginal progesterone, not Cerclage. Cerclage will be given in these patients only when cervix is short. If cervix is normal but history is there, then I give progesterone. In this patient, no progesterone, straight away Cerclage. Okay, got it? Where I don't give Cerclage? Active preterm, infection hai, bleeding hai, membranes have ruptured, or I don't want to save the baby. Baby is already died. Why will I give Cerclage? Baby has anomaly. Why will I give Cerclage? So these are the contraindications. ठीक है? Okay. चलो अब I have to finish through labor by 4. We are almost finishing by doing infections and everything. Infections के बाद एक second. Just let me see when we can take a lunch break. Infections के बाद, after infections, okay, RH, HIV. Okay, I'll take half an hour more and then we will take a lunch break of half an hour. Then we'll meet and finish labor. After that, we'll start with gynae. ठीक है? The speed is, are you guys getting? See, it might look very fast, but we have to finish a lot in this duration, isn't it? So we are trying to cover everything which is important. The speed is fine. Speed is fine. It's not good. Tick. What is the answer to this? Rubella. So infection in pregnancy may just remember these specific signs. Infection in pregnancy, when the question will give you, they will give you IUGR, hepatosplenomegaly. It is present in all infections. But specific signs that indicate that teratogenic infection. So TORCH group are basically teratogenic infections. Chorioretinitis, calcification, and hydrocephalus, as one of you have already mentioned, is a triad. Retinitis, calcification, and hydrocephalus, toxo. If instead of hydrocephalus, same finding but microcephaly, CMV. So toxo में hydrocephalus होता है, CMV में microcephaly होती है. But when the question has given you CMV, question will always give you sensory neural hearing loss. So sensory neural hearing loss and thrombocytopenic purpura will always be given in CMV. One more pathology has sensory neural hearing loss and microcephaly both. What we have just done, rubella. So rubella may be SNHL and microcephaly hota hai like CMV, but what will be differentiating point that heart defects and cataracts are there in rubella. CMV has thrombocytopenic purpura and calcifications. Rubella has heart defects and cataract along with SNHL. So remember these combinations of anomalies. Talking about varicella. Varicella will cause scarring everywhere. Typical cortical atrophy, limb hypoplasia, cicatricial scarring of skin, cataract. When hypoplasia of everywhere is happening and scarring of skin is happening, it is varicella. Okay? Parvovirus, what will question give you? Anemia. Okay? Fetal anemia. Abortion anemia, non-immune hydrops, that is parvovirus. Syphilis. How will syphilis present? Slap cheek will be in newborn. Intrauterine slap cheek नहीं हो सकता. Intrauterine slap cheek will not be a finding. When a newborn baby gets parvovirus, then that will be a slap cheek appearance. है ना? Syphilis, rhinitis, ठीक है, maculopapular rashes, pustules, ठीक है, then thickening of tibial bone. Tibial bone will show anterior bowing, anterior growth, like a saber shin. So this is a saber rod, saber sword. Saber sword क्या होती है? Which is like curved anteriorly. इसलिए we call it saber shin. Shin becomes anteriorly curved. And clutton joints, swollen joints. Can you see swollen joints and saber shin? Saber shin matlab it is curved like this. So this is syphilis. Okay? It's okay. No problem. Okay? What will happen? What extra can happen with syphilis? ऊपर से शुरू करते हैं. So there will be frontal bossing. There will be palate perforation, Hutchinson's teeth. ठीक है, Hutchinson teeth, palate perforation, frontal bossing, palmar pustules and these erythematous patches, thickening of joints, ठीक है, and same sabersion. All that will happen in syphilis. ठीक है, that are very typical of हाँ interstitial keratitis. Thank you so much. ठीक है, keratitis will also happen. Question: antenatal transmission is highest of rubella. Rubella has highest antenatal transmission. It is most teratogenic. 90% transmission happen. So every woman should be rubella immune before pregnancy. So rubella IgG should be positive in every woman once she becomes pregnant. In case she is not, you always vaccinate the woman. If she is not immune, vaccinate. And after vaccination, for how long pregnancy will be avoided? For how long will I avoid the pregnancy? No, that's too long. 1 month, correct. 1 month, beta. For 6 months, no, for 1 month. So once she has been vaccinated, we will avoid pregnancy for 1 month because it's a live vaccine. Okay? Highest perinatal transmission, perinatal matlab during the delivery. During the delivery, highest perinatal transmission is of herpes, followed by varicella. Do not write HIV. HIV has a perinatal transmission of 30%. ठीक है, after taking ART it reduces to 2%. Herpes has 70% perinatal transmission during delivery. ठीक है, so if somebody has primary herpes, if somebody has got primary herpes, vaginal delivery while the baby is passing through vagina, there will be very high chances of neonatal herpes, and neonatal herpes has mortality of 90%. If baby gets neonatal herpes, 90% of time baby will not survive. So primary herpes is a contraindication for vaginal delivery. Okay. What about varicella? If woman has got chicken pox, now chicken pox is not around vaginal area. So if somebody has got chicken pox around delivery, she can undergo vaginal delivery. That's not an issue, but you will not deliver her for another 7 days. Because you want mother to form antibodies and that antibodies to reach the baby. Because if the baby develops varicella, जिसे हम कहते हैं neonatal varicella, again it has a very high mortality. So in case mother gets chicken pox, once mother gets chicken pox, after 7 days, you undertake delivery. Vaginal or cesarean, it doesn't matter. She can undergo vaginal delivery or cesarean because the lesions for chickenpox are not around vagina. So it doesn't matter. But delay the delivery for 7 days. But in primary herpes, the herpetic lesions are around the vulva. You don't let her vaginally deliver. You do cesarean. Okay? Otherwise, you will end up losing the baby. Okay? Baby delivered preterm with rash, thrombocytopenia, hepatomegaly, hearing test failed, calcification. So we see SNHL, thrombocytopenia. What is it? CMV. 37, yes, Gravida 3, Para 2, 37 with previous to LSCS. She is having active primary herpes. What should be the mode of delivery? We have discussed. Primary herpes, LSCS. Classical LSCS करने की जरूरत है? No. Classical क्यों करना है? The lesion is in vagina. Why to make a classical incision on uterus? No, normal lower segment cesarean. Similar question was asked in 2020, but here they did not give herpes. They gave you the presentation. 28-year-old women with painful reddish vesicular lesion. Painful reddish vesicular lesions are most likely herpes. What will I do? Acyclovir or cesarean induction? Obviously. I'm not giving much time on questions because we have to finish, right? Primary known case of post-op heart disease having prosthetic valve. 37 weeks, what should be the next step? Isko you answer. Please answer this question. So why am I switching to low molecular weight heparin? She was on warfarin. Prosthetic heart valves को warfarin पे ही रखते हैं. We keep them on warfarin because warfarin is a very good anticoagulant. So mechanical heart valves patient are always kept on warfarin. Why am I shifting her to low molecular weight heparin at 37 weeks? What is the reason? Warfarin, up to warfarin will not cause any anomaly. है ना? Warfarin is not going to cause any anomaly. Why am I shifting her to heparin? Bleeding where? Where bleeding will happen? Perfect. Bleeding can happen to mother no matter she is warfarin, taking warfarin or heparin. If mother is on anticoagulant, once she goes in labor, you have to stop everything. Otherwise, she will bleed. ऐसा थोड़ी है heparin पे she will not bleed. Problem is that warfarin grows to the baby. And if she delivers vaginally, the baby will have intraventricular hemorrhage. When baby pass through that pelvis, baby will have bleed. That is why you stop warfarin and start on heparin. And once she is in labor, means as soon as contraction starts happening, or you plan cesarean, you stop. Warfarin pe ho ya heparin pe, you stop everything. Because you don't want mother to go into PPH. You will stop. Okay? But at term, you always switch the mother to heparin. Okay? So that baby does not bleed during the process. Okay? So remember, mechanical heart valves patient are always kept on warfarin. Okay? Now warfarin can cause embryopathy. है ना? Warfarin से हो सकता है embryopathy. So what to do as soon as she becomes pregnant? I'm telling you, warfarin can cause embryopathy. ठीक है? Chondrodysplasia punctata can happen with warfarin. Nasal hypoplasia will happen with warfarin. So, but if the dose is more than 5 milligram, if the dose is less than 5 milligram, it will not cause anomaly. You continue with warfarin. But here, if the dose is high, you stop warfarin in first trimester. You stop. And you keep her on low molecular weight heparin till second trimester. Because second trimester pe again I have to keep her on warfarin. This woman is of mechanical heart valve. She can anyway form a thrombus. So in second trimester, I will again shift her to warfarin. Okay. First trimester, I will stop warfarin. I will put her on low molecular weight heparin. Now, when this woman reaches 37 weeks, now she's not in labor. She has just reached 37 weeks. I will stop warfarin and I will again put her on heparin. Because why? Because now if by chance she goes in labor, baby delivers, baby will have intraventricular hemorrhage. So once I stopped warfarin in first trimester, again I stopped warfarin at 37 weeks. I put her on heparin. I will continue heparin till she goes in labor. Or I plan cesarean. If I plan cesarean 24 hours prior, I stop heparin. If she goes in labor, I tell her as soon as you develop pain, stop heparin. Once she delivers, after 6 hours, I again start because she's a heart valve patient, I have to start something. After 6 hours, I'll start heparin and warfarin both. Now in a lactating woman, there is no harm. You can give both. So after 6 hours of delivery, I will start on heparin and warfarin both. And as soon as I have got an desired INR, as soon as our INR is desired, is increased, I will slowly withdraw heparin, let her continue her warfarin. So Jesse, my INR has reached the threshold. This is the threshold. As I get the threshold INR, I'll withdraw my heparin, let her continue on warfarin. This is how you manage. Okay? Very important. 2-3 questions have been asked on anticoagulant. Why did I started on heparin and warfarin both? Warfarin is slow acting. If after delivery you will start only warfarin, her INR will take days to go up till 3. And it is very harmful for her that. So that is why you started both. And as soon as you got an INR, you withdraw your heparin. The only purpose of heparin was it is fast acting. That is why we added it. And then we withdraw. Okay? Good. Smart. Got it? Got this much? Now, if I get this kind of question, I know warfarin is a very good anticoagulant, but it is slow. And I know heparin is a very fast acting anticoagulant. Previous question mein beta, you will switch to low molecular weight heparin. She's 37 weeks. So whatever is the dose, you will switch to low molecular weight heparin. A patient at 31 weeks has got deep vein thrombosis. Now it's an emergency. In an emergency, what will be my choice? I know heparin is very fast acting. I'll use heparin. Why I'm not using warfarin? I can use at 30 weeks, but it's slow. That is why I'm not using warfarin. Okay. Got it? So this is anticoagulation. Now coming to twins. Tired? We have to do twins, emergencies, and then points. Not much is left. Before labor, before going to lunch, I think. Why not C beta? Fondaparinux is a low molecular weight heparin analog, and it has been seen that those who are heparin allergic can be given fondaparinux, but heparin is always the choice. There has been not enough research to prove that this cause no anomaly. But yes, it's a good point. Anyone who is heparin allergic will be given this medication. Okay. Mode of delivery in twin. What is the mode of delivery in this twin? LSCS. Because the first twin, what is first twin? The one near the cervix. This is first twin. It is breech. So I only see first twin. If it is breech, cesarean. If it is kyphlic, first breech is kyphlic, it doesn't matter what is second twin, vaginal. Okay? Yes. Twin pregnancy where one twin is 1 month older. One twin is, there is an age difference of 4 weeks. What is it? Superfetation. अभी आ रहे हैं अभी लेबर पे भी बेटा अरे we'll go to the labor part after lunch and then we'll see at what time ECV is done है ना superfetation. Superfetation matlab one fetus was implanted in the uterus, it was growing. Suddenly mother ovulated in next cycle. Doesn't happen, but suddenly she ovulated. There was already one fetus, another fetus came up in next cycle. Next cycle matlab there will be a difference of 4 weeks. Maybe next to next cycle, difference of 2 months. So fetus above a fetus, superfetation. There was already a fetus, another fetus start growing. Okay, so that is superfetation. What is superfecundation? This is superfecundation. Woman gave birth to twins. Husband says children don't belong to him. DNA shows one child belong to him. So one child belong to him. There is no age difference. This is fecundation. Fecundation matlab she ovulated in the same cycle. Maybe same day she ovulated 2 eggs, or maybe one day and another next day she ovulated 2 eggs. But what happened? These 2 eggs got fertilized by different act of coitus. One coitus happened on Monday, one coitus happened on Tuesday. In the same cycle, there were 2 eggs. But because of different act of coitus, she became pregnant. So it is not twins. Twins may, there is same act of coitus. So many sperms, single act of coitus, fertilizing 2 ovum. Here 2 ovum, but the act of coitus happened on different hours, resulting in heteropaternity, superfecundation. ठीक है? Posthumous child क्या होता है? When the baby is born, once the husband died, woman was already pregnant and baby was born after the death of the husband. So it's more of a legal term. So according to that, posthumous child is he allowed right in father's property? Once the baby is born after the death of the husband, is he allowed? Yes, he is allowed. When if mother has conceived because of that person only, he is allowed. So it's more of a legal term. ये पता होना चाहिए twin में. I hope everyone knows at what day cleavage happen and what do you have to do. ये सबको पता है. I'm not repeating it. I have made so many immense number of reels on that. ठीक है? Does everyone know this? So remember, if the question, so tell me overall, which is the most common variety? Which type of twin is most common? I'm asking overall, which type of twin is most common? Overall, which type of twin is most common? All of you. DCDA. Dichorionic diamniotic, because majority of twins are dizygotic. Majority twins are dizygotic. Dizygotic means two zygotes. Apna chorion, they have their own chorion, their own amnion. Dizygotic means dichorionic diamniotic. This is most common. Some twins are monozygotic. And now monozygotic twins, when have they got cleaved? That will decide the chorionicity. Now, among monozygotic twins, which is most common? Among monozygotic twins, this. Separation on day 4 to 8 is most common separation. So in monozygotic, monochorionic diamniotic is most common, but overall dizygotic diamniotic is most common. Remember, later the cleavage happen. It is very difficult to separate the twins. Earlier the cleavage happen, it is very easy to separate them. Cleavage happen within 1 to 3 days, diamniotic, dichorionic. Cleavage happen after 3 to 8 days. Hello? Huh? Uh-huh. बता दो कि मैम है क्लिनिक पे, बट अभी थोड़ा सा बिजी है, उनसे बोलो कि 2:30 पे आ जाए. Ask them to come at 2:30. हाँ, ठीक है? Okay. Yeah. So cleavage happen at 4 to 8 day. Now they will share the same amnion. Their separation is difficult. So same amnion, but sorry, they share the same chorion. Same chorion, but amnion is different. Separation happen after 8 days, same amnion, same chorion. Separation happen after 13 days, Siamese twins or conjoined twins. It is very important to know the chorionicity using ultrasound. Why? Because monochorionic, where you are sharing the chorion, the complications are more. So I want to know chorionicity using ultrasound. When I see this sign, can you see the base? Always see the base. Can you see the base of the separation is thick? The septum's base is thick. Some tissue is going on inside the septum. It is always dichorionic. So whenever the base of the septum is thick, it is dichorionic. But if what I see here, can you see the base of this septum? It is so thin, no tissue is entering the base. Inverted T sign. No tissue is entering this base. So what is it? It is monochorionic. Okay? So that's how using ultrasound. It is twin peak sign, it is inverted T sign. And when do I check for chorionicity? At 11 to 14 weeks. When I did anti-NB scan, that is the time when I check for chorionicity at 11 to 14 weeks. Okay. Mode of delivery, you should know in twins. Okay. And how the separation and what about chorionicity and amnionicity, that you should know, which is more common. Okay. Coming to obstetric emergencies. Answer this question. Okay. Correct. So she started bleeding profusely, resulting in hysterectomy. Hysterectomy is done again, some new question. But where will I do hysterectomy? In which of these conditions? Do I need to do hysterectomy in placenta previa? No, I remove the placenta, bleeding will stop. Okay, uterine rupture. Uterine rupture may started bleeding profusely during the surgery. Why during the surgery rupture will happen? I can think, no, rupture hota to she should bleed profusely before the surgery. She should come to me with profuse bleeding. Why it will happen during the surgery? So, covalare uterus kya hota hai? Abruption. Covalare uterus, if you will read in Datta also, even Datta has written that you don't need to do hysterectomy in covalare. Once it is delivered, there is risk of PPH, but then you don't need to, you can manage it medically. So covalare uterus maybe you don't need to do hysterectomy. Only place where you end up doing hysterectomy always is eccrita. Eccrita may there is no option of saving the uterus. You can't save the uterus. So this is the answer. ठीक है, we have discussed everything that has been asked in last 5 years, but there are certain questions which have not been asked, but I think which is very important. HIV, whose guidelines have changed a little, but I think you don't know yet. Rh negative guidelines have been updated, and certain obstetrical emergencies. Okay, that I have not mentioned here because there was no question, but I think you should know obstetrical emergencies. So let's have a lunch break. We'll come after that. We'll discuss those points which I feel are important for you, and then we will meet at 2:30. We'll meet at 2:30 and then we'll discuss labor. After labor, we will take a break and we'll finish gynecology. Okay? Okay, everyone. Hi everyone. So we are back. So now we'll be just discussing the important points, important questions. ठीक है? कोई क्वेश्चन आपको पूछना है? कोई डाउट? पक्का? ठीक है, कुछ होगा तो आप कॉल करना। ओके, ठीक है। सो वो टॉपिक चलते हैं तो रिसेंटली अभी नहीं आए हैं, ठीक है, लेकिन अब आपको इनके बारे में कुछ अपडेट्स गाइडलाइंस हैं दैट यू शुड नो, ठीक है। स्टार्टिंग विद आरएच इनकम्पैटिबिलिटी, आई हैव सीन ऑल ऑफ यू हैव नॉट जॉइंड, एनीवेज कोई बात नहीं, एक सेकेंड जस्ट। यस, so RH incompatibility means mother is RH negative and the baby is RH positive. Okay, so when mother is RH negative, baby positive, what happens? The baby's blood goes into the maternal blood, resulting in antibody formation, and as a result, the next pregnancy result in fetal anemia or abortions or uterine death. So there are two things that we have to take care in RH negative pregnancy. One is prevention and one is treatment. Prevention matlab that is there some method through which we can prevent the antibody formation in her body? Now, if there are no antibodies, there will be no alloimmunization, there will be no fetal anemia. So one is prevention, how we can prevent formation of antibodies. So whenever an Rh negative woman comes to us, irrespective of the parity, irrespective of husband's blood group, we do indirect Coombs test. So indirect Coombs test is done at first visit to detect the antibodies in the mother. ठीक है, even if it's first pregnancy we do ICT. ठीक है, once it is negative, I repeat it at 28 weeks. I want to see the antibodies. Suppose antibodies are positive. If antibodies are positive, my prevention will not help. Then I'll go to treatment. That we will discuss later. My prevention will only help if it is ICT negative. If it is ICT negative, then only I can prevent formation of antibodies. How can I prevent? By giving an injection called as anti-D. Anti-D has to be given to her in 3 times. One anti-D is given at 28 weeks. At 28 weeks, if she is ICT negative, I give her anti-D. Another anti-D I give her when she has just delivered. So as soon as she delivers, I do the blood group check of the baby. If the baby's blood group is positive and baby is DCT negative, matlab baby has not formed antibodies, I'll give another injection of anti-D. One more time anti-D can be given if she faces any sensitizing event during pregnancy. So if during pregnancy any sensitizing event happen, then also I have to give anti-D. Now comes the doses. What is the dose? Any injection of anti-D that is given at less than 20 weeks, 150 mcg dosage. Injection of anti-D given after 20 weeks means at 28 pay, at delivery, sensitizing event happening after 20 weeks, the dose is double. Now the 50 mcg dosage has been removed. Okay, so this is Foxy guideline 2022. Okay, so they have updated it. I have even shared a picture on the group. So if sensitizing event happen at less than 20 weeks, dosage is 150 mcg. If it happens after 20 weeks, the dosage is 300 mcg. Now don't mention 50 mcg anywhere. What are the sensitizing events? Any abortion, any threatened abortion, ectopic, molar, chorionic villus sampling. Any of these procedures is a sensitizing event. Okay? That in that case, in these early sensitizing event, the dosage will be 150 mcg. And these late sensitizing event, like external kyphlic version is a sensitizing event, amniocentesis is a sensitizing event. Since they happen after 20 weeks, the dosage is 300 mcg. The dosage that I give at delivery is 300 mcg. It has to be given within 72 hours. And the rule is that baby should be DCT negative and baby's blood group obviously should be positive. Then only I give this prevention. If mother is already ICT positive, means she has formed the antibodies. Now prevention will not help. I have to treat this patient. She has formed antibodies. Now I have to take care that the baby should not develop anemia. So I'll start doing the titer of the antibodies. Titer of antibodies is done every 4 weeks. And once it has crossed the threshold is 1:16. Once the antibody titer has crossed the threshold, it means now it can pass to the baby and cause anemia. Now it is significant. So now I want to know whether baby is developing anemia or not. So there are two ways of knowing whether baby is developing anemia or not. One is ultrasound for checking for ascites, hydrops. Another is middle cerebral artery. Whenever there is fetal anemia, middle cerebral artery blood flow increase. Blood flow to the brain increase. So that brain doesn't become hypoxic. So there is increase in peak systolic velocity of middle cerebral artery. So I'll keep on repeating ultrasound every 2 weeks to check for fetal anemia. And if fetal anemia develops, in case the baby is 34 weeks, I will deliver. Otherwise, I will lose the baby. If baby is less than 34 weeks, I'll do intrauterine blood transfusion. So intrauterine blood transfusion is done only when I see the signs of fetal anemia on ultrasound. Ultrasound is done only when the antibodies cross the threshold. And titer is done only when patient is ICT positive. Okay? So this is the prevention and treatment of anemia. Another thing which I want to know is in case of, so these are now random things. So these are random things which I just wanted you to mention here. One is that in case a heart disease or a hypertensive patient becomes pregnant, there are certain drugs which you have to avoid, which you have to stop immediately. So as soon as a heart disease patient becomes pregnant, you stop warfarin, you stop ACE inhibitors, you stop AT antagonists because they can cause renal agenesis. Then you stop aldosterone antagonists. Aldosterone antagonists are given in hypertension like spironolactone. They can lead to feminization of male fetus. So they are also stopped. Thiazide diuretics and anti-arrhythmics like amiodarone that can lead to hypothyroidism. All these have to be stopped. So these drugs, if a woman becomes antihypertensive, if a hypertensive woman becomes pregnant, remember this list of drugs that has to be stopped in that woman. Okay? There is a question on 2022. A female patient on antihypertensive come for preconception counseling. Which of the drugs will you stop? Which of the drugs will you stop? Tell me the answer. Which drugs will you stop in this patient? Lisinopril. Okay? You'll stop ACE inhibitors. Okay? Methyl dopa, atenolol, difidipine, they all are used in hypertension in pregnancy. A little bit about HIV in pregnancy. HIV testing is universal. It is done in every pregnant woman at first visit, but remember it's an opt-out technique. She can very well refuse for the testing. The screening test is ELISA and the confirmation is using Western blot. Whom to treat? Since 2017, NACO is following the guideline of treat all, everyone, irrespective of CD4 count. Pehle, the guideline was that if CD4 count is less than 350, then only you treat. But now it is treat all. Everyone who is HIV positive has to be treated. And the drugs which are used now are TLD. Previously, it was TLE. Now, efavirenz has been removed. What is there? Tenofovir, lamivudine, dolutegravir. So TLD is the regime that has to be used in all HIV patients. Okay? And who's to be treated? Everyone. There are certain steps for preventing mother to child transmission. As such, without anything, the transmission is 30%. But when you start ART in this mother, the transmission risk is 2%. So what are the steps for preventing MTCT? You have to start ART in all the HIV positive mothers. LSCS. Do we do LSCS for preventing HIV transmission? No. Doing LSCS for HIV transmission is not allowed. Delayed cord clamping. In HIV positive, please tell me, should we do early cord clamping or delayed cord clamping in HIV positive patient? So delayed cord clamping is the norm now. Everyone has to go delayed cord clamping to prevent fetal anemia, even an HIV positive person. So even in HIV positive, delayed cord clamping is done. Indication for early cord clamping is only one, and that is when the baby need resuscitation. When your baby is hypoxic, need resuscitation, then you immediately clamp the cord, give the baby to pediatrician. Other than that, preterm, hepatitis B, C, HIV, RH negative, diabetic, sub में delayed cord clamping. Just remember that. Okay? And that has been specially given in NACO guidelines, delayed cord clamping. Breastfeeding, woman is allowed to breastfeed, and in fact, woman is encouraged for exclusive breastfeed. If she's not ready for exclusive breastfeed, ask her to give exclusive top feed. Mixed feeding is not given. What is preferable? Exclusive breastfeed. Important thing is viral load. In all the HIV positive mother, we do a viral load at 32 to 34. Why do we do viral load? We are giving ART in everyone. Why do we do viral load? We do viral load to see what to give to the neonate. The neonate that is born, immediately after birth, we start the prophylaxis. इसे हम कहते हैं post exposure prophylaxis. Exposed तो baby has been. No, baby has been exposed. So we give post exposure prophylaxis. But what will we give will be decided by this viral load. So if viral load in the mother was less than 1000, it means it's a low risk baby. You give either nevirapine or zidovudine syrup, any one of them. But if the viral load we did at 32, 34 was more than 1000, it's a high risk baby. You give two syrups, nevirapine and zidovudine both. If the baby is breastfeeding, give it for 12 weeks. If baby is not breastfeeding, give it for 6 weeks. But all the HIV positive mothers' baby are given some kind of post-exposure prophylaxis. If it's a low-risk baby, either nevirapine or zidovudine. If it's a high-risk baby, depending on the viral load of mother, both the syrups are given. Okay? And these are not very new guidelines. I don't know why they have not been updated everywhere. These are NACO 2017 guidelines. 2017 or 2020, but not very new. Okay? So everything is from that NACO guidelines. Done? A little bit about obstetric emergencies. Obstetric emergencies are extremely important. They can be anytime asked. Does everyone know the management of shoulder dystocia? What is the definition? Head comes, shoulder doesn't follow even after 1 minute. This is the definition. Okay? What are the steps of shoulder dystocia? Can somebody tell me the first step for shoulder dystocia management? Correct. But usse pehle bhi, you just make a gentle traction, axial traction. Before starting any procedure, you just try one axial traction. You give axial traction, and now when the baby is not coming, now you start your maneuvers. Remember, it's an axial traction in the axis of baby. Lateral traction like that is not given. Otherwise, there will be brachial plexus injury. So it is always axial traction, first step. Now, next step is Mac Roberts. Mac Roberts means you sharply flex the thigh. Okay? And correct, Mac Roberts and suprapubic are done together. The same person who is giving Mac Roberts will give suprapubic. But still, if the question asks which is done before, Mac Roberts should be your answer. But as such, all the books say Mac Roberts and suprapubic. They mentioned it together. Okay? Mac Roberts and suprapubic pressure are given. Gaskin maneuver, though it is not done next, Gaskin is a maternal maneuver. All these maneuvers are maternal maneuvers, where you are manipulating the mother. So Gaskin is all four position, though it is not done after suprapubic pressure. After suprapubic pressure, we straight away go to the internal maneuvers. Internal maneuvers where you enlarge the episiotomy and you insert your hand inside, and now you manipulate the baby. First, anterior shoulder is stuck, bring the posterior out, sweeping out of posterior shoulder. Okay, sweep out the posterior shoulder. Not working. Then rotational maneuver, rotate the baby. One is Rubin's maneuver. This is Rubin's 2 maneuver. In Rubin's 2, you put pressure on the dorsal aspect of shoulder here. If you push the baby like this, what will happen? This biacromial diameter will reduce. So you put the pressure on the dorsal aspect and you try to reduce the biacromial diameter. This is Rubin's 2 maneuver. In case Rubin's 2 doesn't work, you, along with pushing from here, you add Wood's maneuver. Here, in Wood's maneuver, you put the pressure on the ventral aspect here. And now you try to rotate the baby. You try to rotate the baby in the diagonal plane. Abhi, shoulders are stuck in AP plane. You try to rotate it. Once you try to rotate it, they come in a bigger plane and they will come out. So this is Rubens and next is Wood's corkscrew. This is Rubens, and when you're applying from this is Wood's corkscrew. Wood's corkscrew is generally done along with Rubens. You manipulate both the shoulders to rotate it in diagonal plane. Okay? If this is Rubens 2, what is Rubens 1? What is Rubens 1 maneuver if this is Rubens 2? This is Rubens 1. Not very famous by this name, but this is the first maneuver given by Rubens, Rubens 1. And this is Rubens 2. Now, if even rotational maneuvers fail, now it is quite late. You deliberately fracture the clavicle cord as clidotomy. You do clidotomy, the diameter reduce. And last is Zavanelli. You push the fetal head inside and you take the baby out using cesarean. This is Zavanelli procedure. Okay? You have in shoulder dystocia, your aim is to deliver the baby within 5 minutes. If you want to prevent hypoxia, you deliver within 5 minutes. Okay? Steps याद हो गए सबको? Clear? Is everyone clear? Please, if there is any problem in anything, any doubt, please ask. Everyone is asking for recordings. I just want everyone to join live, but I don't know why people are not joining live. Okay. Cord prolapse. What is cord prolapse? When the cord has come out besides the head. When the cord has come out besides the head, it is cord prolapse. When the cord is lying, when the cord has come after the head, it is cord prolapse. When the cord has not come out, but it is just lying and covered by the fetal membranes. They're covered by the fetal membranes. As the membranes will rupture, they will come out. It is cord presentation. And cord presentation looks like bag of worms. When you do the PV, you feel worms like something on PV. So whenever question gives you bag of worms, it is cord presentation. Okay? And cord prolapse is when the membranes have ruptured and the cord has come out. That is overt cord prolapse. Okay? How to avoid cord prolapse? Remember, whenever there is cord presentation, means the membranes have not ruptured. Whenever there is cord presentation, avoid the rupturing of membrane and always go for cesarean. Because if you rupture the membrane, cord will come out. And once the cord come out, the vasospasm is so bad, you lose the baby within minutes. I've seen that myself. I mean, you don't get the time even to take consent and shift to OT. There is so severe vasospasm, baby, you will lose the baby. Okay? So how to prevent cord prolapse? That if you are feeling cord presentation, if you are feeling bag of worm, take the patient for cesarean. Don't let her go in labor. See this question. Woman in labor at 39 weeks, cervix phase 3 centimeter dilated, bag of worms felt. What is the next step? If I'm feeling the bag of worm, I am not waiting for spontaneous. I will definitely not rupture the membranes. I will do immediate cesarean. Otherwise, cord will completely prolapse. There will be spasm. I will lose the baby. Okay? Management of cord prolapse. Now, once the cord has come out, what will I do? Only one thing, deliver. As soon as possible, deliver. So the treatment of cord prolapse is deliver. If she's in second stage of labor, put an instrument, deliver. If she's in early stage, do cesarean. So the only treatment for cord prolapse is deliver as soon as possible. So do the PV. As you see cord prolapse, do the PV, see the stage of labor and prepare for delivery. That is the only thing. One question that can be asked is, while you are preparing her or while you are shifting her to OT, while you are preparing her for delivery, you can do something to prevent the cord compression. Cord compression कैसे हो रहा है? ये pelvic, this is the pelvic wall, this is the fetal head. Cord has come from somewhere above and is coming out here. Now cord is getting compressed between fetal head and the pelvis. So meanwhile, when you are trying to deliver, can I just avoid this compression? That is the main cause of hypoxia. Yes. One is push the fetal head above. You never touch the cord. You never touch. As soon as you will touch, the cord will prolapse. Cord has never felt touch. Never. So as it is something new thing will touch it, it will cause further vasospasm. So never touch the cord. Push the fetal head above. Or Another way is Vago's method. Fill the patient's bladder with saline. Once you fill the bladder with saline, head will be pushed out of the pelvis. Bladder will push the head above. So either manually push the head or using Vago's method. One thing you can do, put the patient in Trendelenburg position or knee chest position. By doing this, again, the compression on the cord will be relieved. But the main treatment is deliver. And you never push the cord above. You never touch the cord. You push the fetal head, but never the cord. Okay? Okay? Uterine inversion. I know these steps you have known. If there is anything controversial, if there is anything you have read which is different, please let me know. Okay, if you have also read the same steps, the same management, then we can continue. Third is inversion. It means uterus come inside out. This uterus was here after third stage of delivery. You were pushing the placenta. This was placenta. You were pulling the placenta. The uterus has come out. Inside out. The inside surface has come out. That is uterine inversion. See how the question will give you inversion? Immediately after delivery, patient starts bleeding. But with little bleeding, she has gone into shock. So shock is much more significant compared to bleeding. And on examination, uterus is not felt. Why not felt? It has come out. On local examination, a shaggy mass is seen. This is how it presents. What is the management of uterine inversion? Who can tell me? What is the management of uterine? As soon as you see uterine inversion, you call for help. What is your next step? Once you have seen uterine inversion, what is your next step? Perfect. Stop oxytocin. Next. Oxytocin stopped. Okay, I have stopped oxytocin. What will I do next? Should I remove the placenta? Because generally when inversion happens, placenta is attached. Should I remove the placenta? So you are instructing me. I'm asking you, should I remove the placenta? Should I remove the placenta before replacement? So I'm not supposed to remove placenta. I have to replace it. So should I, ma'am, shift the patient to OT, or will you be pushing the inverted uterus in the labor room? Should I first shift to OT or should I do it in the labor room? Everyone please answer. If I'm asking you, ma'am, what should I do? Will you do Johnson's maneuver here, or should I shift it to OT? So uterus is inverted like this. She is in neurogenic shock. You will shift to OT. You will lose the patient. You manage the inversion at the place of inversion. If inversion has happened at home, you do the Johnson's at the home. You don't need any instrument. Wear gloves, push it. You never shift to OT first. You stop oxytocin. No, it's not controversial. No. I can show you the guideline. Absolutely not. The question was directly from Foxy 2023. Foxy is Indian Guidelines, Federation of Obs-Gynae Society of India. These are the people who actually make the question papers for NEETPG. So these are those big biggies of Obs and Gynae who make the guidelines and who make the paper for you. So Foxy ne 2023 May, they released the guideline for uterine inversion. And that year only the question was asked exactly the same steps. Now I'll show you what is written in the guideline. This is written in the guideline exactly. Restore circulation, put cannula, do not remove placenta, reposit uterus immediately in labor room itself. See, in my practice, if I will encounter, maybe, though I have not done that, when I faced inversion, I did it in the labor room. Itself, I have done that. Maybe somebody would be more comfortable doing it in OT. That's okay. But it doesn't matter. You have to know what the guidelines say. So guidelines में clearly लिखा है reposit immediately in the labor room itself. And I will post that screenshot of the guideline also to you. Okay? Not to prove that I'm right, but so that there is no controversy in your mind. So that you are clear. Then what the guideline has written? Shift the patient to operation theatre for reposition under general anesthesia if it fails in labor room. This is the line which they have written. You will shift once it fails in the labor room. Okay. So remember, these people are making the paper for you. They will be checking it. And so we have to follow what guidelines they have given. Okay. So reposit it in the labor room and there is absolutely no controversy. Bache. How will I reduce? Using either Johnson method, using hand, Johnson method. Okay. And or using O'Sullivan method. When there is no complete inversion, there is only notching. I can use saline, put it at a height of around 1 meter, and then I forcefully let the saline flow. So this is O'Sullivan method. I shift to OT only when I'm not able to manage it in labor room. Okay. PPH. Question: 25-year-old female giving birth to a child. Please read the question and tell me. Patient ko you have to do devascularization. What is the step of devascularization? Which vessels will you devascularize? NEET 2020 question. Which vessels will you like to devascularize? I will devascularize the vessels which supply the uterus. Everything in the pelvis is arising from internal iliac. I will devascularize that. Then I will devascularize the main branch supplying the uterus, uterine artery. Another branch that is giving some branches to uterus, ovarian artery. So this I will ligate. Uterine artery, ovarian artery and internal iliac artery. Okay? Obturator artery is the posterior division of internal iliac artery. Okay, so what I ligate is basically anterior division of internal iliac. Posterior division is basically supplying the नहीं, posterior division का नहीं है. No, obturator artery is also from anterior division of internal iliac artery, but obturator artery is directly not supplying to the uterus or ovaries. So that is why ligating obturator artery is not going to help. Okay. A little bit about PPH. What should you know about PPH? PPH can be of two types. Primary PPH that happens within 24 hours. Secondary PPH is the one that happens within 12 weeks. From 24 hours to 12 weeks, we call it secondary PPH. Now, whenever PPH happens, your first step is start uterotonics. The uterotonic of choice for PPH is oxytocin IV. That is the uterotonic of choice. Very safe drug. Can it be used in asthma? Yes. Only side effect that can happen with oxytocin is water intoxication. If given in excess dose, it can act like vasopressin. Okay, because both are secreted from posterior pituitary. So in excess, it can lead to water intoxication. Otherwise, it's a very safe drug for asthma patient also. If oxytocin is not working, I will give ergot alkaloids, ergometrin. The dose is 0.2 milligram IM. Maximum I can give 5 doses. Very strong uterine contractor, but cannot be given in heart disease, hypertension, asthma, because it's a very strong vasoconstrictor. Rh negative, I can't use this. Next drug that I have to use is carboprost. So if ergometrin is not working, I'll go to carboprost. Prostaglandin F2 alpha. The dose is 0.25 milligram. Maximum I can give 8 doses. A very good drug, but cannot be given in asthma and heart disease. So in asthma, which drug I can give? Oxytocin. Another safe drug which can be given in asthma is misoprost. But misoprost is a slow acting drug. But good thing is that misoprost is very cost effective and it does not need refrigeration. Like oxytocin, carboprost, it does not need refrigeration. So because of long shelf life, very good for use in periphery. What is the dose of misoprost for treatment of treatment of PPH? 800 mcg sublingual. For prophylaxis, when I'm using it in active management of third stage of labor, for prophylaxis, the dose is 600 mcg oral. So for prophylaxis, 600 mcg oral. For treatment, increase the dose, 800 mcg. Change the route, sublingual. Okay. A new analog of oxytocin, long-acting analog has come, which is carbetocin. Carbetocin right now not used for treatment, only used for prevention. It is used either IM or IV. It is a long-acting analog. Okay, so these are the drugs, uterotonics, that has to be used in PPH. PPH में FIGO ने, they have given some care bundles. This is first response bundle. As soon as you see PPH, the first response bundle is 4. Give drugs immediately, start massage, give tranexamic acid, and give crystalloids. So first response bundle is 4, all are done together. Start fluid, give oxytocin, start massage, start trenexa. This is first response bundle. If the patient is refractory to this first response bundle, I go to second step, जिसमें आता है balloon tamponade. See the image, you can be asked an image based question. Using Bakri balloon or Seng's taken black or Foley catheter, I will inflate it with at least 500 ml saline. 500 होना चाहिए, तभी it will stop the bleeding. If you will inflate it with only 200, 300, it will not help. So inflate it with 500 ml saline, and then it will provide tamponade to the uterus. So this is intrauterine balloon tamponade. Meanwhile, suppose patient does not respond to this also. It is a conservative method. Patient doesn't respond. I will take the patient to surgery. Now this patient has bled enough, I'll take the patient to surgery. Meanwhile, when I'm taking the patient to surgery, I'll use some temporizing measures. इन्हें कहते हैं temporary measures. Temporary measures are done just to prevent excess blood loss through the pelvis. We just want the blood to stay towards vital organs. So temporizing measures are not the treatment. They are done temporarily till you are shifting the patient to surgery. ठीक है? Temporizing measures are bimanual uterine compression, aortic compression, non-pneumatic anti-shock garment. What are the temporizing measures? Bimanual uterine compression, aortic compression, non-pneumatic anti-shock garment. By temporizing measure, I have given some life to this patient. Now I'll take her for surgery. So all these form refractory PPH bundle. First PPH bundle क्या था? What was first? नहीं बेटा, bimanual compression is done when your patient has not responded to uterotonics. Patient has not responded to uterotonics, I will do balloon tamponade. Patient has not responded to balloon tamponade, still bleeding, I'll take the patient for surgery. Okay? While I'm taking the surgery, that time I'm doing on the way some temporizing measures. Temporizing measure is not a treatment. It has no competition with oxytocin. Temporizing measures done meanwhile is bimanual compression, aortic compression, and anti-shock garment. I'm just trying that blood should stay towards the vital organ for a while. What is first response bundle? What have you written? Okay, uterotonics, crystalloid, tranexamic, perfect. This is first response bundle. What is refractory bundle? Balloon tamponade, aortic compression या bimanual compression, and non-pneumatic anti-shock garment. These are the refractory PPH bundle when it has not responded to your uterotonics. And finally, you take the patient for surgery. These are compression sutures, B. Lynch, Heyman, Chow sutures, compression sutures. Selective vessel ligation that we have just read, where we ligate 3 vessels: uterine artery, ovarian artery, internal iliac artery. इसे कहते हैं selective vessel ligation. ठीक है? We are ligating the anterior division of internal iliac. Once the posterior division has been crossed, then we ligate only the anterior division of internal iliac. Okay? Third, one step, in case your hospital has this facility, you do uterine artery embolization. We inject certain embolizing particles into the femoral artery. We make a incision at inguinal area. It's not a surgery. It is basically a non-surgical procedure where through inguinal area, you inject embolizing particles, enter the external iliac, internal iliac, and uterine artery. ठीक है? इसे कहते हैं uterine artery embolization. This is how you manage PPH. Now we finally come to labor. We'll finish labor in an hour and then we'll take a break and start with gynae. Okay? Let me have some water, please. Okay, labor. Identify the yellow colored plane in the image. Tell me what is the answer? What is this yellow colored plane? Even if you are seeing it for the first time, it is not a question that should be left. Just guess what it can be. Those who know good, those who don't know, just make a guess. Can it yellow zone be a pelvic inlet? It doesn't seem to be. Inlet should be somewhere here, right? It doesn't. It can be outlet. So outlet I know is from lower border of the cervix, from the pubic symphysis to tip of coccyx. And one is to the, so obstetrical outlet is till the tip of sacrum. Anatomical outlet is till the tip of the coccyx. So it doesn't seem like this yellow zone doesn't seem like outlet. So obviously it is zone of mid pelvis. So even if I have not seen it, I can see it is somewhere lying in the mid pelvis and it is a whole area. It is looking like a zone lying in mid pelvis. So it is zone of mid pelvis. It is not outlet. Outlet will be from lower border to tip of sacrum or to the tip of coccyx. So it is zone of mid pelvis. You can divide pelvis into you can see the pelvis like a house. Now this house has a door. This door is a plane. It's a two-dimensional plane. This door is from anterior upper border of pubic symphysis to the sacral promontory. And this door is inlet. Now this has a wall, a small wall. Is a plane of least pelvic dimension. And another one is there is another door is anatomical outlet. So it's a house. From superior border of pubic symphysis to sacral promontory, from inferior border of pubic symphysis to the coccyx, plane of least pelvic dimension is from midpoint of pubic symphysis to S4, S5. And it is a very small one. It is still S4, S5. Now these planes, have divided the house into rooms, two rooms. This room is called as cavity, mid cavity. And this room is called as obstetrical outlet. So there are three planes and there are two rooms, cavity and obstetrical outlet. Now this room is huge. It is a huge room. How I can tell you it is a huge room? There is a plane running from this within this room. Now this plane is just to tell you how big it is. This plane is running from posterior border of pubic symphysis to S2, S3. The purpose of this plane is to tell you how wide the cavity is. This plane is plane of greatest pelvic dimension. So plane of greatest pelvic dimension is lying in the cavity. So what you are seeing is, what the yellow colored area you are seeing is this one. Cavity or mid pelvis. You are seeing a zone of mid cavity. So if somebody asks what is this green plane? This green plane from lower border of pubic symphysis to almost tip of sacrum, that is obstetrical outlet. What is this plane? This is inlet. What is this plane? This huge plane in between? Dekho, I'm not able to make a straight line also. Yes, this plane running to S2, S3, this is the plane of greatest pelvic dimension. So this has three planes, four planes in fact, and two rooms. Okay. Question. Primary gravida, present to labor room. She has been in labor for 3 hours. Which among the following would determine she's in active labor? It means we just need to know what are the stages of labor that we should know by heart. How will I know she's in active labor? Yes, when her cervix is 5 centimeter. Membranes might be ruptured, might not be. Contractions should be more in active phase. In active phase, contractions are 4 to 5. Head might be palpable, might not be. We don't know, but this is the definition. So we know the stages of labor. First stage is from pain to full dilatation, which is 10 centimeter. इसमें भी latent phase क्या होता है? What is latent phase is up till 5 centimeter. And active phase is from 5 to 10. Second stage is full dilatation to delivery of the baby. And third stage is from delivery of the baby to the delivery of placenta. Okay? That we know. Only thing you have to know in labor mainly is management of second stage and third stage. Management of first stage should also be known to you. Management of first stage is very conservative. Latent phase में याद रखना, remember whenever the patient is in latent phase, it should be always a conservative management. ठीक है? You basically, you can even send the patient home. If the latent phase is prolonged, the answer is always do nothing. It is latent phase. The uterus and cervix are preparing. Do nothing if she is only 2 centimeter or 1 centimeter or 3 centimeter dilated. She is in long latent phase, don't worry. Never answer cesarean, never answer ARM in latent phase. She will herself enter into active phase. Active phase is something where now patient is actively dilating. This is the phase when the progress of labor start, active phase. This is the phase where we start the plotting on Partogram. And here, if it is prolonged, here, if it is slow, we don't do conservative. We manage. We'll see, seeing the Partogram, how do we manage? But this is the phase where we plot on the Partogram and we manage the prolonged phase. Latent phase, we do not plot on Partogram. We do not manage unless baby and mother are doing fine. Okay. Next comes the management of second stage of labor. Second stage of labor management has been given by WHO. So that is why it is extremely important to know. Yeah. Second stage management steps आपको पता होना चाहिए. Given by WHO Labor Care Guide. Position of mother choice. Not lithotomy, mother choice. Fetal heart monitoring in second stage. 15 minutes in low risk, every 5 minutes in high risk. Fetal heart monitoring in first stage. 30 minutes in low risk, 15 minutes in high risk. ठीक है? Pushing. You ask mother to push only when she is fully dilated. You ask her to push only when she has urge to push, and she has to push only when there is contraction coming. So pushing may there are three things: urge to push, with contraction, and when she is fully dilated. Episiotomy is always restrictive. It is given only when needed. It is not a universal episiotomy. WHO has given 3 steps to prevent the perineal trauma. 3 steps. Does anybody know 3 steps given by WHO to prevent perineal trauma? Does anyone know 3 steps given by WHO to write down one step if you know? No? Correct. Warm towel. जिसे हम कहते हैं applying warm compresses. Correct. Massage. Perfect. Perineal massage and warm compresses. Third, very important. During delivery, what do you do so that perineal trauma doesn't happen? Correct. Perfect. Hands-on technique. Very good. Hands-on, you put one hand on the perineum, with other you flex the head. Remember, the aim of hands-on is to flex the head. Flexed head has the smallest diameter, isn't it? Extended head has a larger diameter. So the aim of hands-on is to flex the head, not deflex. Once it flex, the trauma is minimum. Then apply warm cloth, okay, and do perineal massage. Perineal massage is even started in the 3rd trimester. Okay? Fundal pressure. Now, fundal pressure is never given. If you have seen anywhere in your labor room, a person a person just onto the patient, pushing the fundus, that is absolute no. Fundal pressure is not to be given. Okay? About episiotomy, when do we give episiotomy? At the time of crowning. Where it is given, so we give medial or mediolateral. We give mediolateral episiotomy at an angle of 60 degree. Okay? Important is Why do we give mediolateral? Because we want to prevent the anal sphincter injury. That's what we want to prevent. Okay. What are the muscles that are cut in episiotomy? Now, these are the questions which have not been asked in last 5 years, but these are among the favorite questions. So that is why I'm covering them right now. Urethra, vagina, rectum. Okay. Now, let's see the muscles. Covering the vagina like a bulb, bulbocavernous. Okay. Far away here, ischio-cavernous. Okay, near the ischial bone. Here, transverse perineum, superficial and deep. Okay. Then let's color the sphincters. Anal sphincter, urethral sphincter. In between filling the whole area, levator ani muscle, a little above levator ani muscle. Now let's see what muscles are we cutting. When I'm giving an episiotomy, what muscles am I cutting? Okay, levator ani and what else? So when I'm giving an episiotomy at an angle like this, what I'm cutting? I am cutting bulbocavernous. I am cutting superficial and deep transverse perineum. I am cutting levator ani. I am not at all touching the sphincter, anal or urethral. I am not touching the ischio-cavernous. So I am cutting bulbocavernous, superficial and deep transverse perineum, and I am cutting the levator ani. These are the muscles cut in episiotomy. Okay. So this was second stage of labor. Third stage of labor, active management of third stage of labor. AMTSL, that is active management of third stage of labor, was given by WHO in 2018 with sole purpose of preventing PPH. The sole purpose was to preventing PPH. We don't want PPH to happen, which is so common in our country. So AMTSL has 3 steps arranged importance wise. Okay, they have arranged these steps importance wise. First, foremost, uterotonic. Uterotonic given immediately after baby birth. Okay, what do we give? We give oxytocin. Oxytocin doesn't work. We can give methergine, misoprost, and carboprost. We can give anything. But oxytocin 10 units IM is the drug of choice in AMTSL. Okay. Second step, controlled cord traction. Third step, uterine, not exactly massage, uterine tone assessment. These are the 3 steps given by WHO at AMTSL. Cord clamping is done, delayed cord clamping is done in everyone, but they are not part of AMTSL. AMTSL is only for PPH. You're clamping the cord early or late, what it has to do with PPH? It has to do with fetal anemia. It has nothing to do with PPH. So remember, delayed cord clamping is done in everyone in third stage of labor, but it is not part of active management of third stage. एक्टिव मैनेजमेंट में 3 स्टेप्स है, यूट्रोटोनिक, कंट्रोल कॉर्ड ट्रैक्शन, यूट्राइन टोन असेसमेंट. So you do all 3 steps of active management and you do delayed cord clamping in everyone except when your baby needs resuscitation. When your baby needs immediate resuscitation, that is the only indication for early cord clamping. HIV, TB, anything, delayed cord clamping. ठीक है. Okay, everyone. Do this question. While giving traction to the structure, this structure got torn. Which among the following the most appropriate step? See, all of them are appropriate. Even in RH negative, you do delayed cord clamping. In RH also, early cord clamping is not given, not done. Early cord clamping has only one indication, that is maternal fetal distress. If mother is in severe distress, will you deliver her vaginally? And see, this is little, mother is in severe distress, it has nothing to do with the baby. Okay, if mother is in severe distress, how distressed? Matlab, what do you want to say about distress? Mother is in shock, then you are already resuscitating the baby, resuscitating the mother. By not doing delayed cord clamping, it doesn't matter. है ना, मदर के डिस्ट्रेस का कॉर्ड क्लैंपिंग से कोई मतलब नहीं है. मदर इज स्टिल बीइंग रिससिटेटेड एंड मदर डिस्ट्रेस्ड इन शॉक getting delivered vaginally, it's a very imaginary scenario. So why to talk about scenarios which just don't exist? Mother in shock, you are doing vaginal delivery or you are doing cesarean, very a little impractical scenario, right? So there will we do early or delayed? I think it's not, it's a little impractical kind of a scenario. And even if asked, I think I will still write delayed cord clamping. Okay. So now what is this? Yes, manual removal. So once the cord has got torn, I'll do manual removal of placenta. I will give oxytocin. Uterine massage is also done, but they have asked the most appropriate. You have to remove the placenta using manual removal of placenta. Now, abnormal fetal lie and presentation. Usme se hai yes. Gravida 2 para 1 previous history of classical cesarean. जो भी important point मिलता है market. No complaint, low dose aspirin पे है, single life breach. What would be the next step in the management? She's already 35 weeks. What will be the management in this patient? She's breached 35 weeks, previous classical cesarean. What will you do next in her? So I will not do external Kiflic version in this patient. I'm not going to do external Kiflic version. She's breached. Why am I not doing external Kiflic version? Why am I not doing ECV in this patient? Yes, because it's a classical cesarean. She cannot deliver vaginally anyhow. Why will I do ECV? It means in case question has not given you classical cesarean, question has given you placenta previa with breach. Still, I will not do ECV. I can't deliver her. So anything which question has given you, she has got primary herpes and she's breech. Will you do external Kiflic version? If I cannot deliver vaginally, why will I do ECV? ECV का purpose क्या है? Bring her to Kiflic, deliver vaginally. I can't deliver vaginally. So I will schedule the cesarean. Okay? So coming to abnormal fetal lie and presentations. See, abnormal fetal lie presentations, you should know about breech, you should know about transverse, and you should know about basically occipito-posterior. So breech baby is, generally, how will you know the baby is breech? The lie is longitudinal. In first grip, in first fundal grip, you feel a hard, broad mass, hard, regular mass. And in your polyp grip, you feel something very soft, non-benoutable. That's how you know it is breech. Okay? So whenever there is breech, unless there is any contraindication, you always try the external Kiflic version first. External Kiflic version is always done after 36 to 37 weeks. When the baby is almost mature, then you do external Kiflic version. Why? Two reasons. If you do external Kiflic version in a premature, it will revert. Second, sometimes while doing ECV, what happened? The membranes rupture or the patient start bleeding and you end up doing cesarean. So you only do ECV when the baby is almost mature, so that even if membranes rupture, you have got a mature baby. And once you do it at 37 weeks, the chances of reversion are less. So in all the breach, you always try external Kiflic version unless there are some contraindications, like we just read, classical cesarean hai, placenta previa hai, or RH negative pregnancy hai, where if we'll do external Kiflic version, sensitization might happen. ठीक है, abruption है, severe preeclampsia hai, severe preeclampsia, and we are doing version, abruption will happen. In all these, I will not do. I'll do only when everything is normal. If version has been successful, good. If version has not been successful, what I do is trial of breech delivery. Okay? I always let this baby deliver vaginally. I'll rule out contraindications. I always let it deliver vaginally. इसको हम कहते हैं assisted breech delivery. And I'll show you all the images of assisted breech delivery. Assisted breech delivery matlab, we are assisting at every step for the baby to deliver. This is called as assisted breech delivery. What about transverse lie? Just like breech, I will try external kyphelic version at around 36 to 37 weeks. Why not here? Here also, if there is no contraindication. If version is successful, good. If not, I have to do cesarean. There is no option. I can't deliver it vaginally. Okay? Transverse lie, how it feels on abdomen. The transverse lie abdomen is unusually broad. The fundal height is extremely small. My first grip and my third grip are empty. That's how question will give you. Broad abdomen, first and third grip empty. That is transverse lie. On PV, you feel the ribs. You call it gridiron feel. Gridiron, pata hai, that those windows where iron bars are there. So that's a gridiron feel of transverse lie. Okay? So when you are doing external kyphelic version, it is a difficult procedure. It's not easy. You should only give 3 attempts. If you have not been successful in 3 attempts, then you leave it. Okay? Occipito-posterior. First of all, which pelvis result in persistent occipito-posterior position? So even if occiput is entering posterior, generally it rotates. But there is a pelvis which does not allow rotation and it ends up in being persistent occipito. Array? Anthropoid, bitu. Anthropoid. Not android. Anthropoid pelvis is the one which results in persistent OP. Okay? Android is next common. So anthropoid pelvis ki wajah se there happens occipito-posterior position. And the baby is not able to rotate, resulting in stuck in persistent occipito-posterior. How does abdomen look like? Whenever there is occiput posterior. See, occiput is such a, what I can say, such a elevated part of the head. So when occiput is anterior, the head looks a very uniformly enlarged. The patient is like that, the abdomen is like that. But when occiput is posterior, this part, which is a flat part, which is facing anteriorly, there will be infra-abdominal flattening like this. Infraumbilical flattening is seen in when the occiput is posterior and this flat part is anterior. Okay, so if I am the fetus, I am lying this face anterior. Obviously, there is flatness. If this part is anterior, there will be smoothness. It will be curved. So how do you manage occipito-posterior? Either you let it deliver, it will take long rotation, it will deliver. If not, either using forceps or using vacuum or using a manual rotation, you can rotate the fetus. You can rotate the head and deliver. Android की आपने बात की, android pelvis is a pelvis where the cavity is narrow. Head gets engaged, but it gets stuck in the cavity. If you know deep transverse arrest, in the cavity at level of ischial spine, the head is stuck in transverse diameter. It is not able to rotate because android pelvis mein cavity is narrow. So deep transverse arrest happen in android pelvis. And generally when deep transverse arrest happen, you end up doing cesarean because it is at level of ischial spine. At level of ischial spine, I can't apply instruments. So I have to deliver via cesarean. What I'm telling you right now, question has been asked on every segment. Abdominal look, how to deliver DTA, how to deliver occipito-posterior, everything question has been asked. Okay? In recent or in past, question has been asked. 32-year-old pregnant female with infraumbilical flattening, fetal heart heard in flank. What is it? It is occipito-posterior. Occipito-posterior ko hum, how do we else describe? The another name is face to pubes delivery. When occiput delivers as posterior only, suppose occiput is posterior and I let it deliver, then the first part that comes behind pubic symphysis is face. So once the baby delivers, the first part that comes is face. So इसे हम कहते हैं face to pubes delivery. So when question is asked which pelvis promote face to pubes delivery, it is same. Anthropoid. ठीक है, it is same thing. ठीक है, so देखो, ये है occipito anterior, how smooth it is. But occiput when it is posterior, there is some flattening. Okay. Platyploid has face presentation. फेस टू प्यूब्स डिलीवरी का क्या मतलब होता है? फेस टू प्यूब्स डिलीवरी मतलब ऐसे आपका बेबी आ रहा है. दिस इज द नोज, माउथ. कितना गंदा बेबी है. दिस इज नोज, mouth of baby. This, the baby occiput is posterior. This is the pubic symphysis, and this is the buttocks of the mother. Baby is delivering like this. Can I see the occiput being posterior? Baby is delivering like this, and when I'm delivering, I'm seeing the face first. इसे कहते हैं face to pubes. Face presentation मतलब when I'm doing the PV. Here, when I'm doing the PV, the first thing I feel is head only. No, Kyphlic presentation में occiput is posterior. But what I'm feeling on PV is Kyphlic. When on doing PV, what I feel is face. What I feel is face. As I do PV, I'm not feeling this Kyphlic. I'm feeling face. This is face presentation. Face presentation is seen in platypod. Occipito posterior है Kyphlic ही ना? It is Kyphlic presentation. This is the presenting part. Occiput, instead of being anterior, it is posterior, but this is the presenting part. Once this baby delivers, it delivers like this. This baby delivers like this. Face comes first, face to pubes. Face presentation means on the cervix, face is there. That is platyploid pelvis. Okay, so face to pubes, face presentation, different. Face to pubes matlab occipito posterior. Now when the baby is delivering, it is delivering like this with face coming just in front at the time of delivery. If you have not got it, please let me know. Please let me know if you have not got it. Got it. Good. Okay. 36 weeks, 6 days with transverse lie. Everything is normal. What will be your next step in transverse lie? She is 36, 6 days. What will be your next step? Let's finish करते हैं. Perfect. External Kyphlic version. सब में करेंगे हाँ. Trial of breech delivery. Whenever the external Kyphlic version has failed, it is a breech baby. After ruling out contraindications, I will let her deliver normally. I'll just try. इसे कहते हैं ट्रायल ऑफ ब्रीच डिलीवरी. ठीक है. व्हाट आर द कॉन्ट्राइंडिकेशंस? फुटलिंग ब्रीच. ठीक है. वेरी स्मॉल बेबी or a big baby, I am not gonna deliver both of them in breech. Previous cesarean, then extended neck. The sign is called a stargazing sign. Extended neck, the as if the baby is gazing at the stars. Extended neck and एक और था extended neck and cesarean, IUGR, macrosomia, footling. That's it. Previous year, CS, yes. Okay, so the or I don't have anybody expert who can deliver a breech baby. ठीक है. So yes, IUGR, preterm, मतलब it's a small baby. I can let it deliver. Why I can't let it deliver? You know what will happen if it's a small baby? I should let it deliver. The body is small. When the baby is IUGR or preterm, the head is still large. The body is small. Body will come out. Cervix is not fully dilated. Body will come out. Head will get stuck. Now you have got a baby whose body is hanging, head is inside, and cervix has not dilated. By the time you'll wait for the cervix to dilate, the baby is gone. So that is why you don't deliver a small baby. Okay? Herpes, CPD, they are the general indication for contraindication for vaginal delivery. I was just asking when I cannot deliver a breech through vagina. But good, herpes may, CPD may, I can't. Okay? If I can, what I do is assisted breech. If there are no contraindications, I do assisted breech. Assisted breech matlab I assist in every step. Okay? Once the baby's buttocks start coming, I wait. I don't do anything. If the legs are flexed, it's a complete breech. If the legs are flexed, slowly legs will come out. But in frank breech, legs doesn't come out. And here comes assistance 1. Delivering the legs. So first step, first assistance is for delivering the legs. One method is groin traction. Can you see groin traction? Another is pinards. So this is, suppose this is the extended leg, this one. I go and pin the popliteal fossa. I pin the popliteal fossa. Can you see it flex? I pin like this, it flex, I'll pull it out. So for assisting the legs, I use two maneuvers, groin traction and pinnats. Now legs have delivered, now baby is coming out. If the hands are flexed, hands will come out. Many times it's a nuchal arm, hand is like that. Hands are not coming out. This is assistance 2. That is why we call it assisted breech. Hands are not coming out, they are over the head. Again, I use two maneuvers. One is sweeping out the posterior shoulder, sweeping out another shoulder which is flexed. Another is rotate the baby, hold the baby by pelvic girdle. Never hold the baby at abdomen. Okay? Hold it at the bony place so that it doesn't have compressive injuries. Hold at pelvic girdle and rotate. Bring the extended arm posteriorly and the flexed arm anteriorly. इसे हम कहते हैं Lovset maneuver. So in shoulders, I did two things, sweeping out posterior shoulder or Lovset maneuvers. Okay? Correct. Now, everything has come out, head is left. This is my assistance 3. For delivering head, I have 3 methods. First and foremost, Marusi Semmelweed. Put the baby on my left hand, put my right hand above the baby, flex the head and bring it out. Whenever you flex, smaller diameter comes out. So Marusi Semmelweed. Next, Burn Marshall, though not done because of extensive injuries, now not practiced, but yes, Burn Marshall is for bringing the head out. Third, Piper forceps. Can you see a long forceps with this curved body? Why this body is curved? We need space for the fetal body. That is why the shanks are curved. This is Piper forceps. So 3 methods for delivering head: Marusi Semmelweed, Burn Marshall, Pipers. For delivering legs, what were the method for delivered legs? What 2 methods I used for delivering the legs? Groin traction and pinnats. For delivering the arms, what was the method I used for delivering the arms? Lovset and sweeping the posterior shoulder out. Correct. And for head, 3. So these many maneuvers used in breech, isliye we call it assisted breech. Remember, whenever breech is delivered, can you see back is always anterior? Back should always be anterior. Back should always be anterior. Sometimes back turns posterior. When the back turns posterior, what we use is modified Prague maneuver. Okay? So these are the maneuvers used in breech. Okay? So we have finished the breech deliveries. Now, a little bit more questions. A lady with asthma is in labor. What will you not use in her? If she has got asthma, what will you not use? I'm not using carboprost in her. Okay? Carboprost is contraindicated in asthma. Vaginal delivery at PHC was referred to you for extended tear. What is the grade of this tear? What is the grade of this tear? Can I see that not only just can I see this that mucosa of the vagina and the mucosa, see, rectum is a whole canal. So upper part of the rectum has gone, no? This upper mucosa of rectum has gone. That is why you can see through and through. So rectal mucosa has got involved. If rectal mucosa might have not got involved, sirf vaginal mucosa involved hoti, this cavity would not have been one. There would have been just tear in the vagina. This cavity has turned to be one. Vagina and rectum are now one. Because vagina, see, this is rectum, this is vagina, right? This mucosa is injured and this above mucosa is also injured, and now they are one cavity. Both the mucosas are injured. Vaginal lower wall, rectal upper wall. So what is it the grade? What is grade in this? If I can see the mucosas are involved of both of them, it is grade 4. Grade 3 कब होता? Grade 3, if they would have given you grade 3, they will not give you 3 ABC. Why? 3A क्या होता है? Internal, external anal sphincter injured less than 50%. External anal sphincter injured more than 50%. You can't see that on picture. So they will never give you that. If they will give you, they will give you grade 3 only. So in that case, sphincter will be involved, but the cavity will have been 1. No, not this cavity would not have been 1. Only there would have been tear at the mucosa, but rectal mucosa would have been intact. Rectal mucosa is damaged. Now the cavity is 1. That is why it is grade 4. 3 ABC, you can't make out you seeing the picture. So they will not give you that. Okay, I'm not telling the grading. I know you all of you know the grading. Management based on partogram. LAC is vacuum outlet forceps oxytocin. Okay. So this woman comes at 12, 1, 2, 3, 4, 5, 6, 7. This is the progress. What do you think should be the answer here? Options are, should I go for LSCS or should I apply an instrument like forceps or vacuum, or should I wait? What should I do here? Or should I start oxytocin? Sorry. What should I do here? Okay. Just try whatever comes to your mind. Okay. देखो पहले okay. So we have a lot of doubts. Let's see. First, you should know how to read a partogram. So this is a part of partogram. Partogram has information of everything. Partogram has maternal information, fetal information, and the progress of labor. This part where progress of labor is plotted, इसको हम कहते हैं cervicograph. So cervicograph is a part of partogram. So when there are two lines, alert and action line, that are separated by 4 hours. Why? Because once the labor cross the alert line, you have to take some action. And after taking action, you wait for 4 hours. So that that whatever intervention you have done should work. You wait for 4 hours and reassess. And now if it has touched the action line, it means your intervention has not worked. That is why there is a gap of 4 hours. As soon as once the labor start, once the alert line is crossed, be alert. Your labor is slow. Alert line is crossed. At 12 p.m. it was 4 centimeter. Here it is 6 centimeter. There should be at least 1 centimeter per hour dilatation. But in these 4 hours, only 2 centimeter dilatation has occurred. It is slow. Alert line crossed. Once the alert line is crossed, what do? I check for CPD, cephalopelvic disproportion. I check for contractions. These are the steps which I take. I shift her to a center which is better equipped for cesarean. These are the 3 things are done when I see line crossing the alert line. Look at the contractions. How many contractions are there? 4. Number of boxes I have colored. Tell me the number of contractions. I have colored 1, 2, 3, 4. 4 boxes. Here there were only 3 boxes colored. Here I have colored 4 boxes. So there are 4 contractions. And completely filled with color, matlab good. If there would have been dot dot, mild. Line, moderate contraction. Completely colored, good contraction. So 4 good contractions are good. Why will I start oxytocin? Contractions are already good. I have ruled out CPD. Now let me check after 4 hours. After 4 hours, it has touched the action line. Once it has touched the action line, I have to deliver. It is extremely slow progress. I have to deliver. Now I have many methods to deliver. LSCS or forceps. For applying forceps, first prerequisite, it should be fully dilated. See the dilatation, 7 centimeter. Can I apply forceps at 7 centimeter? Descent of head, 2 by 5. 2 by 5 matlab descent of head is how many parts are palpable per abdomen. 2 parts are palpable per abdomen. It is not engaged. Fetal head is engaged when the parts palpable per abdomen are only 1 by 5 or 0 by 5. Then it is engaged. So neither it is engaged nor it is full dilated. I can't use forceps. I will not wait. It has crossed the action line. I will do LSCs. So remember, once the alert line is crossed, look at the contraction, start oxytocin, rule out CPT. Once the action line is touched, deliver. अब यही बेबी अगर यहाँ होता, suppose यहाँ पे, it is fully dilated, not getting delivered. Head is 0. I would have answered forceps. It is fully dilated, head is 0/5. I would have applied forceps. But not here. And why oxytocin? Contractions are so good. 4 to 5 contractions are good. Sorry, not 4 to 5. 3 to 4 contractions, good intensity are good. So you just need to see how to read a partogram. Many times molding is also mentioned. I forgot either molding nahi mentioned होती. Many times molding is mentioned. Remember, whenever molding means how close the fetal scalp are. If it is one molding means they are touching, okay. Plus 2 molding, they are overlapping but slipping back. Okay. Plus 3 molding is significant slipping, overlapping. Whenever your question has given you plus 3 molding, there is a column for molding also. Here it is not there. Whenever there is a column given plus 3 molding, you can't deliver it vaginally. It indicates CPD. It has no space. Scalps are overlapping. So whenever there is a plus 3 molding, there is CPD, you can't deliver it. Whenever it is not fully dilated, you have to go for cesarean. Okay. So remember few things about partogram. Partogram में first plotting is always on the alert line. Suppose patient comes to me at 6 centimeter. Where will I plot? आपने internship में you might have done plotting in internship ना? Yes. Alert line cross, take action. मतलब do intervention. Action line touch. Action line को cross नहीं होने देता. Cross नहीं होने देना है. You don't have to wait for cross. Action line touched. Take the baby out. So these are two things. Alert line cross. Whenever I start plotting, plotting is always on the alert line. Remember, patient comes to me at 6 centimeter. You start plotting from here. Never. It is wrong. Why are you giving an extra advantage? You plot from here. My plotting for partogram will start from here. If the patient comes at 6 centimeter, here I will start plotting. And the dilatation should be 1 centimeter per hour. If it is any slow, it will immediately cross the alert line. So as the alert line is crossed, I will intervene. After 4 hours, as the action line is touched, I will take the baby out. Okay? So whenever patient comes, plotting is on the alert line. Do not plot here. Practice maybe I'm telling you, don't start plotting from 8 centimeter. Even if it is slow, you will not know, because even if it is slow, it will still be here only. You have already started from the left. So start from here, always on the alert line. Okay? Just remember, let me remind, I forgot to include it. I have to do the new partogram also. WHO Labor Care Guide. No question has been asked ever, but maybe this time it will be asked. 2022 May it was launched, and I think it's a high time some question might be asked on new partogram. Okay, so just let me know when I finish कि ma'am WHO new partogram बता दीजिए. Okay, I'll tell you the new partogram. Which pelvis has highest probability of phase 2 pubes? Now see this question. 2024 का question है. Which has highest phase 2 pubes delivery? This one. Which has highest face presentation? Face presentation मतलब head is so extended that face is coming up. Face to pubes मतलब flex है. Head is flexed. It is just occiput anterior. Sorry, occiput posterior. So face presentation is platypod. थोड़ा सा इंस्ट्रूमेंटल डिलीवरी देख लेते हैं, then I think it is done. फिर बस हमें करना होगा labor care guide. Okay, let's just finish this. We'll take a break then and we'll go for gynae. Multigravida was in second stage of labor matlab when the cervix is fully dilated for more than 2 hours. On PV, fetal head is palpable at level of ischial spine. Ischial spine matlab 0 station. Occiput transverse. Sagittal sutures are palpable in transverse. Most likely it is an android pelvis. Molding plus caput plus what will you do? ischial spine के level पे, can you apply that? When the head is at ischial spine, head has to be engaged, है ना? So head has to be engaged means when it crosses the ischial spine, below the ischial spine. It is at the level of ischial spine. And molding plus plus caput plus plus, indicating me that it is deep transverse rest. Okay. So when I'm talking about forceps, there are three places where the forceps can be applied. When the forceps is just at the, when the head is just at the pelvic floor and I can see the head without separating labia, it is outlet forceps. I can see the head, but it is not coming out. Without separating labia, I can see the head. It is at the pelvic floor. Okay. Second is low forceps. Low forceps means it is +2 station and below that. It is below +2, but not at the pelvic floor. Okay, so it is below +2, but not at the pelvic floor. That is low forceps. And mid forceps is, it is between ischial spine and +2. So it has crossed the ischial spine, but it is above +2. That is mid forceps. Now, based on different sides of forceps, I have different types of forceps. A small forceps with small handle, small shank. Where will it be used? When I want to just take the baby out with minimal force. It is an outlet forceps. Outlet matlab baby is at the perineum. So I need a small forceps. So outlet forceps is Wrigley's forceps. An Indian version is also there, Das forceps. This forceps where the shank and the handles are long, it is mid cavity forceps. I need more length and more force. It is Simpson. Simpson forceps is for mid cavity forceps. Okay? Long hand, no, it's not key length. Long shanks, long hand. Key length देखो क्या होता है. Can you see when the forceps are closed, the handles are closed and the shanks are apart? See reverse. On closing, the handles are apart, but the shanks are closed. It is reverse. This is key length. The rotational forceps. How to differentiate? On when the blades are closed with each other, the handles will be away and shanks will be closed. It is opposite of other forceps. So that is key length forceps. That's how you identify that. One forceps I have already discussed with a curved shank, Piper forceps in breech delivery. So remember these types of forceps. Okay. Where to apply vacuum on fetal head during delivery? Where do we apply vacuum? When I apply vacuum, I always apply it something called as flexion point. Flexion point means vacuum is a very good thing. It will not just pull the baby out, it will also flex the head. But it has to be applied at the right place. If it is applied at the right place, somewhere near the occiput, once I pull, head will flex. इसे कहते हैं flexion point. Flexion point means the center of the vacuum is 3 centimeter front of the posterior fontanelle. So vacuum ka center is just 3 centimeter anterior to the posterior fontanelle is the flexion point. Okay, when I'm putting it on the flexion point, remember my rim, my posterior rim is on the fontanelle. So question can also come, posterior rim on posterior fontanelle. This is same. When posterior rim is on posterior fontanelle, the center is 3 centimeter away. So both are correct. Okay. Or I can say the center is 6 centimeter from anterior fontanelle. Okay. So these are the other ways of stating the flexion point. This was also a question asked in 2024. The maneuver, what is this maneuver? Burn Marshall. Now I'm just rushing so that we can start gynae. In which of the following conditions ECV is not contraindicated? It means I can do external Kiflic version. Maybe it's a breech baby where I can do external Kiflic version. Previa? No. Can I do external Kiflic version of placenta previa? Will you deliver placenta previa vaginally? Oh no. Primary gravida mein. Aram se karo. What is the problem? Postpartum. A woman comes to emergency 5 days after normal delivery. She's having crying, loss of appetite, difficulty sleeping, low self-esteem. She has come 5 days. She has come quite early. So what is it? Blues. Remember, blues or depression is very same. Only thing that is different in blues and depression is these days. See, psychological disorders are basically three. Postpartum blues may be same hota hai, excessive crying and depressed and low mood, but it presents early. Day 3 to day 5 of delivery pe it comes. And it persists only for 24 to 48 hours. If you give this woman proper rest, it will resolve. You don't need to give treatment. It comes very early. Similar is postpartum depression. Again, she's crying, but some extra features. She's not able to sleep. She doesn't enjoy anything she previously used to enjoy, and all those things. Important is it presents late. 3 weeks. So it has two spikes. One spike at 3 weeks, another spike at 3 months. This is the time when around postpartum depression comes. And it does not resolve spontaneously. You have to give the treatment, which is SSRIs, preferably fluoxetine. So it is a late presentation. And the most easily identifiable psychosis can happen anywhere within 1 year of delivery, anytime. Typical hallucinations, suicidal thought of killing the baby, thought of killing herself. That is psychosis. It's an emergency. You will admit her away from the baby. Obviously, she has thoughts of killing the baby. You will admit her away from the baby. You will start lithium, electroconvulsive therapy, valproate. Everything is started. Okay. At what level uterus is felt after second day of delivery? So uterine involution. Second day of delivery. और ये question I've done so many times in my reels. It means you don't see my reels. So disheartening. None of you see my reels. See, when the uterus starts first, where is uterus immediately after delivery? At the upper border of umbilicus. So yes, good. See, the reason after seeing my, see, you have answered right. Pakka they see my reels. So where is uterus immediately after delivery? Uterus is at the upper border of umbilicus here. Okay? Remember, once the delivery has happened, that is day 1 postpartum. I don't know from where that concept of day 0 has come. Once the woman has delivered, that is day 1, as written by Williams, not by me. So Williams say once she has delivered, that is day 1 postpartum. On day 1 postpartum, it stays at the same level. So for 24 hours, it is static. From day 2, it starts involuting. On day 2, it is 1 finger below. So every day, it is 1 finger below. So on day 2, it is 1 finger below. Why 1? Because for day 1, it was static. On day 3, it is 2 finger below. On day 4, it is 3 finger below. So on day 1, it stays at the same place for 24 hours. When the day 2 comes, at the end of day 2, it is 1 finger below. At the end of day 3, it is 2 finger below. At the end of day 4, it is 3 finger below. By the time it is 2 weeks, it is intrapelvic. And when does the involution complete? Remember, involution complete at 4 weeks, not at 6 weeks. At 4 weeks, uterus is pre-pregnant state. Pre-pregnant, sorry. So uterine involution completes at 4 weeks, not at 6 weeks. Okay. So at the end of second day, it is 1 finger below. So 1 finger each day is the involution rate. You can also call it ½ inch. Okay. This is 1 inch. This is ½ inch. Or 1.25 centimeter. This is all same. 1 finger is ½ inch or 1.25 centimeter. So anything can be given. Yes, day -1. Okay. So we have finished this. Once we finish gynecology, then only I'll do the new partogram. Okay. And even if I miss it, even if it's too late, I will put a video of new partogram on the group. Okay, we all are there in the group. Anything which is missed, I'll put it on the group. है ना? So there is no hush hush. Okay. So should we meet at around, it's 4:10. Should we meet at around 4:25? Okay, we should meet at around 4:25. Will that be okay? Okay, sure. Hello everyone. So we are reaching towards the last of our topic. I hope everything what we have discussed is clear without doubts. And even if there are certain doubts, and even if something is left, because there will be certain things which will be left, then because if what I can remember, a little discussion about CTG and NST. Okay, I've put down questions also in the group. I'll put them down again. We'll discuss on the group. We can discuss new labor care guide partograms, few things which are left, a little bit of things that we can always discuss on the WhatsApp group. Okay, so let's just finish this up. Starting with gynecology, little bit about embryology. So the female structures are formed by, in a female, the genital structures are formed by Mullerian ducts, also called as paramesonephric ducts. And in males, it is formed by Wolffian duct or mesonephric ducts. The arrangements of these ducts are like this. So this is how a Mullerian duct is arranged. And here from lateral to medial comes the, so this is how, this is how the mesonephric duct is arranged. And this is how the Mullerian duct comes up. In a female, these Wolffian ducts degenerate and only the Mullerian ducts stay, forming uterus and vagina. Sometimes there are certain remnants of Wolffian ducts which are there. So certain remnants of Wolffian ducts which are there, like Gartner's duct, like epuphoron, paraoophoron, they all are the remnants of these ducts which have degenerated, but small parts remain. So if the question has been asked, where does the remnants of Wolffian duct will be? I can see that the Wolffian duct is lying lateral to the vagina. Can I see this? This is how it is. So Wolffian ducts are, if there are any remnants, they are always in the lateral uterine wall or to the lateral vagina. So when they are always placed laterally, there where you find the remnants of Wolffian duct. So this is a 2020 question. Now, 22-year-old female presents with recurrent pregnancy loss. HSG was done. This is what? Hysterosalpingography, where you inject a radio opaque dye and take the X-ray. So what do you think is the diagnosis? What do you think the diagnosis will be here? Okay. Anybody else? See, it can't be didelphys. Why? Didelphys all just hello. Didelphys always has everything too. So didelphys will have two vaginas. And whenever there are two vaginas, why one cannula will be used? So in didelphys, we use two cannulas. Because there are two vagina, we have to use two cannulas to inject the dye. So it is not didelphys. I can see that it is not definitely unicornuate because there are two horns. So didelphys and unicornuate are gone. It looks like either bicornuate or septate. Now, bicornuate or septate depends on your personal perception, I must say. There are guidelines which say that if the horns are far apart and the distance is almost 4 centimeter or the angle is more than 120 degree, it is bicornuate. If the horns are closer, the angle is less than 90 degree, it is septate. But the thing is, you can't measure. This is a radiological picture. You don't know what the actual distance this is. So this is more on your perception. I would say if the horns to you look like far apart, they are bicornuate. If the horns look like close by, that you will understand by looking this. So can you see here? It is kind of forming an acute angle. They are not falling apart. When the horns are not trying to fall apart, this is septate. When the horns are trying to fall apart, they are trying to go away from each other. This is bicornuate. Okay? So though theoretical definitions are there, but they can't be applied when you are seeing the HSG image. What is the angle? How much is the distance? You can't see that. So when the horns look like they're falling apart from each other, it is bicornuate. And when the horns are seen to be closer to each other, then it is septate. That is the only differentiation. Otherwise, they look very similar. See, this is didelphys. Can I see two cannulas? Can I see two completely different vaginas? This is uterine didelphys. So didelphys means there is completely no fusion at all. ठीक है? Now there has been questions on Embryological anomalies. There has been question on what complications can happen. Like there was a question in NEET 2021. Which of these anomalies will not happen with diadelphous uterus? With diadelphous, which of these will not happen? Preterm labor, transverse lie, endometriosis, abortion. What cannot happen? Look here again. Transverse lie can't happen. So transverse lie cannot happen here, but endometriosis can happen in uterine diadelphous. Can you please explain me how uterine diadelphous will develop endometriosis? Can anybody explain me how, if you have chosen not to mark endometriosis, can you please explain why endometriosis is not happening in diadelphous uterus? There are two cavities. Why endometriosis means uterine blood regurgitating out. Why will it happen in diadelphous? Why is it regurgitating out? Diadelphous means the cavity is small. Obviously, there will be preterm and the abortions, but there will be always malpresentation. Since it's not a normal cavity, baby can lie in breech, baby can lie in transverse. Why it cannot lie in transverse? A small baby can take a transverse position. It is malpresentation. Baby can take any comfortable position what baby wants. So malpresentations are very common in uterine anomalies. Why will endometriosis happen? Endometriosis का basic reason है that blood is regurgitating out. Why it is regurgitating out? There is no reason. Endometriosis happen basically in transverse blockage. When the blockage is here, like imperforate hymen, then the endometriosis will happen. ठीक है? Uterine septum, uterine diadelphous will have preterms, abortions, and malpresentations. Malpresentations में transverse lie, breech, oblique, anything can happen. Endometriosis risk is less in these kind of anomalies. Endometriosis risk happen when there is a blockage transversely here. Okay? ठीक है? Next question comes what are the diagnostic tests for these kind of uterine anomalies? So remember uterine anomalies, previously what we used to do for diagnosis was laparoscopy plus hysteroscopy. Lapro plus hystero was the previous diagnostic method of choice previously. But now it is not so. The diagnostic method of choice is 3D ultrasound. 3D ultrasound, not 2D. So 3D ultrasound is the diagnostic method of choice for uterine anomalies. Okay. Previously, it was laparoscopy and hysteroscopy. Why I'm mentioning it? If a question comes where 3D ultrasound is not given, then you mention this one. Okay. Which of these is the most common uterine anomaly? Septate. Septate uterus is the most common uterine anomaly. Which uterine anomaly has the worst obstetrical outcome? Worst. Unicornuate has the worst obstetrical outcome. Okay. Then what other system anomaly is common with uterine anomalies? Renal system anomalies. 40% of patients have these. Okay. When you do HSG, what is the day when you do HSG? HSG is always done in proliferative phase, preferably at day 10 of menses. Okay. It is not done in post-ovulatory phase. Now comes the surgeries for repair. Okay. What are the surgeries that are done for repair of these anomalies? Yes, yes. All the uterine anomalies will have a risk. Obviously, there will be different percentage, but yes, uniconvert will have renal anomalies. MRKH also has renal anomalies. Longitudinal fusion defects like these one will also have renal anomalies. Renal and spinal are most common system involves. Renal 40% and spinal anomalies are there in 10% of patients. The treatment of these uterine anomalies. Septate uterus, very easy to treat, a very good obstetric outcome. Hysteroscopic, you go hysteroscopically, hysteroscopic septal resection. You just resect the septum out. Hysteroscopic septal resection. Okay? Then bicornuate. Twice this question has been asked in 2021 and in 2020. In uterine bicornuate, what do? You do metroplasty. Metro matlab uterus. So you have to repair the uterus. You call it metroplasty, not Stressman. Stressman nahi karte hain. What we do here is in bicornuate is, yes, sorry. Correct. Strassman metroplasty. Strassman metroplasty. ठीक है. Other methods for uterine septum is septal resection. Here you also do John's procedure. ठीक है. John's and Hopkins procedure. You don't need to remember that. Just remember septum के लिए hysteroscopic septal resection, biconduit के लिए Strassman metroplasty, uterus diadelphys. We do not repair. Because there are two vaginas, even if we unify the uterus, what will happen to vagina? We can't unite the vaginas. So vagina are two, cervix are two, everything is two. We don't repair it. So uterine diadelphys is not repaired. Okay. What is this hymen? Very easy. Though it was first time it was asked, but what is this hymen? Septate hymen. है ना, इसमें तो there is no doubt. ये 24-year-old woman comes with infertility, ultrasound finding uterine anomaly. Which of the following is used to confirm the diagnosis? This question was asked in 2021. So maybe now when they will ask, they will change the options. Correct. Hysteroscopy, laparoscopy. But suppose they have given 3D ultrasound. Then you will mark this as 3D ultrasound. Okay. So this is all about amenorrhea. The procedures, the diagnostic methods. Now comes the amenorrhea. A girl of primary amenorrhea with no breast, no pubic and axillary hair, bilateral inguinal masses on ultrasound. What is her diagnosis? A very weird question, but anyways. What is her diagnosis? But androgen insensitivity mein breasts are present. So when this question was released in 2023, that was the confusion. Everything looks like AIS. Inguinal masses means always testis. No pubic axillary hair. It means it is androgen insensitivity. But there was no breast. Whereas androgen insensitivity has breast. So there are two possibilities. Correct. Either this was a misprint, which is very unlikely. Okay? But still, majority of people marked androgen insensitivity. And it was a very controversial question when it was asked later. But then it was discussed that it was actually a very difficult question. There is an enzyme deficiency called as 17-alpha hydroxylase deficiency. When there is 17-alpha hydroxylase deficiencies, what happened? The steroidogenic pathway doesn't work. The steroids, no, it is not a part of congenital adrenal hyperplasia. CAH में 21-alpha hydroxylase, 11 hydroxylase, 3 beta hydroxylase होता है. This is 17-alpha hydroxylase deficiency. ठीक है? It is a part of hypergonadotropic hypogonadism. Hypergonadotropic hypogonadism, why? Because in this enzyme deficiency, the FSH and LH are high. Why? Because body does not form steroids. Body does not form steroids, any steroids. That is why there are no pubic and axillary hair. There are no breast. And even when they are males, there will be inguinal masses, but no breast and no pubic axillary hair. Okay? So no pubic axillary hair, no breast is 17-alpha hydroxylase. No pubic axillary hair, breast present is androgen insensitivity. 17-alpha hydroxylase comes under hypergonadotropic hypogonadism because of steroid deficiency, FSH-LH is very high. So most likely what they are asking is 17-alpha hydroxylase deficiency, and they have not even mentioned that in the option. They have just mentioned hypergonadotropic hypogonadism. So this should be the answer. Okay, considering it as an enzyme deficiency. 17-alpha hydroxylase is a very initial step enzyme that is needed to start the steroidogenic pathway. The steroidogenic pathway doesn't start. So we don't have anything. We don't have any steroids. No adrenal androgens, no estrogens, no mineralocorticoids, no hormones are there. And that is why this kind of presentation happens. Okay? Very weird question. Once it was asked, I was also very confused. What are they trying to ask? I thought it is a misprint. Because what I was thinking that if they want to ask this enzyme deficiency, they should write this enzyme's name rather than writing this. They should write this enzyme's name. So my take was it is a misprint. That was my take. But everybody agreed that it is 17 alpha hydroxylase and hypergonadotropic hypergonadism. Let's see. A patient of primary amenorrhea, cyclical pain, suprapubic lump. On PR examination, fullness was felt. What is this? When the fullness is there in whole vagina, obviously cyclical pain, it is cryptomenorrhea, but whole vagina is filled with blood. Why whole vagina is filled with blood? That is imperforate hymen. Now, again, this question was seen for the first time. This was first time asked in 2023. But even when, I don't know, I know all of them will cause cryptomenorrhea. PR fullness was felt in whole vagina. I have to think. Fullness in felt in vagina, it means vagina is filled with blood. Will vagina be filled in blood in cervical agenesis? No. In upper vaginal septum? No. Vaginal agenesis may? No. So obviously it is imperforate hymen. So straightforward answer. Wide spaced nipple, short height, karyotype is this. Simple. It is Turner syndrome. Remember, Turner syndrome has many other abnormalities starting from head to toe, low hairline, short neck, shield-like chest, increased carrying angle, multiple navis, cardiac anomalies. But remember, IQ is normal. In Turner syndrome, the IQ doesn't change. So person has normal IQ. There are chances of autism which are there, but IQ of a Turner syndrome patient is normal. Okay? Okay? A girl present with primary amenorrhea with well-developed secondary sexual characteristics on examination. This was the finding. What is the diagnosis? What is her karyotype? Sorry, what is her karyotype? Please answer, what is her karyotype? What is her karyotype? Please tell me, primary amenorrhea with well-developed secondary sexual characters, this closed. Can you see vagina? I can't see vagina. Why I can't see vagina? Why I can't see? Because just at the opening, a membrane is there. Just at the opening. It is hymen, which is not perforated. Yes, it is imperforate hymen. It is 46XX. Why you said XY? So it is primary amenorrhea with well-developed secondary sexual characters. Well-developed secondary sexual characters means her pubic and axillary hair, they are also part of secondary sexual characters. They are also developed. Breasts are also developed. So what is it? It is 46XX. It is imperforate hymen. Right? See, whenever the question of primary amenorrhea comes, what you always have to see first, सबसे पहले आपको क्या देखना होता है, is always secondary sexual characters. Secondary sexual characters will tell her whether she has estrogen in her body or not, whether her HPO axis is functioning fine or not. In case her secondary sexual characters are absent, it means her HPO axis has not started functioning. So secondary sexual characters absent means some problem in either hypothalamus, pituitary or ovary. What will I do next? I will do her hormone levels to know where the lesion is lying. Isn't it? If her FSH LH are high, hypergonadotropic, means there is some kind of ovarian problem. It is ovarian dysgenesis. So what is the reason for dysgenesis? What will I know? I will know by doing a karyotype. Because it can be Turner's, it can be XX or XY, pure gonadal dysgenesis. They all present exactly the same. X0 has short height. That's it. Other than that, they have no secondary sexual characters, uterus, vagina inside. They all present same. So I have to do karyotype. But if FSH-LH is low, most likely this problem is central or pituitary. My next step is the CT scan head. As soon as the question gives me that the secondary sexual characters are present, it means there's a problem of the uterus. If the secondary sexual characters are present, means HPO axis has been functioning fine. Okay, there is some problem with the uterus. So what will I do? Either I'll do local examination to see any blockage, or I'll do ultrasound to see whether uterus is present or not. If question gives you cyclical symptoms, so it is obviously cryptomenorrhea. And we know the two causes of cryptomenorrhea and how to differentiate, isn't it? We know them. Bluish bulging membrane is imperforate hymen. Okay? And pink non-bulging membrane is transverse vaginal septum. But if there is no cyclical pain, it means it is not cryptomenorrhea. Then I'll do ultrasound and I'll see uterus is absent. Uterus is absent, there can be two reasons. Either it can be MRKH or it can be androgen insensitivity. The diagnostic test is karyotype, but question can give you anything. Question can give you inguinal masses. Inguinal masses, androgen insensitivity. Question gives you pubic axillary hair absent, androgen insensitivity. Question gives you high testosterone level, androgen insensitivity. So besides karyotype, these things are given, they indicate androgen insensitivity. Ovaries are present, pubic and axillary hair are present. This is MRKH. Okay. Now you have presented, I am also having doubt in this question. I thought it is imperforate hymen, but now I am thinking it doesn't look like hymen. Now I have just noticed that it doesn't look bluish bulging membrane. It looks as if there is no vagina at all. Non-cyclical pain. So if patient has secondary sexual characters developed, it means her HPO axis is intact. Secondary sexual characters will develop only when her hypothalamic pituitary ovarian axis is functioning. It means I am dealing something in the uterus. So either uterus is blocked, vagina is blocked, or it is absent. If it is blocked, there will be cyclical pain covering every month. So obviously either imperforate hymen or transverse vaginal septum. But if it is not blocked, patient will not have any cyclical pain. Most likely the uterus is absent. A girl comes to you with secondary sexual characters well developed, okay, no cyclical pain. Two differentials. Either it is MRKH, means Mullerian agenesis, or it is androgen insensitivity syndrome. There are two differentials. Two differentials where breasts are developed, uterus is absent. They both have the same things. The question will give you what to differentiate. Here there will be inguinal masses. Remember, inguinal masses are never ovary. Inguinal or labial masses are always and always testis. Or pubic and axillary hair absent. Or serum testosterone level high. Or on ultrasound, no ovaries are visible. Question can give you anything. Here, if it is MRKH, ovaries are visible on ultrasound. Pubic and axillary hair are present. But the main diagnostic test to differentiate between them is karyotype. One is XY, one is XX. Okay. Another thing which presents like androgen insensitivity is 17 alpha hydroxylase deficiency. 17 alpha hydroxylase deficiency comes here in hypergonadotropic, here in this category. इसे हम लिखते हैं rare enzyme deficiency. This rare enzyme deficiency means the steroids are not formed. Neither androgens are formed, neither estrogens are formed. So as a result, there will be no pubic axillary hair. There will be no secondary sexual characters. Okay? And no breast developed, but it's an XY boy. Swyer syndrome, what is Swyer syndrome? Swyer syndrome is XY person with gonadal dysgenesis. So gonadal dysgenesis in XY syndrome, how will it present? It will present as a girl. Since the gonads have got dysgenetic, the gonads are not functioning in XY individuals. Swyer syndrome, testes are not functioning at all. What will be there inside the person? Internally, there will be uterus and vagina. Okay? Outside, external genitalia will be like a female. But there will be no secondary sexual characters. Because for secondary sexual characters, you need estrogen. There is no ovary where the estrogen will come from. So no secondary sexual characters. Uterus, vagina are present. External genitalia is also like female, but it is XY boy. Androgen insensitivity is also an XY boy, but here it is insensitivity of the receptors. Receptors are not sensitive. Testes are producing the normal hormones, but receptor is insensitive. Here inside uterus and vagina are absent. Here uterus vagina are present. Why uterus vagina are absent? Testis is functioning. Anti-Mullerian hormone is being secreted by testis. Testis secrete two hormones, na? Testosterone and anti-Mullerian hormone. So uterus vagina absent because her Mullerian ducts have degenerated. Why? Because testis was secreting anti-Mullerian hormone. So uterus vagina is not formed. But external genitalia development needs testosterone. And it is insensitive to testosterone. So external genitalia is like female. But inside no uterus vagina. Here inside uterus vagina is present. Breast will get developed. All the testosterone will go into periphery, convert into estrone. So breast will develop. Here breast is not developed. Okay, there is no testosterone at all, so there is no breast. Pubic and axillary hair absent because pubic and axillary hair are because of adrenal androgens. Now receptors are insensitive to any androgen. So pubic axillary hair absent. Either pubic axillary hair are present. So androgen insensitivity and XY gonadal dysgenesis are totally opposite. Okay? ठीक है? Contraception. Which among the following condition is contraindication for application of contraceptive method given here? It is multi-load. So where we cannot apply multi-load? Multi-load cannot be applied in all of you got this chart, no? This chart you got, or you want me to, I'll make it more clear when I'll send that to you. Don't worry. But right now, have you got it? I can explain this to you again if you want, because on all this paper, the whole amenorrhea, primary amenorrhea is there. Okay, no? Got it. Okay. So where this contraception can't be used? Trophoblastic disease. In trophoblastic disease, in molar pregnancy and all, the uterus is so soft, it will easily perforate. So we don't use it. Can we apply IUCD during menstruation? Yes. Can this IUCD be used, condom rupture during intercourse means, can it be used as an emergency contraception? Yes, it is the best emergency contraception that we have. Following delivery, yes. So following delivery, at what time I can insert copper IUCD? I can insert immediately after delivery. जिसे हम कहते हैं post placental. If she was not ready, I can still insert it, but within 48 hours. While she is in the ward, I can still insert it within 48 hours. Now, even after 48 hours, she has not decided, I can't insert now. From 48 hours till 6 weeks, I can't insert. I can again insert it only after 6 weeks. This is the time when it is inserted immediately after delivery. Okay? A 28-year-old woman delivered 18 months back, 18 months, breastfeeding her baby regularly, now want a contraceptive advice. Periods are irregular and heavy. What will be the best contraceptive for her? This is very simple question, but what does your sense says? What should be used in this patient? Everyone, please. Though malign is not the best contraceptive, but the problem is periods are irregular and heavy. So can we treat two conditions with one medication? Yes, Mala-N. Can I use Mala-N at 18 months? Yes. Oral contraceptive pills can be very well used after 6 months. ठीक है? So postpartum, if I can talk about postpartum contraception. So immediately after delivery, I have 3 types of categories. One is exclusively breastfeeding. Exclusively. Somebody who is exclusively breastfeeding does not need contraception for at least 3 months. So I don't need any contraception. She is safe for 3 months. After 3 months, I can only use progesterone related products. I can also use IUCD. I cannot use oral contraceptive pills till 6 months. Okay? There is a woman who is not breastfeeding at all. If she is not breastfeeding, when she should start contraceptive? She should start contraceptive after 3 weeks. What I can use in her? I can use combined oral contraceptives. I can use progesterone only pills. Okay, and after 6 weeks, I can use IUCD also. Now, there is a woman who is breastfeeding but not exclusive. Not exclusive. If she is not exclusively breastfeeding, after how many days contraception should be used by her? 3 weeks. She should start using by 3 weeks. I cannot give her combined oral contraceptive pills. The only method she can use is progesterone methods. At 3 weeks, I can't give her IUCD. At this time, I can't give her COCs. Only thing I can give is progestins. Okay? IUCD can be inserted after delivery till how long? We have done that. After delivery within 48 hours. Lady comes with pregnancy and IUCD in situ. What to do? So if there is a pregnancy with IUCD in situ, if the thread is visible, then just safely pull the thread out. But if the thread is not visible, what will I do? I will do ultrasound. If the IUCD is lower in the cavity, then under ultrasound guidance, I will remove it. Why I want to remove IUCD? Because IUCD does not cause congenital anomalies. IUCD can cause sepsis. IUCD can cause preterms. IUCD can also cause ectopic pregnancy. That is why I want to remove. But suppose IUCD is somewhere in the upper cavity. That is the part where baby implants. If it is an upper cavity, I have to take consent now. Either she can go ahead with abortion or she can continue the pregnancy with IUCD in situ. So if it is somewhere in the upper part, either abortion, because if you will remove it, abortion will happen. So either abortion or continue the pregnancy with IUCD in situ. If it is lower in cavity, I will remove it. Okay. One thing I have forgotten here is missed pills. Just give me a second. Missed pills I have forgotten. Emergency contraceptives. Yeah, will be a very incomplete question if they ask how a lady came with pregnancy IUCD in situ. Since I had no full question, that is why I just mentioned what to treat. If they have not mentioned where it is, what to do? Pregnancy with IUCD in situ. So advise abortion or continue with IUCD after explaining risk. Both are feasible. So you have to choose what the options are given. If options are given abortion also, continue with IUCD explaining risk, it will be a very difficult question. Okay? Okay, there was remove IUCD. What else options were there? So first you try always to remove IUCD. If thread is visible, if there's just mentioned pregnancy with IUCD in situ, they have not mentioned anything, then remove the IUCD is better answer, right? Because we will assume the thread is visible. We'll assume the thread is visible and we will safely remove the IUCD. Unless the IUCD is upper in cavity and I can see the thread, then that is a problem. Otherwise, remove the IUCD simply. Okay? Missed pills. How to manage missed pills? Whenever OCPs may missed pill happen, very important how to manage it. See how the OCPs are arranged. There are 3 rows of hormonal pills. These are hormonal pills rows. Okay? So there are 21 to 28 tablets of hormonal pills. And there are non-hormonal pills, which are generally ferrous sulfate. Ferrous sulfate iron pills are there for non-hormone free interval. Now, if missed pills happen, the question is how many pills missed? If she missed just 1 to 2 pills, if only 1 to 2 pills are missed, no matter where it is in the packet, you continue with packet. You continue with the packet. Take only last missed pill. Take only last missed pill. Last missed pill means the last pill you missed, take only that one. And start today again with your normal packet. Okay? And then no extra precaution. You don't need extra precaution. In case you miss 1 to 2 pill. In case you miss 3 or more than 3 pill. Remember 3 or more than 3 pill if you have missed. Important is where in the packet. If these 3 pills you have missed lies in first 2 rows here, somewhere here, then same, continue with the packet. Take only last missed pill. ये नहीं कि you have missed 3 pills, you will take 3 pills. No, only one last missed pill. Take last pill that you have missed. Okay, continue with the packet. Use extra precaution. Now you have missed too many pills. So use extra precaution for 7 days. For 7 days, take extra precaution. Okay, simple. Now, if you have missed 3 or more than 3 pills in the last hormonal loop, here if you have missed the 3 or more than 3 pills, now what do you have to do? Take again the last missed pill. Take last missed pill. Use extra precaution for 7 days. है ना? Take extra precaution for 7 days. Complete only hormonal pills. Throw iron pills. If you have missed some pills here in the last row, throw the iron pills, straight away start with new packet. This is how missed pills are managed. 1 to 2 pills, continue with the packet, no extra precaution, only take last missed pill. 3 or more than 3 pills missed in first 2 rows, continue with packet, take the last missed pill, extra precaution for 7 days. Last more than 3 pills or 3 pills are lost in last row. Suppose you have missed pills, these many in the last row. Only finish the hormonal pills. Don't take these iron pills because iron pills ka purpose hai to give your body a hormone free interval. You have given your body a hormone free interval already. You have already given your body a hormone free interval. So now don't take iron pills, finish hormonal pills and start with the new packet. Use extra precaution for 7 days. That is how you manage missed pills. Okay, everyone? Got this missed pill? If the question comes, a lady has missed multiple pills at different days, 1 pill here, 1 pill here, 1 pill here, what to do? Then ask her to use some extra precaution, wait for menses and start some new method. It means she is somebody who just can't take OC pills. So if multiple pills are missed at different intervals, it means she can't take OCPs. She's not somebody who can take OC pills. You will advise her some new method from next cycle. Okay. So you got how to manage missed pills? Emergency contraception. Emergency contraception are basically only 3 methods that are available with us right now. Ulipristal acetate. Okay, ulipristal acetate is a selective progesterone receptor modulator used in 30 milligram single dose that has to be given within 5 days of menses. Sorry, within 5 days of intercourse. Second oral drug is levonorgestrel, taken as either 1.5 milligram single dose or 0.575 milligram 2 doses within 72 hours of intercourse. And the best and the most effective is copper T. Remember, Mirena is not an emergency pill right now. If 3 pills missed before day 16, here, these are 7 pills, no? So before where? If it is in first two rows here. So these are 7 pills. So here if it has been missed, you are saying before 16 days. So here somewhere in first two rows it has been missed, then you have to follow this one. Copper T is the best emergency contraceptive that can be inserted within 5 days. Ulipristal or levonorgestrel may say more effective is ulipristal, effective only in also in obese patient, but very less used. LNJ pill is available everywhere by the name of unwanted 72, I pill. It is available everywhere. Still, ulipristal is more effective. Why it is yes less used? Because it is a prescription based drug. You have to need prescription for ulipristal, whereas levonorgestrel is an over the counter drug. You go to the pharmacist, ask for emergency contraceptive, you will get levonorgestrel. But ulipristal clay, you need a doctor's prescription. That is why it is less famous compared to this. But the best is copper IUCD. Okay. What is the most common site for tubal ligation and what is the reason? The most common site for tubal ligation is isthmus because it is narrow and it has a uniform diameter. So isthmus part has a very uniform diameter. That is why it is the best part for tubal ligation. Okay. So that's it. Not many questions have been asked on contraceptions. These many only have been asked. Maki, you have to know what? You have to know the mechanism of action. What is the mechanism of action of oral contraceptive pills? Inhibiting ovulation. What is the mechanism of action of progesterone only pills? Making cervical mucus thick. What is the mechanism of action of DMPA injection? DMPA injection has high progesterone. Whenever progesterone is high, like in implants, like in DMPA, mechanism of action is inhibiting ovulation. Here, mechanism of action is not making cervical mucus thick. No. Whenever some contraceptive with high progesterone is used, mechanism of action is inhibiting ovulation. Okay? What is the mechanism of action in IUCD? IUCD basically does not let sperms go into tube. It kills the sperm into the uterus. So there the mechanism of action is inhibiting fertilization. It does not let fertilization happen. If fertilization happens, second mechanism of action is inhibiting implantation. So these are basic things of contraception that should be known. Okay. Not many questions have been asked on contraception. I don't know what else to cover in contraception, postpartum contraception, and one thing I'd like to mention here about vasectomy is another permanent method of contraception. Vasectomy may you ligate vas difference, and there are two methods: non-scalpel vasectomy and scalpel vasectomy. Only difference is the incision that you are making on scrotal skin. In non-scalpel vasectomy, on the scrotum you make a hole. You stretch it, you take the vas difference out. Scalpel vasectomy में पहले we used to give an incision, then take the vas difference out, and then we used to stitch it. So it was more invasive and painful and caused hematoma. But here you are making a puncture hole. You don't need to stitch it. No infection risk, less pain and no hematoma. But the success rate of both is same, 0.1%. Both have same success rate. Important that whenever you do vasectomy, the person is not infertile till 3 months. The whole system is filled with sperms. So unless there are 3 months, it takes almost 21 ejaculates to empty the whole vast difference from sperms. So you will not declare the person as infertile until 3 months, where you do the semen analysis first. And once the semen analysis shows azoospermia, then you declare this person as infertile after 3 months. So the couple has to use contraception for 3 months. Right? Infections. See, infections ko we study infections in 3 parts. Vulvovaginitis, what drug exactly you are asking for, beta? What drug you are asking for? Any postpartum contraception? हेलो मामी, अभी तो मेरी क्लास चल रही है, अभी तो मुझे लगेगा 1-1.5 घंटा. Tick. What drug exactly you're asking? The contraception you're asking me? What contraception? Yes, you will give her emergency drug, either ulipristal or levonorgestrel. We avoid inserting IUCD because of infection risk. But ulipristal or LNG pill, anything can be given in a effective as a post-exposure prophylaxis, as a post-exposure contraceptive. We avoid giving IUCD because there are chances that there might be some infections. That is why. Okay. Infections. We study infections in three parts: vulvovaginitis, cervicitis, and PID. Vulvovaginitis is a squamous epithelium. So the infections that cause vulvovaginitis are different from that causing cervicitis. Cervicitis is a columnar epithelium. So the causative organisms are different. Vulvovaginitis is caused by three organisms. Bacterial vaginosis. Bacterial vaginosis typically has a grayish discharge. And the diagnosis of bacterial vaginosis is by using Amsel's criteria. Amsel's criteria. Amsel's criteria has four things. Any three are present, that is bacterial vaginosis. What are the four things present in Amsel's criteria? Can you please tell me? Bacterial vaginosis diagnosed by Amsel's criteria. What are the four things which are there in Amsel's criteria? Okay. Okay. Right. Okay. Sorry. Not WBC. ठीक है? Whiff test, or you can say fishy odor. This is Amsel's criteria. Amsel's criteria is used for bacterial vaginosis. One another score is used for bacterial vaginosis. Nugent score. Nugent score may you just do a microscopy and you count the number of other bacilli. You count the number of Streptococcus and Mobilincus and you give a score. Okay, you don't have to remember score. You just remember that Nugent score is used for bacterial vaginosis, where you count how many lactobacilli the other bacilli are there. So normally Streptococcus, Mobilincus, Gardnerella are very less in number. But once they increase, it is called bacterial vaginosis. So you count the number of bacteria. And that is for bacterial vaginosis. What is the treatment for bacterial vaginosis? Bacterial vaginosis is not considered a sexually transmitted infection. It is not considered an STI. So will I treat the partner? I'm not going to treat the partner. Okay? Partner is not treated in bacterial vaginosis, remember. Because it is not a sexually transmitted infection. It is just the flora of the female vagina has changed. It is just the vaginal dysbiosis. So it is not sexually transmissible. Another vulvovaginitis is caused by trichomonas, which is a motile organism. It is an STI. Typical green discharge. Again with fishy odor. Diagnosis, microscopy. In microscopy, you will see motile organisms. These organisms can also be cultured, but easy one is you can see motile organisms with proper jerky movements. Okay? And what is the treatment for trichomonas? Again, metronidazole. Will I treat the partner? Yes, the partner here is treated. Okay? Third vulvovaginitis is caused by Candida. Candida is again right now not an STI. Caused by Candida albicans, the features are curdy discharge. Hello? हाँ. जैसे कल क्या था वैसे ही करो. अगर वो रोएगी तो मत ले जाना. अगर चली जाती है आराम से तो ठीक है. ठीक है. Significant itching. Though itching is there in all the infections. That is how you differentiate a physiological discharge from pathological. Physiological, normal discharge also happen in women, right? Okay? Estrogen influenced discharge happens, but there is no itching, there is no smell. Vaginitis always causes itching, but Candida has significant itching, significant swelling of vulva, red vulva, itching vulva, curdy discharges Candida. So what do I treat with? I treat with antifungal. Some antifungal cream is applied, or you can give fluconazole. It is not an STI, so partner treatment is not done in Candida. Okay? Itching is present, Betu. Itching is present in bacterial vaginosis, in trichomonas, in Candida. Itching is present in all of them. Candida has significant itching, significant excoriation, significant inflammation. That's what I'm saying. But itching, any infection, itching will be there. That is how you differentiate it from a physiological discharge. How to diagnose Candida? By using microscopy again. When you do microscopy in Candida, you see budding cells. Budding yeast cells are seen in Candida. So in all the vulvovaginitis, microscopy is the simple way of diagnosing. Cervicitis. Cervicitis is caused by bacteria, which is chlamydia and Neisseria gonorrhea. Patient will come to you with discharge. How will you know it is cervicitis? When there are two things that will tell you it is cervicitis. Either the discharge is coming from endocervix, or when you pass a swab through cervix, it bleeds. So these two things indicate that it is not vulvovaginitis, it is cervicitis. The causative organisms are different. They are bacteria and both are sexually transmitted. Both are STIs. Okay? Diagnosis of these two is by nucleic acid amplification technique. And what is the treatment? The chlamydia, the treatment is doxycycline. And for gonorrhea, the treatment is single injection ceftriaxone. So doxycycline for chlamydia, Neisseria gonorrhea, ceftriaxone. I can't use doxycycline in pregnancy. What will be my treatment for chlamydia in pregnancy? Who will tell me? The treatment for chlamydia in pregnancy. To be more specific, erythromycin. Erythromycin is used. Okay, very close. That is the treatment for chlamydia in pregnancy. PID. PID matlab when the infection has ascended up the cervix. Cervix se upar. Endometritis, salpingitis, oophorytis, pelvic peritonitis. All this is PID. PID is caused by same organisms. Now here, how the patient will present. Here the patient had discharge. When you examined, you saw the discharge coming from cervix. How the patient will present with PID? She has to be sexually active. A sexually active woman with pain abdomen, no other system seems to be involved. There is no other sign or symptoms showing us any other system involvement. And on examination, there is either uterine tenderness, there is either cervical tenderness, there is either adnexal tenderness. This indicate, not confirm, but this indicate PID. Sexually active women, pain abdomen, uterine, adnexal or cervical tenderness. This is PID. Causative organisms are same. How will I treat? You add these two. I will treat with doxycycline plus ceftriaxone plus, if so much infection has happened, obviously vaginal dysbiosis might have happened. Vaginal flora might have changed because so much infection is there. So I will add metronidazole. So the treatment for PID is doxycycline plus ceftriaxone plus metronidazole. Now, where the partner treatment is done? Partner treatment is done in trichomonas. Partner treatment is done in chlamydia and gonorrhea. Partner treatment is not done in Candida and in bacterial vaginosis. They are not STIs. I'm not going to treat the asymptomatic partner in them. Rest all, I will treat the asymptomatic partners. Okay? Question. What is true about trichomonas? What is true about trichomonas? Can we not culture it? We can culture it. It is not sexually transmitted. It is a sexually transmitted infection. On wet smear, cyst. Did I anywhere mention cyst? Trichomonas does not occur in cyst. Trichomonas, you can see on urine. If urine is infected on urine or cervical microscopy, you can see trichomonas with twitching mobility. Okay? There are very few organisms that cannot be cultured. Majority organisms can be cultured. Very few cannot be cultured, like Vibrio cholerae, Mycobacterium leprae, Corynebacterium. There are only few organisms. There might be some other, you can see the microbiology lectures, but there are only few organisms that cannot be cultured. Majority of you can culture. Okay? 28-year-old married female, anxious about conception, complain of profuse white discharge with no history of itching. Present to you on 12th day of LMP. ठीक है, 12th day of LMP मतलब she is in her proliferative phase. Proliferative phase मतलब estrogenic phase. When the discharge is very watery, very stretchy, and very profuse. As soon as she will enter the luteal phase, what happens through the discharge in luteal phase? It becomes dry and it becomes thick. So discharge is always there. So what is the most probable cause? There is no itching. When they have given no itching, it is physiological. Okay, rest all of them presents with itching. Okay, okay. Now I have told you what I have told you, that first, whenever a woman comes with infection, you check what infection it is. You do microscopy, you check the motile organism, you check the yeast cell, and then you treat. इसे हम कहते हैं etiological approach. But tell me practically, have you ever seen in your gynae ward anybody carrying a microscope? Anybody doing the microscopy of the vaginal smear? Have you ever seen that? That gynecologist is checking for the vaginal smear for any organism? No, it doesn't happen in our country. So, right. What we do is, so sexually transmitted infections ko treat karne ke, there are two ways. One is etiological approach, which is done in the developed countries, which we just discussed. They do nucleic acid amplification to see whether it is chlamydia or gonorrhea, and they treat accordingly. But in our country, we don't have that much. We don't even have microscope in every OPD. What we do is syndromic approach. Means based on symptoms we treat. How? If a patient has come to me with vaginitis, I know vaginitis is caused by 3 organisms. Why don't I make a kit which has antibiotics for all these 3 organisms? Why to go and diagnose it? If a patient comes to me with discharge and when I examined, I saw the discharge is from cervix, it is cervicitis. I know 2 organisms cause cervicitis. Let me make a kit having antibiotics for these 2, for gonorrhea, for chlamydia. Finish. Why to do nucleic acid amplification? No doubt I am over treating. Maybe she has only chlamydia, not gonorrhea. I am over treating, but at least it is not expensive. At least the patient is not lost to follow up. So for developing countries, syndromic approach is best. And that is why the NACO guidelines have come up with the kits. Kits for managing sexually transmitted infections. They have made kits based on the symptoms of the patient. You tell me the symptom, I'll give you the kit. And that kit has antibiotics for all the probable causative organisms. Okay. If a patient has vaginal discharge, obviously you will examine first. He comes to you with discharge, you examine it is vaginal. So remember vaginal discharge, there was trichomonas causing green discharge. Green kit. Green kit is for vaginitis. So vaginitis has green kit. अभी थोड़ी देर में we'll study ulcers. Ulcers can be herpetic and non-herpetic. Means ulcers caused by herpes and non-herpetic. Herpetic ulcers are very painful, very painful. They're red and painful. red kit. Patient comes with pain abdomen. If a sexually active woman comes with pain abdomen, I am thinking about PID. ठीक है, so pain abdomen, P for pain, P for पीला, या फिर दर्द से लाल पीला होना. How do you explain pain? दर्द से लाल पीला होना. लाल is done, yellow kit. For pain abdomen, I'm suspecting PID, yellow kit. Obviously, what is there in yellow kit? It has antibiotics for Neisseria gonorrhea, for chlamydia, and metronidazole. So pain abdomen, yellow kit. ठीक है. Non-herpetic ulcers. Herpetic ulcers, red kit. Non-herpetic ulcers, they are non-herpetic. There are multiple causes of non-herpetic ulcers. Syphilis, chancroid, LGV, many. So non-herpetic ulcer, remember ulcer that happen in your mouth? They are what color? White. White kit. ठीक है. Not blue. I'll tell you where blue. Non-herpetic ulcer में a very common infection is syphilis. White kit has penicillin in it. Because we have to treat syphilis also. Syphilis का एक ही treatment होता है, penicillin. Certain people are penicillin resistant. Penicillin resistance is very common. So in case of penicillin resistant non-herpetic ulcer, because I know that white kit में penicillin is there. If somebody is penicillin resistant, then in that case, what kit I will give? So somebody who does not like pencil, I will give a blue color pen. They use that blue pen. So blue kit. In penicillin resistant non-herpetic ulcer, blue kit. In a normal non-herpetic ulcer, white kit. Herpetic ulcer, red kit. Inguinal buboes means inguinal lymph node. B for buboes, B for black kit. Now, vaginal discharge was green. Rest all discharge, which can be cervical, it can be rectal, it can be urethral. Rest all discharge, which is like a big gray mammoth discharge from anywhere. Gray kit. So these are the syndromic management where based on syndrome, I have added the antibiotics, made the kit. Okay. No. There is no brown kit. Rectal discharge is gray kit. Rectal, cervical, urethral discharge, gray kit. There is no brown kit. Okay? So these have been made by NACO, especially for Indian scenario. So we have to know the kits. What is inside kit? You don't have to worry. Even if you will think, even if question comes, what is there in green kit? Can I think what is there in green kit? It is for vaginitis. Obviously, there will be metronidazole. Obviously, there will be fluconazole. If I know how the infection is treated, I will know what is there in the kit. Okay. Okay. A lady present with vaginal discharge on examination, she has cervical erosion. What kit will you give her? What kit will you give her? Everyone else? Vaginal discharge hai, ठीक. It doesn't mean कि it is vaginitis. Patient will tell you I have discharge. Now you have to check it is vaginitis or cervicitis. You checked, it is cervical erosion, it is cervicitis. We'll give gay kit. So just by seeing vaginal discharge, don't mention green kit. Vaginal discharge bracket में vaginitis. That is green kit. Okay? Okay? Here is my, just give me a second. I had a very, just wait, I had a beautiful slide for making For ulcers, no, I have a very beautiful slide. Let me find that for ulcers. Then I'll just show you. It is getting tiring, I know, but we have to finish. No, what do we have to finish? Remember, this discussion is not the last one. If whatever confusions are coming to your mind, you can always come and ask. ठीक है. अरे, where are the ulcers? Okay, this is one. Hmm. Yeah. ठीक है. This was clear. Now little bit about, so infections was clear to everyone and kits was clear to everyone. Brown kit. Okay. If it is latest, maybe I might have missed it. Is it okay if I check today the narco kits again? Maybe it is something which is new, it has been added. Let me check what is the latest, whether kit brown has been added or not, and I'll get back to you on the group. Will that be okay? Thanks for telling me, because I didn't know if it has been updated or not. Okay, I'll definitely check. Okay, I have to note it down somewhere. Narco STI kits. I'll check. Okay. Little bit about ulcers. Just like we read vaginitis, now a little bit about ulcers. Whenever question gives you ulcer, always see whether it is painful or painless. Painful ulcers are only two. Okay? Whether it is painful or painless. If it is given painful, there are only two ulcers which are painful. And that is herpes and chancroid. Herpes are multiple small vesicular ulcers, small punched out clean ulcers. Lymph nodes are also painful. Chancroid, maybe lymph nodes are painful, but it is generally one ulcer or maybe two large ulcer, irregular margins, dirty bleeding base. So multiple punched out clear ulcers is herpes, but one or two large bleeding base ulcer is chancroid. Both are painful with painful lymph nodes. Now, if the question gives you painless ulcer, then you have to look at the lymph nodes. ठीक है? Hello? 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 Painless ulcer, painless lymph node. A very sweet ulcer. Neither lymph node is painful nor ulcer is painful. That is why patient doesn't come for treatment. Because remember, all the genital ulcers, all of them are sexually transmitted infection. And patient knows that it is sexually transmitted. So patient doesn't come, resulting in complications after 10 years. Syphilis. Why complications happen? Why it leads to tertiary and secondary stages of syphilis? Because nothing is painful. Neither ulcer, neither lymph node. And patient doesn't come for treatment, it resolves by itself. Remember, patient always comes when pain is there. Painless ulcer, but ulcer is painless, but the lymph nodes are very painful. Okay, very painful lymph nodes. Lymphogranuloma venerum. LGV, lymph nodes, very painful. Ulcer is not painless. Ulcer is painless. Patient will not come for ulcer. Patient will come for lymph nodes, LGV. Okay? And lymph nodes are so painful and enlarged. Yes, yes. Ulcers are so, the lymph nodes are so enlarged and painful that there is something called as groove sign. Inguinal ligaments form a groove between upper and lower lymph nodes. So groove sign is positive in LGV. There is an ulcer where it is painless, but the lymph nodes are absent. There are no lymph nodes. It is granuloma inguinal. Now, granuloma inguinale looks like lymph node, but it is not. It is the granulomas, the skin induration form at the inguinal area. It looks like lymph node, it is not. Granuloma inguinale में जो that skin induration at inguinal area is called as pseudobubos. So what you get is pseudobubos in granuloma inguinale. And what you get in LGV is groove sign. They all are sexually transmitted infections. So whenever I'm treating these ulcers, चलो इस next slide पे देखते हैं. So herpes are painful, multiple vesicular ulcers, lymph nodes are also painful. Causative organism, obviously herpes. The treatment should be known to you, acyclovir. Syphilis, painless ulcer, painless lymph node, treatment of syphilis, penicillin. Chancroid, another painful ulcer caused by Haemophilus ducreyi. Treatment azithromycin, single dose. Lymphogranuloma venerum, where ulcer is painless, but the lymph node is painful, caused by Chlamydia trachomatis. Treatment is doxycycline. Granuloma inguinale caused by Klebsiella granulomatis. Azithromycin again. So if I tell you there was a kit, which was herpetic kit, red kit, what was there in herpetic kit? Acyclovir. What was there in non-herpetic ulcer kit? In white kit, what was there in white kit? Azithromycin and penicillin and doxycycline. Okay? Remember, all the ulcers are sexually transmitted infections, all of them. So I will treat the asymptomatic partner in all of them except one. Among these, in except one, I'm not going to treat the asymptomatic partner. Can someone tell me where I'm not going to treat the asymptomatic partner? In which of these infections I'm not going to treat the partner besides it being STI? Correct. In herpes is sexually transmitted. But in herpes, we don't treat the partner because it is a viral infection. Viral infection में treating an asymptomatic partner will not help. Virus has entered your body, it will keep on occurring. Even if you give antiviral can only reduce your symptom. It cannot remove the virus from your body. So giving it to an asymptomatic partner is of no use. Bacterial infection में, when you give antibacterial to this partner, this antibacterial will remove the bacteria from the body. So it will help. But viral infection may we don't treat the partner, even if it is sexually transmitted. So infections where I'm not treating the partner is bacterial vaginosis and candida. Why? Because these are not sexually transmitted. Another infection where I'm not treating the partner is herpes. It is sexually transmitted, but it is viral. So I'm not treating the partner. In rest all, I will treat the asymptomatic partner. Otherwise, this women will again get the infection. Okay? Buboes is inguinal buboes. All these cause inguinal buboes, all of them. Inguinal lymph nodes are called as inguinal buboes. Okay? Got it? So this is done. Now let's do some questions. Yeah. Lady with multiple partner has perineal ulcer, painless, and inguinal lymph node, which is also painless. What is it? Everything is painless? What is it? Correct. Syphilis. Good. What is this? Some infection just at the hymenal opening, just at the vulval opening. What is this? Bartholin abscess. Now here, even if I'm not sure it is Bartholin abscess and not even if I'm seeing it for the first time, does herpes present as swelling like this? Syphilis present as ulcer, not like this. Candida present as a cheesy discharge. So this swelling seems like an abscess. Even if I don't know what it is Bartholin abscess. A patient with vaginal discharge which eventually stopped. Now she has pain. Now, even if you are seeing it for the first time, can you answer this question? Now she has pain abdomen. Pehle there was discharge, but now it has ascent up causing pain abdomen. What is it? Yes. So basically the vaginal discharge was cervicitis and now it has ascent up and it has caused PID. ठीक है, all of these cause vulvovaginitis, this cause ulcers. ठीक है ना? Now there was a question in 2024, there some smear was given and they asked what infection it is. Now nobody is clear what smear was given. So I just want to show you certain vaginal smears. This pink cells, and can you see gram positive rod-like bacilli? Can you see this? It is normal smear. When I see this pink cell, but can you see this pink cell is so clear, but this one is so granulated, filled with some gram negative bacilli, and I cannot clearly see the margins. I cannot clearly demarcate the margins. Can you see the margins are obscure? Can anybody tell me what cell is this? Where it is so granulated, I can't even see the margins. It is glue cell. Glue cells are studded with bacteria. The margins are not clear. So it is bacterial vaginosis. When I see something like this, a flagellated organism, trichomonas. Okay? Now, so these are simple. I can see budding yeast cell, that is candida. Okay, now when I see something like that, when I see the nuclear changes happening, can you see this nucleus in other cells? It is small compared to the cell. The nucleus is small. Okay? Strawberry cervix is seen in trichomonas. So strawberry cervix is not cervicitis. Basically, what happened in trichomonas, the cervical vessels dilate. The pinpoint vessel dilate is not cervicitis, and when you examine locally or on a colposcope, you see cervical vessel dilatation, looks like a strawberry. When I see the nuclear changes, it is a viral infection. Can I see the nucleus has enlarged and it is bilobed? Enlarged bilobed nucleus. And can I see big? Can you see these big perinuclear halos? Can you see these big perinuclear halos? These one, big one. It is herpes. So herpes has enlarged nucleus with big perinuclear halos. HPV, how HPV presents, that was I was thinking where my slide has gone. HPV ki I'll just show you a slide. HPV may be exactly like this is there. The cell is there, the nucleus is enlarged and it is multinuclear. It is multinuclear and there are dense inclusion bodies are there. You see a big large body inside the nucleus. It is very darkly stained and inclusion body is there. That is the coliocytes. Okay? I'll just show you a picture of coliocytes also. Nugent score is used for diagnosis of? Nugent score is used for diagnosis of what? Bacterial vaginosis, correct. Cogwheel sign, this is what? This is what? Can I just, by just seeing this, can I identify the structure, what it is representing? It looks like, does it look like uterus? No. Cogwheel sign is a tube which is enlarged. It's a tube which is enlarged and there are septas. So it is an abscess. The tubercular abscess, the pyoselpinx. Pyoselpinx present as this cogwheel appearance. Can you see this? See this image. This is the uterus. They have seen the cervix also. This is the uterus. This is the endometrial cavity. This dilated structure like this. Tubes, see, tubes are like this, no? So if they will get enlarged, they will look like this only. If they will get enlarged, they will look like this. And abscess always has septa. This is tube filled with abscess. This is pyosalpinx. Okay? Now you know what is this. A woman has undergone ovarian stimulation under IVF. What it is, our ovaries get overstimulated. We know this. OHSS. You know? It is OHSS. Why it is not theca lutein cyst? Theca lutein cyst look exactly like that. There is no difference. Only difference is in history. They have clearly given a history of IVF. That is why it is OHSS. Ultrasound appearance is exactly the same. This is PCOS. A women with infertility and dysmenorrhea, following image is seen. What it is? Infertility and dysmenorrhea. So there is a triad. Infertility, dysmenorrhea, dyspareunia. This typical triad is seen in endometriosis. Or endometriosis may there is chocolate cyst. So what it is? Typical endometriosis, chocolate cyst, correct. Pain after 6 months of delivery. Now she has complaints of pain at episiotomy site and increase during menses. So whenever there is anywhere pain which increase during the menses at a random place, episiotomy site पे हो रहा है, ठीक है? Sometimes patient has hemoptysis all the time during menses only. It is always endometriosis. The far-flung areas showing some symptoms because of menses. So it is endometriosis. What is it? Tubercles are filling the whole pelvic cavity. Tuberculosis. Pelvic floor. I think before, let's not do the questions. We don't have much time. Let's just see what we should know about pelvic floor disorders. Do you guys want a break or do you guys want to finish this? Or you want a 10 minutes break? If you want, we can take a 10-minute break, meet at 6 and finish it at 10-minute break. I also feel so, hai na? It's okay. We can meet at 6. We'll finish it in 45 minutes. This is just a matter of 45. Let's just get a little. Okay, everyone is finish. Chalo, ठीक है. Everyone else, please. Why there are equal votes, exactly equal number of votes. 10 minutes, please. Let's meet at 6. Okay? 8 minutes are more than enough. Let's meet at 6. Okay? Okay. Should I start now? Little bit about pelvic organ support followed by oncology and then we'll finish. So pelvic organ supports are basically three types. We know one is muscular support given by pelvic diaphragm. Pelvic diaphragm is formed by levator ani. Levator ani plus one more muscle forms pelvic diaphragm, coccygeus. They together form pelvic diaphragm and they provide muscular support, certain ligamentous support, and the certain support due to the position. Talking about position, the uterus is always at an angle. It is never straight. It is always at an angle. So the angle between the cervix and the vagina. So cervix and vagina is anteversion. So there is an V here. So angle between cervix and vagina is anteversion, which is a 90-degree angle. The angle between uterine body and cervix is anteflexion. Between the body and the cervix is flexion, and this angle is 120 degrees. Okay, so this is a mechanical support. Muscular support is by levator ani. Question is asked, which muscles form levator ani? There are three muscles which form levator ani. From pubis to rectum, puborectalis here. Okay. Another one is pubococcygeus, puborectalis. Then ischiococcygis. Sorry, iliococcygeus. So three muscles forming levator ani is puborectalis, pubococcygeus, and iliococcygeus. One another muscle innervated by a different nerve is ischial spine se originating ischiococcygis. Ischiococcygis is not a part of levator ani. Please remember, levator ani is formed by only three muscles. Ischiococcygis, also called as coccygeus, is not a part of levator ani. It forms muscular diaphragm but not levator ani. Ligamentous support, there are primary, some very tight ligaments which are supporting it. So some very tight primary ligamentous support are three-tier system. Anteriorly, pubocervical, transversely, transverse cervical, posteriorly, uterosacral. So these are holding the uterus and cervix from three sides. These are primary ligamentous support. There is also something secondary ligamentous support. It's a very weak support. Secondary ligamentous support is a weak support, that is round ligament. Round ligament is a very weak ligamentous support. So question, ligament that maintains anteflexion, something that is pulling the uterine body anteriorly. So anteflexion is by pubocervical and round ligament. Both maintain anteflexion. Ligament that prevent retroversion, मतलब antiversion रहना चाहिए between body and vagina. There should be antiversion. So ligament that is maintaining this antiversion is one pulling it from behind, from here. That is uterosacral. Uterosacral is the one pulling it from behind, maintaining antiversion. Most important support of uterus is levator ani. It is the most important support. Muscle which is not part of levator ani, coccygeus. Ligament which does not support uterus at all, which does not provide any support, broad ligament. Broad ligament does not support uterus at all. Okay? Now, whenever there is pelvic floor disorder, we use, how do we classify it? We classify it using this grid. इसे हम कहते हैं pelvic organ prolapse quantification. So this POPQ table is made for uterine prolapse. ठीक है? You don't know how to make that grid. You don't need to understand. Just remember this grid is for pelvic organ prolapse. Now coming to the surgeries, it is very important because I feel students don't understand right now how to manage the uterine supports. See, uterine prolapse can be anterior vaginal wall, posterior vaginal wall, and apical prolapse. So prolapse can be of three types. If it is an anterior prolapse, anteriorly the prolapse hoga, to what is there anteriorly? It is either cystocele or it is either urethrocoele. So cystocele or urethrocoele are the one which comes in anterior prolapse. So what do you do when there is anterior vaginal wall prolapse? When there is cystocele, what do? You do anterior colporrhaphy. Colporrhaphy matlab tightening of the vagina. Colporrhaphy, repairing it. When there is posterior prolapse, what is there in the posterior part of uterus? Posterior part means there is rectum. So there is always rectocele. Rectocele is posterior vaginal wall prolapse. How do you manage? Posterior colpography. Talking about apical prolapse. Apical prolapse may, there are two things that come. Either uterine prolapse happen, or remember this is uterus. The posterior part of uterus has rectum. So rectocele happen. Enterocele means bowel coming from above, coming through posterior fornix here. It is not posterior prolapse. It is apical prolapse. So enterocele means bowel coming down is apical problem. It is apical prolapse. It is not the problem of posterior vaginal wall. So how to manage them? Just abhi forget uterine prolapse. I will tell you how to manage uterine prolapse. How to manage enterocele. Enterocele is happening because this pouch of Douglas was here. This pouch of Douglas has got weakened, and that is why it is sagging down. So pouch of Douglas ko what else do we call? We call it cul-de-sac. So it is enterocele repair is done by culdoplasty. Since it was invented by Meckel, so we call it Meckel culdoplasty. So enterocele may we open the posterior cul-de-sac, push the bowel above and tighten the cul-de-sac. It is called as Meckel culdoplasty. Now important is how to manage the uterine prolapse. See, the ideal management of uterine prolapse is hysterectomy. But prolapse can happen in a reproductive age woman when you do not have to remove the uterus. If you want to preserve the uterus, then what will you do? The best surgery for preserving the uterus is sacrohysteropexy. You take a mesh, tie it with the uterus, pull it above, tie it with the sacrum, the anterior sacral ligament. इसे कहते हैं sacrohysteropexy. You have tied the uterus to the sacrum. So now you have preserved the uterus. So either you can do hysterectomy if uterus is not needed. If she is a person who has to complete family, do his sacrohysteropexy. And remember, if she is a very old, fragile woman, she can't undertake such long surgeries, then you stitch the vulva, you stitch the vagina. In very old, fragile, risky women, leave foot. There is a problem which is called as cervical elongation. Cervical elongation, when the cervix is getting elongated, is not uterine prolapse. It is cervical elongation where fornix get deep. So when there is cervical elongation, what you do is Fothergill's. Fothergill may you cut the cervix, amputate the cervix and tie the remaining cervix with the ligaments. So Fothergill is not done for uterine prolapse. Fothergill is done for cervical elongation. Okay? A para to live to women present with cervical elongation. What surgery should be performed in her? When there is cervical elongation, I will do Fothergill. Yes. Okay. Young women present with prolapse, sacrocolpopexy is done. Where will the mesh be fixed? Mesh is fixed to the ligament anterior to sacral promontory. Okay. That's it. एक क्वेश्चन आया था ऑन एंटेरोसील रिपेयर. रिमेंबर एंटेरोसील रिपेयर को आप मेकेल कल्डोप्लास्टी से ट्रीट करते. ठीक है. लिटिल बिट अबाउट जेनाइटल फिस्टुलास. Genital fistulas can be is a abnormal communication in the genital organs. Vesico-uterine between bladder and uterus. Vesico-vaginal between bladder and vagina. Urethro-vaginal between urethra and vagina. ठीक है. Causes. In India, the most common cause of fistula is obstructed labor. Prolonged obstructed labor is the most common cause. That is why the most common fistula in our country is vesico-vaginal. When the head is stuck in the vagina, it is stuck for so long that necrosis happen, resulting in abnormal communication with the bladder. So vesico-vaginal. In developed countries, the most common cause is surgical hysterectomy. That is the most common cause. So in developed countries, when the hysterectomy happens, the fistula that forms is ureterovaginal. Ureter is injured, forming communication with vagina. So there the most common fistula is ureterovaginal. ठीक है? Most common surgery that is leading to fistula formation is simple hysterectomy. Simple hysterectomy is done so extensively, so many numbers are there that it is the most common cause of surgical fistulas. But the most risky hysterectomy causing fistulas is radical hysterectomy. It is the most risky hysterectomy. ठीक है? How the fistulas present? So there are generally commonly three fistulas: vesico-vaginal fistula, ureterovaginal fistula, and urethrovaginal fistula. How will it present? Vesico-vaginal fistula will continuously leak. Ureterovaginal will also continuously leak. But urethrovaginal, urethra and vagina, urethra may there is no urine. Urethra may urine comes only when patient pass urine. When she pass, then only urethra gets urine. So there is leak only when she is micturating. As such, there is no leak. When she micturates, then along with passing urine, the urine leaks through vagina. So there is no continuous leak. Another feature in vesico-vaginal fistula, the bladder is never full. Whatever urine comes in bladder, it goes to the vagina. Whatever it comes, it goes to the vagina. So patient does not urinate at all. The bladder is not filled. In ureterovaginal, one ureter is giving urine to vagina, continuous leak. But another ureter is filling the bladder. So patient will urinate. Her bladder is getting filled. Here also she will urinate. But in vesico-vaginal, she will not urinate. The bladder is completely empty. So these are the symptoms that will indicate which fistula it is. Then you can also identify by seeing the dye test. If you insert 3 swabs, if the lowermost swab is stained blue and you fill the bladder with methylene blue, if the lowermost swab is stained, it is urethrovaginal. If the middle swab is stained, it is vesico-vaginal. If the uppermost swab is wet but not stained, why it is not stained? Because the dye has not reached the ureter. The ureter does not have dye. So it will be wet but not stained. It is uretrovaginal. Okay? When do you repair fistulas? If you have diagnosed it during the surgery, immediately you repair it immediately within 24 hours. But if you have missed it initially, if you have missed it for one day, now so much inflammation develop, you can't repair. You have to let the inflammation and swelling got settled. So then you repair after 8 to 12 weeks. So either repair immediately within 24 hours or then wait for 8 to 12 weeks. Okay? So anybody who has gone fistula repair, there you will advise her to avoid abstinence for 6 weeks. No. Avoid abstinence for 3 months and avoid pregnancy for 1 year. Once you have repaired the fistula. Now we come to oncology. Oncology means let's finish. This is first endometrial pre-malignant lesion, endometrial cancer, then cervical and then ovarian. Okay? Endometrial cancer, see, before turning into cancer, there is always some pre-malignant lesion. So if endometrium is exposed to excessive of estrogen, there will be hyperplasia. Simple hyperplasia means glands are enlarging. Complex means glands are too much in number. But when atypia happens, atypia matlab nuclear changes have started happening. So simple and complex hyperplasia have risk of cancer in only 1 to 3%. Very less risk. But complex hyperplasia has a risk of cancer of 8 to 20%. So how are you going to manage anybody with simple hyperplasia? Here the treatment is progesterone releasing IUCD. Progesterone IUCD is given in simple and complex hyperplasia without atypia. If there is atypia, then the treatment is always hysterectomy. Okay, because the risk of converting into cancer is high, so treatment is always hysterectomy. So treatment of endometrial cancer. Endometrial cancer presents at age of 60 years and the most common symptom is abnormal uterine bleeding. That is the most common presentation. Any condition which has high estrogenic condition is a risk factor for endometrial cancer. Any patient who is obese, any patient who is diabetic and hypertensive, patient who have anovulation. So anybody with high estrogenic condition will lead to endometrial cancer. So what is the treatment of endometrial cancer? Irrespective of the stage, it is very simple treatment. Simple hysterectomy. So remember, endometrial cancer may we do simple hysterectomy. Plus we add radiation. Now depending on stage, the radiation dose will change. If it is stage 1, it is only pelvic radiation. If it is stage 2 and 3, it is external beam radiation. It is brachytherapy, it is external beam radiation. If it is stage 4, then it is whole abdominal radiation. So how much area you are covering, that will change depending on stage. But the hysterectomy will be simple hysterectomy for plus oophorectomy. So here the treatment is simple. Do the hysterectomy and then give the radiation. Depending on the stage, the area you are covering in radiation is different. It is unlike cancer cervix where stage-wise hysterectomy is also different. Okay, coming to cancer cervix. So cancer cervix की पहले screening पढ़ते हैं. Screening can be done using cytology. ठीक है, this is our spatula and cytobrush, where we take the sample, make a slide and see it under microscope. ठीक है, another one is liquid based cytology, where same thing, we are taking the sample but instead of slide we are just putting it inside a liquid can. The preservative which is used is ethanol. Ethanol 95% is used as preservative. And we see the cytology, we see the individual cell. And this result we get either LCIL, low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, adenocarcinoma, atypical squamous cells of high significance. So this type of report we get by seeing individual cells. Another method of doing cervical cancer screening is visual inspection. Visual inspection after applying acetic acid. When we apply acetic acid, the cancerous cells, because of high protein, turn snowy white. The protein got dense, it gets coagulated, and you see a dense white patch. That is visual inspection with acetic acid. When you apply Lugol's iodine, a normal cell turns brown. Because of high glucose, it turns brown. But cancerous cell don't has much glucose. It has more protein. So cancerous cell will not get stained. So by visual inspection using Lugol's iodine or acetic acid, we can see the cancerous cells, we can see the suspicious cells and can take the sample. So this is the second method. And another is HPV DNA detection. The most recent one, take the cervical sample, detect the HPV DNA in it. Important when the cervical screening is started. Remember, this is the updated one. So if any of your book has given you a older version, please change it. Starting age is 25 years. 25 years pe we start the screening, not 20 years, not 21 years. We start the screening at 25 years. What is the primary test that is used for screening? HPV. Human papilloma virus repeated every 5 years is the primary test. If a center does not have HPV, then we go for pap smear. Otherwise, we do HPV screening in everyone. Okay? Till what age? Till 65. Okay? If it is a poor resource setting, if question has given you it's a poor resource setting where there is no lab, there we do visual inspection. Remember via villi? It doesn't need a lab. Just apply acetic acid or Lugol's iodine and see and take the sample. So in a poor resource setting like ours, we do via villi at age of 30 years. Here screening is started at 30 years. And whatever suspicious lesions are there, you take the sample. Okay? So what is the primary test for screening? HPV. The starting age, 25. In a poor resource setting, visual inspection. How to manage? So whenever you have done cytology and you have got some kind of report, like you have got LCIL. So if you have got LCIL, you do go for conservative method. It is low grade squamous intraepithelial lesion. But in case you get HCIL or you get atypical squamous cell, of high significance. In that case, you need to go for biopsy. Biopsy can be naked eye biopsy or colposcopic. Colposcopic matlab microscope लगा के you see the cervical cells and take the biopsy of suspicious cells. So either use a naked eye or use a colposcope and take biopsy. Biopsy will give report like this. Biopsy will tell you that how much abnormal invasion has happened. Biopsy आपको देती है depth of invasion. Cytology gives you individual cell change. When I've taken a chunk of tissue, it will tell me how deeply the cells have invaded. CIN1, only lower 1/3 has been invaded. CIN2, 2/3 invaded. CIN3, whole depth invaded. But basement membrane is intact. As soon as the basement membrane breaks, it is cancer. So biopsy will give you me either CIN1, 2, or 3 report. Biopsy can also give me invasive cancer. So how to treat these cervical, these are pre-malignant. If not treated, they will turn into cervical cancer. So how to treat them? CIN1, you don't treat, but you retest using HPV and pap smear after 1 year. CIN1 में you don't have to treat. But CIN2 and 3, you have to treat. And the treatment for CIN2 and 3 is simple. Large loop excision of transformation zone. LEEP or leads. You take a loop and you remove the whole transformation zone. If the transformation zone, this is the transformation zone between the old and new squamocolumnar junction is transformation zone. If the whole transformation zone is not visible, then conization. Cryo भी करते हैं, cryotherapy भी करते हैं, but that is not the primary choice. The primary choice is large loop excision of cryoablation is done. Okay, if you don't have leads then, but the primary choice if given a question treatment for CIN2, leads, cryotherapy, hysterectomy or conservative leads. That is the primary test. You remove the whole transformation zone. Cryoablation is in secondary, it's a secondary treatment. Second choice. If the whole cervix transformation zone is not visible, remove the whole cone. Do conization. Okay? So this was about detecting and treating the precancerous lesion. What about vaccine? So remember the routine. See, HPV vaccine के two routines हैं. One is CDC and this is followed by our country. Another one given by WHO, SAGE guidelines. You have to remember both. Our country says that, so this is same for both. Starting of vaccination is at 9 years. You start vaccination at 9 years. From 9 to 14, you give 2 doses. From 15 to 45 years, you give 3 doses. This is a normal dosage vaccination according to CDC and according to our country. 9 to 14, 2 doses. After 14, 3 doses. Now, WHO has given a low dose regime. Remember, WHO ने low dose regime दिए because it has seen that people are not getting vaccinated. So, low dose regime is 9 to 20 years. Either 1 or 2 dose. Anything. Our guidelines don't say so. Our guidelines say 2 doses. But you have to remember both. Last year, WHO's vaccination schedule was asked. So 9 to 20 years, 1 or 2 doses. More than equal to 21 years, 2 doses. This is the WHO regime. You have to remember the both regimes. Okay. If you have read anything other than that, then that is older one because I have recently updated vaccination schedule and screening schedule. Okay. We have these many vaccines. Cervarix is bivalent. Since it is bivalent, it is given only in females. Gardasil quadrivalent and nonavalent are against genital warts also, so given for males and females both. Recently, an Indian vaccine has come up, Cervavac, which is again quadrivalent. It is by Indian Serum Institute and it is given in males and females both. Okay. We'll do that question. That's an easy one. Cervical cancer. Cervical cancer is what type of cancer? It is a squamous cancer. Most common symptom is vaginal bleeding, especially post-coital bleeding. What is the age? Cervical cancer has two peaks. One is at 45 and another one is at 60. So there are two peaks which are seen at cervical cancer. Okay? What are the risk factors? Cervical cancer is basically a behavioral cancer caused by HPV. Now, HPV is a sexually transmitted infection. So obviously, whatever increase the risk of transmission, that will increase cancer risk. Like young age at intercourse, multiple partners, HIV patient, unhygienic patient. So whenever there is a high risk sexual behavior, risk of cervical cancer will increase. Okay. Treatment is extremely important. So treatment of cervical cancer depends on stages. Endometrial cancer treatment was very simple. Simple hysterectomy. Why simple? Because we are covering it by radiation afterwards. Cervical cancer में we don't give radiations afterward. ठीक है? So we either do hysterectomy or we give chemo radiation. ठीक है? So stage wise treatment. See, every treatment has a uterus preserving treatment and uterus non-preserving treatment. Every stage. In the first stage, only first, stage 1A1, you can preserve the uterus. And the procedure that you do is simply removing a cone, conization. If you don't want to preserve uterus, you will do simple hysterectomy, that is type 1. That is applicable only for stage 1A1. Stage 1A2 till 1B1. In 1A2 and 1B1, in next two stages, can you preserve the uterus? Yes. But what you have to do is modified radical trachelectomy. In trachelectomy, along with cervix, I remove some part of paracervical and vaginal tissue also. So it is trachelectomy. If she wants to remove her uterus, yes, I can. But here I will do hysterectomy, not simple. Modified radical hysterectomy. Modified radical, that is type 2. So first में I did simple hysterectomy. Next 1A2 and 1B1 में I did modified radical. ठीक है? From here 1B2 to 2A1. Next 3, 1B2 to 2A1. In next 3 stages, I cannot preserve the uterus. I can't do any uterine preserving surgeries. I have to remove the uterus. And uterus removal is by radical hysterectomy. That is type 3. Up till what stage? Up till 2A1. After 2A1, now I can't do any surgery. I have to go for chemo radio. Got it? So 1A1, preserve uterus by doing conization or simple hysterectomy. Next, those stages, 1A2, 1B1. Preserve uterus by doing trachelectomy. Don't want to preserve, do modified radical hysterectomy. Next 3 stages, 1B2, 1B3, 2A1. In next 3 stages, can't preserve uterus now. Remove uterus doing radical hysterectomy. What about after 2A1? Chemo radio. Okay? A lady with necrotic lesion on cervix was diagnosed as cancer cervix involving lateral pelvic wall. So lateral pelvic wall is stage 3. So what will be answer here when it is involving the lateral pelvic wall? Correct. Chemoradiation. Simple. A 14-year-old daughter underwent radical surgery for mother of 14-year-old daughter went surgery for cancer cervix. What should be done in her daughter? So in cancer cervix, did we anywhere read genetic as the risk factor? Cancer cervix is a behavioral cancer because of behavior of your sexual behavior. So it has nothing to do if her mother had cancer, doesn't mean daughter will have cancer. So what will you do? We will vaccinate her. Like every girl, we will just vaccinate her. We don't check for cervical biopsy. Okay? Cervical cancer staging, extension to pelvic wall. I think you can know that. This finishes the cervical cancer. Now we come to the ovarian cancer. Finally. So ovarian cancer, see, ovaries has various types of cancer. Why? Because cancer can arise from anywhere in ovary. Some cancer arising from epithelium. like serous and mucinous. When they are benign, we call them cystadenoma. When they are malignant, we call them carcinoma. They are epithelial, they are most common ovarian cancer. Cancer can arise from these germ cells, these follicles, germ cell tumors, common in young age, in reproductive age women. Okay? If it is benign, yes, germ cells can be benign. They are called as dermoid cyst. They are the most common germ cells tumor in a young woman. Epithelial cell cancer happen at 60 years and they are the most common. Germ cell tumors happen at around age of 35-40. Malignant germ cells tumors होते हैं and they are dysgerminoma. Dysgerminoma is most common malignant germ cell tumor. Other than that, immature teratoma, yolk sac tumor. Now the stroma in between, this connective tissue in between, the granulosa and theca cell in between, they can also form cancer. इसे कहते हैं stromal cell cancers. ठीक है? Stromal cell cancer can be benign again, fibroma, thecoma. Malignant is granulosa theca cell tumor. So granulosa theca cell tumors, Sertoli Leydig cell tumors, obviously they are hormone secreting. They are hormone secreting tumors. So these are the three areas from which tumors arise. Most common epithelial type. What are the risk factors for ovarian tumors? Anybody who has never been pregnant, who has never lactated, has ovarian cancer risk. Nulliparity and infertility. Okay? How it presents? It presents as a solid, irregular, fixed mass, okay, with very vague symptoms. That's how it presents. There are certain things that can be seen. Can you see Cole-Exner bodies and coffee bean appearance? Can you see coffee bean appearance? The nuclei has a induration coffee bean appearance and they are arranged in these circular forms. So Cole-Exner bodies and coffee bean appearance are seen in correct granulosa cell tumors. Certain tumors show these ring-like calcifications called as Samoma bodies. Samoma bodies. Samoma bodies are seen in which type of ovarian cancer? Epithelial में which type has Samoma bodies? If you are talking about epithelial, which type of epithelial tumors has Samoma bodies? Serous. Correct. Serous cell. They have Samoma bodies. Okay? Some of the ovarian tumors are hereditary. Okay? They run in family. 15% of ovarian tumors are hereditary due to what gene? BRCA1 and BRCA2. They are breast risk cancer antigen, but they can cause ovarian cancer also. So somebody who is BRCA1 or BRCA2 positive, they have a risk of ovarian cancer 57% and risk of breast cancer 80%. Such a high risk of cancer if the family has this BRCA gene. These are called as hereditary cancers. So in hereditary cancers, what do you have to do? You have to advise hysterectomy before 40. Because after 40, risk of ovarian cancer will increase. So you tell her, anybody who's BRCA positive, that she has to undergo oophorectomy before 40. Before that, can I give some chemo prevention that can delay cancer development? It will not prevent completely. It can delay cancer prevention. There is one chemo prevention, OCPs. If I give OCPs, the development into ovarian cancer will be delayed. So in hereditary cancer, for some time I can give OCPs, but eventually she has to undergo oophorectomy before 40. Okay? How to diagnose ovarian cancer? Whenever, basically, if a perimenopausal patient comes to you with ovarian cyst, so you have to see what type of cyst it is. If it is a simple cyst, simple matlab no septa, no papilla, there is nothing. This is a simple cyst. If it is small, observe, don't do anything. But if it is a simple cyst which is huge, then you have to remove the cyst. Okay? If it is a complex cyst matlab it's an irregular cyst with lot of internal septations and papilla, then in that complex cyst you have to get the tumor markers. Tumor markers that will indicate you whether the cancer is there or not. Since she is a young woman, perimenopausal means somewhere between 35 to 45. The tumor markers are many. CA125 is for epithelial cell. LDH is for dysgerminoma. Remember, perimenopausal mein chances are it is a germ cell tumor. So LDH, HCG for trophoblastic tumor, alpha fetoprotein for yolk sac tumor. So all these markers will be done in case of a complex cyst irrespective of size. And in case the tumor markers are raised, chances are it is an ovarian cancer. Okay? And when it is, we will go for staging laparotomy. Ovarian cancer may we do staging laparotomy and remove all the suspicious tissue. If it's a postmenopausal patient, in postmenopausal, any cyst, there should be absolutely no cyst in a postmenopausal patient. Any cyst in a postmenopausal patient get two markers only, CA125 only. You don't need LDH, HCG and alpha fetoprotein in postmenopausal, because postmenopausal में germ cell tumor, yolk sac tumor will not happen. So just get CA125. If what you calculate is a risk of malignancy index, RMI. If your RMI score is high, then there are very high chances it is malignancy. Get the CT scan, do the laparotomy. If your score is less, still there is a cyst in this woman. So what do? If it is complex cyst, you remove the ovaries. You don't do staging laparotomy. You don't do extensive surgeries, but you remove the ovaries. What is staging laparotomy? Staging laparotomy is you open the abdomen and you remove all the suspicious lesions. All the suspicious lesions. इसको हम कहते हैं debulking surgery. Remove as much bulk of cancer as you can. Remove everything. You remove ovary, uterus, remove omentum, any suspicious lesion on the liver, remove it. Any suspicious lesion on the bladder, remove it. Drain the ascitic fluid, remove as much cancerous tissue as you can. इसे बोलते हैं debulking surgery, which is done in ovarian cancer. Why we are doing debulking surgery? Because the main treatment is chemotherapy. And if there is so much tumor in the abdomen, chemotherapy can't act. Chemotherapy can act when you can remove maximum of the tumorous tissue. So remove as much visible tumor tissue is there, and for only small microscopic tissue, we will give chemotherapy. Platinum-based chemotherapy, 6 cycles is to be given after the surgery. This is what the treatment for ovarian cancer. Debulking surgery followed by platinum-based chemotherapy. What was the treatment for endometrial cancer? Simple hysterectomy followed by radiation. What was the treatment for cancer cervix? From up till 2A1, hysterectomy. Below 2A1, chemoradium. What is the treatment for ovarian cancer? Debulking surgery. We don't call it oophorectomy. We call it debulking. Remove all the suspicious areas and give chemotherapy. This is called as ovarian cancer treatment. One important thing is sometimes the patient is such an advanced stage. Patient is in such an advanced stage of ovarian cancer, we can't resect it. It seems unresectable. In that case, what we do, we give chemotherapy prior to surgery. Chemotherapy ki 3 cycles are given before surgery. Shrinkage of the tumor happens. Then we do the surgery and remaining 3 cycles of chemo are given afterward. This is done in advanced cancer. इसको हम बोलते हैं neoadjuvant surgery. It is neoadjuvant cancer surgery. But what we normally do in early stages is debulking followed by chemo. इसे हम बोलते हैं adjuvant surgery. Adjuvant chemo. Neoadjuvant मतलब some chemo before surgery, some chemo after surgery. That is neoadjuvant. Okay. Let's see certain tumor markers. CA125 is a tumor marker for ovarian epithelial tumors, especially serous one. CEA is again a tumor marker for epithelial tumors, especially mucinous. HCG is for choriocarcinoma, which is a germ cell tumor. Alpha fetoprotein is again for germ cell tumor, that too yolk sac one. LDH is for dysgerminoma, which is a dysgerminoma is which type of tumor? Dysgerminoma is arising from which cell? It is which type of tumor? Dysgerminoma is which type of ovarian tumor? अरे एपिथीलियल है, जर्म सेल है, स्ट्रोमल सेल है, 3 जगह से तो ट्यूमर आ रहा है. एपिथीलियम से Germ cell से बीच के stroma से, yes, it is a germ cell tumor. It is malignant germ cell tumor. Inhibin is from granulosa cell tumor. So remember these tumor markers. ठीक है? Remember the management and done. Thank you. Too much time. I thought it will be finished in 5 hours, but I think I overestimated. So what I told you, everything was clear today? See, if there is anything which you have read, which is not what I have told you, like updated, somebody told me the gray brown kit that I'll see, anything comes into your mind, till exam our WhatsApp group is active. Okay, thank you so much. Labor care guide. Yes, labor care guide. I think I should make a video on labor care guide and I should post it on the WhatsApp group. Will that be okay? है ना? That's a very active group. You can always put in comments and I will always answer there. So I'll put labor care guide. Anything more you remember, please put it there. ठीक है? चलो. Revise beta. One thing I'll tell you, which I have told you again, be extremely honest to yourself. Just complete whatever you have decided. ठीक है? जो सोचा है उस दिन के लिए finish that. That's it. Be very disciplined. Learn to be disciplined. उठना है सुबह तो उठना है. 6 घंटे 7 घंटे पढ़ना है तो पढ़ना है. Disciplined होने से क्या होता है? Will you get selected? Is it a surety by getting disciplined you will get selected? No, it is not a surety. The one thing is surety, you will not have any regrets. One thing is, even if you don't get selected, you will not have regret. But whenever you will go to your anatomy or biochem department, whenever professors are there or PGs are there, they are not very happy with whatever they have got. So you know why they are not happy in clinical branches, why they are not extremely happy. There is a lot of scope in their branches. All the medical colleges are searching for non-clinical professors. Still, they are not very happy. You know why? Not because of rank, because of guilt, because of regret. So if somebody is not happy with their rank, it is not because of the rank. It is because they have regrets that I could have done better. So just try one thing, try having no regrets. After that, whatever branch you will take, clinical, paraclinical, non-clinical, you will be a very happy person and you will do brilliant in it. Trust me, you will do better than any surgical branch person. Only thing, you should be happy. For being happy, you should have no regrets. Trust me, I have gone through that phase. Okay, I had certain regrets and it took a lot of effort to finish them off. So don't keep any regrets, just be disciplined and let's just see what will happen. है ना? ठीक है? Okay? Bye bye.